Good to start.
Ready. Good morning to one and all. Welcome to day 2 of Synoptic 2021. We'll now be starting off with session 3 of Synoptic, that's Peadiatric Ophthalmology and Strabismus. I humbly request Dr. Rashmi Bhaskar, Senior Consultant of Peadiatric Ophthalmology at Chaithanya, Trivandrum, to moderate this session. Over to you, ma'am.
Good morning and welcome all. The first session today is Peadiatric Ophthalmology and Strabismus, and our esteemed panelists include Dr. Meenakshi Swaminathan, Senior Consultant, Shankar Nethralaya. She was a Director Academics for over 14 years, trained at PGI and US. She is a represent the ICO at the AAOS Teachers in Ophthalmology program. She was awarded the Strabismus keynote by the WSPOS for the 2021 Connect this year. And she is passionate about teaching, education standard, and embracing technology for teaching. And she has launched and run a podcast for eye care professional called Snippets. She's a wonderful teacher, excellent person, and I am honored to be her student. Welcome, ma'am.
Thank you.
Our next panelist is Dr. Elizabeth Joseph, Head of the Department of Ophthalmology. She's the Chief Pediatric Ophthalmology and Strabismus Specialist in Little Flower Hospital, Ankamali. Madam is an eminent personality in state as well as in the national level. She has presented various instruction courses in national and state level and received many awards. At present, she is the executive member of Strabismus and Pediatric Ophthalmological Society of India. Welcome, ma'am. Our next panelist is Dr. Rohit Saxena, Head Strabismus and Neuro-Ophthalmology, Dr. RP Center for Ophthalmic Science, AIMS, New Delhi. His academic achievements include numerous projects, and he has published more than 130 index publications. He has authored 2 books and written many chapters, and he has received more awards. And I think this slide is not enough to fill all the awards that he has received. Welcome, sir. Our next panelist is Dr. Abraham Kudian, sir, our in-house Senior Consultant, Medical Superintendent, Chaithanya Eye Hospital and Research Institute, Thiruvananthapuram. He has numerous publications in his name, that is national and international level. He is a guide, mentor, and father figure for all the consultants as well as postgraduates of Chaithanya Eye Institute, Trivandrum. Welcome, sir.
Thank you, Rashmi.
Now, first we will have the case discussion, and this is our team. Dr. Chaithanya Arvadi and Dr. Sanitha Satyan will be presenting the cases, and Dr. Krishna Babu will be presenting the algorithm. First, we will go with the case discussion. The first case is by Dr. Chaithanya Arvadi, the case of ectopia lentis. Over to you, Dr. Chaithanya. Please share the screen.
Good morning, madam. Good morning, all. I am going to present a case of ectopia lentis. 5-year-old male child presented to our OPD with compliance of defective vision in both eye for last 1 year and also squinting notice in left eye for last 1 month. Mother also noticed the child is playing with toys and also watching TV very closely for last 1 year. Also difficulty for reading and writing since last 1 month, and he is closing his eyes more frequently. There is no significant past history or any history of trauma or any systemic history, but there is an interesting family history from paternal side. His father also his father's siblings and also grandfather, few of them underwent some ocular surgery in very early age. This is an affected child. His cousin also is having some ocular issues, and she is using glasses from very early age. Coming to visual acuity, coming to ocular examination, unaided visual acuity is 6/24 N10 right eye and 6/36 N10 left eye. Ocular examination proper. Left eye, there is exotropy of 15 degree by Hishpictus, no abnormal head postures or no nystagmus. Ocular movements were full in all directions and gazes. Orthoptic evaluation revealed left eye exotropy of 15 degree Hishpictus. Cover test revealed left eye exotropia, and alternate cover test showed alternate exotropia with right eye dominance. Prism bar coverters showed 30 prism diopters exotropia for both distance and near. Worth-for-dot test, left eye suppression and stereopsis is less than 400 arc seconds. Coming to anterior segment examination, all anterior segment structures were normal except for irregular anterior chamber depth, and there is a supratemporal subluxation of clear lens even in undilated pupil and mid-dilated pupil. There is a supratemporal subluxation of clear lens, right eye, and also the same feature in the left eye showing supratemporal subluxation of clear lens. Intraocular pressure was normal. Dilated fundus evaluation was also normal. We did dilated retinoscopy through both phakic and aphakic portion. Phakic portion dilated retinoscopy revealed a significant cylinder up to 5 diopter cylinders. Aphakic portion retinoscopy was normal, reading up to 11 to 12 diopter spheres. Acceptance was not improving with any glasses. Keratometry readings were normal. And to sum up the case, a 5-year-old male child presented with compliance of defective vision for 1 year, more for the last 1 month. Family history of similar illness through 4 generations on paternal side. General and systemic examination were normal and no features of marginoid habits. Bus corrected visual acuity in right eye was 624 N6, left eye 636 N6. Ocular examination revealed bitemporal supratemporal subluxation of clear lens with left eye exotropy. Dilated fundus evaluation was normal. Diagnosis: moderate supratemporal subluxation of clear lens with autosomal dominant inheritance. Left eye exotropia and emmetropic amblyopia was made. We evaluated the child and cardiac evaluation revealed aortic dilatation. Urine homocysteine levels were negative. Genetic testing revealed autosomal dominant inheritance. The rest of the ocular examination evaluation was normal. Now, how to manage this case?
Thank you, Dr. Chaithanya. You can just stop sharing your screen. Now we have a 5-year-old child with bilateral ectopia lenses. I think Dr. Abraham Kurian sir can say what are the baseline ocular and systemic evaluation that should be done when you see a child with ectopia lenses. Sir, can you please unmute?
The first thing we should do would be examination on the slit lamp thoroughly if it's possible. And what we would like to know there is how much of the lens is in the pupillary area. And depending on that will be what we will do and what the vision of the child should be. Now, if it is just a slight subluxation, then most of the lens will be in the pupillary area and we may be just tackling extreme refractive error. Whereas if it is more, then we have to think about managing the lens otherwise. It's easier to manage the aphakic portion of the pupil if it is large enough. Otherwise, we may have a more difficult time and there may even be amblyopia because of the high astigmatism if the child comes to us late. Among other things we can check is the cornea. The cornea in associations can be of different shapes and sizes. So I think pachymetry to find out a thick cornea or a thin cornea and the presence of various curvature problems like keratoconus, keratoglobus, megalocornea, etc. can be ruled out. And gonioscopy, especially to rule out even anterior segment dysgenesis or to find out what the subluxation has done in the anterior chamber. In addition, an anterior segment OCT would be useful because we find that there should be a irregularly shallow AC and we can rule out iris tumors and ciliary body tumors. Along with that, we can do, if the lens is cataractous, we would of course proceed as for cataract. In addition to this eye situation investigations, we should be doing everything that Dr. Chaithanya just said, including a thorough cardiac examination, because most of those syndromes, metabolic, involve the heart, and also the skeletal examination and specific tests like for what we did, nitroprusside and homocystinuria tests, and for again the cardiac tests for Ehlers-Danlos and such like. I think that about sums it up.
So we have in detail heard about the ocular and systemic evaluation to be done. Now I think Meenakshi ma'am can say whether there's any role for glasses in this child, as the child is having a myopic astigmatism of -5. Ma'am, is there any role for glasses and amblyopia treatment?
Thank you. First of all, Chaithanya, nice presentation. And I want to just say that almost all of them you can manage with glasses, because it's quite difficult to put contact lenses or whatever is the ideal treatment in such a young age, except if there is a big anisometropia, in the sense, if one eye is still very phakic and the other eye has become aphakic, and in those situations, then you may have to start thinking of other alternatives. But otherwise, glasses works wonders. Only I noted down a couple of points. The important thing is that you will, even if you find a tiny bit of aphakic portion, even if most of it still looks phakic, for some reason the kid starts accepting only the phakic, prescription. So my, my approach has been that you give the phakic glasses if you find that that's all the refraction you can get and very little aphakia is there. But call the patient back after a month or two to see whether the patient has really accepted the phakic glasses. Very often the parents will say that he's miserable and he's trying to look over the glasses, and then you will say, aha, okay, maybe this aphakia is what is really required. So then take off these. Sometimes you just have to hold the aphakic correction in front of the child. The child will just the expression will change because now the child can see. So very young kids, sometimes we have 3-year-old, 4-year-old siblings who the lens is just starting to subluxate. Those do very well with this little, cheat test that you can do. But answering your question, absolutely, glasses in this kid is the way to go. And did you ask me about amblyopia? I will definitely do amblyopia treatment as well, because I think the left eye vision being less is perhaps strabismic amblyopia component in addition to bilateral, probably refractive amblyopia from the aphakia.
Maybe when we give glasses for the first time, it may not be improving because of the amblyopic part. Still, we have to give the full correction and see.
Yes, I mean, in this kid with that much subluxation, as you showed in the undilated state, which is the way to look at this kid, is undilated state, which is a natural state of the child. Give the aphakic glasses. Don't even bother about the myopic refraction. I think you should give the aphakic glasses.
What are the indications for surgery in case of ectopia lentis? And what are the factors that you keep in mind when you decide that, yes, that child should have a surgery? I think Elizabeth ma'am can throw light into this.
Good morning, everyone. Am I audible? Am I audible?
Yes, yes.
Okay. First of all, I thank the Chaithanya team for having me here. And to answer my question, what are the indications for surgery? First and foremost, if it is a subluxated lens, if the lens edge is crossing the mid pupil, then it is very difficult to correct. If the mid pupil is undilated, mid pupil is blocked by the lens border, then that is one indication for surgery, because then it is very difficult to correct phakic or aphakic refraction. And another indication is to prevent complications or to treat complications like glaucoma in an anterior subluxation. And if there is an irritation on the iris, it can lead to uveitis, and constant uveitis is again another indication for a surgery. And they say that subluxated lenses eyes are tend to grow myopic. If there is a large myopia progressing, then that also is an indication for lens surgery. Thank you.
Thank you, ma'am. Various surgical procedures has been described for ectopial lenses actually. I think Dr. Rohit sir can say in detail about the various surgical procedures and choice of IOL.
Thank you for the opportunity and this very interesting case. I mean, firstly, I would of course share the opinion of the previous panelist. Our first step should be to give refractive correction and follow up. What I noticed was that his near vision was normal. His near vision was N6. So it means that he's looking through his natural lens. So that part should be encouraged because that would help us in managing amblyopia and managing the child as the child develops. So near stimulation would be very good. So in this child, I would definitely encourage refractive correction and follow up and see how the vision develops. And I would probably not think of patching at the first go, and I would probably just give him glasses and follow up. Now we talk about the various procedures. As has been mentioned, you have two options. You have either tried to get the lens to center so that you can use the phakic part of the lens, or else you can remove the lens and give forms of rehabilitation, including scleral fixated lenses, which are now becoming very, very popular. So in congenital or in developmental subluxated lenses, we know that over time this is going to progress. So back fixation procedures may not be such a great idea. Like I said, not in this case, but if there is a significant subluxation and bulk of the vision is through the aphakic portion, I would say you remove the lens. And possibly if a child is older and you think you can manage with contact lenses, maybe for some time. Otherwise, a scleral fixated lens would be one of the best ways to intervene in these children. Of course, you need to be careful because the eye may, as has been mentioned, the eye may grow axially, and that may cause the subluxated lens, the scleral fixated lens to be not so stable in the long term. So you need to follow up these children. But if you can rehabilitate with contact lenses for a bit, that may probably be the better way to intervene at the moment.
Regarding the fixated lens, what is the minimum age in which you prefer a SFIOL?
So at our center, we are doing SFIOLs now in 3 or 4 years of age also. But they are more often traumatic or unilateral effects, secondary effects. But after 5 years, I think it is stable enough for a long-term outcome. But of course, as this thing is still very early, we have possibly 5 or 6 year old follow-ups. But as of now, like I said, in most cases, they are very stable, but you need to follow them up to see for long-term stability of these lenses in congenital subluxated lenses.
I think we will just see how, to Dr. Chaithanya, to see how we have managed this case.
We managed with, we prescribed the glasses with full cylindrical correction and patching right eye for 2 hours. And we reviewed the child after 6 weeks. His bus corrected visual acuity improved to 6/18 N6. So we advised to use same glasses and continue patching 2 hours per day in right eye and advised to review after 2 months.
I think we have tried the aphakic correction also, but the child was not accepting the aphakic correction. The child was better with the aphakic correction, so we gave the glasses in that way. I think all the panelists will agree that the glass will be the ideal choice for this child at this time. Any opinion?
Absolutely. I think excellently managed. I mean, in conditions like this, like I said, because we have surgical out, although we always think of surgical interventions as great, but we know that in children, long-term outcomes may not be that great. And if we can manage a child with glasses over time, like I said, N6 vision was being achieved after refraction. So it was good that it was obvious that he was seeing through the phakic part, and I think excellently managed. And that's what our aim should be, to be conservative in small children and see step-by-step intervention, how we can improve, and then intervene surgically only when there is clear evidence that your intervention will definitely benefit the child in the long run.
I also wanted to add very quickly, I think very well summarized, Rohit, and well managed as well. I just wanted to add very quickly that very, very early in my career, I remember once taking up a child like the suspected subluxated lenses for EUA. And at that time, I had actually not even fully investigated the child. And that's dangerous because if you have not ruled out homocystinuria and you keep the child fasting, then there is a chance of, dehydration and then thromboembolic phenomenon. So the caution is, if you are ever going to do any procedure, make sure you investigate thoroughly before you take up any kid with suspected subluxated lenses for, for any procedure.
One point I would ask the panelists, what about the exotropia 30 prism diopters? Do we have to do anything for that, or just think about only subluxation?
If I can answer, I think we wait for full vision recovery. And once the vision is fully recovered and equal in both eyes, it's even possible that the exotropia may reduce spontaneously. And then giving room for refractive error, there is thick glasses causing some change in the measurement. I think you can take up for surgical correction, but it is only after adequate amblyopia treatment.
So most likely cause of the exotropia would be the subnormal or a relative subnormal vision in the left eye. So possibly a foria breaking into atropia. And as Dr. Meenakshi said, you get the vision up, possibly the child may become, an exophoric over time, and you may not require any surgery. So you know that good quality vision is a prerequisite for fusion. So only when you are able to eliminate the, cause, which is poor vision. Once the vision develops and there is a strabismus despite that, then you consider for surgery. A divergent squint or an intermittent divergent squint does not become such an urgent intervention in this case. So you probably would get the vision up and then think of intervention.
I think we can move on to the next case. I invite Dr. Sanitha Satya, our consultant pediatric ophthalmologist, Palarvattam branch, to present her next case. Case of acute esotropia.
Good morning, everyone. Thank you, Dr. Reshmi. Acute esotropia in a child. So a 13-year-old boy presented with spontaneous double vision and crossed eyes of 1 week duration. He had sudden onset double vision following prolonged reading from mobile phone during exams. There was no history of recent trauma, no history of similar illness in the patient or in the family. On examination, his unaided visual acuity was 6.6 in 6 both eyes. This was his clinical photograph in different positions of gaze. You can see that there is a esotropia, which measured about 35 prism diopters for distance and near in the primary position. In all other positions, all other movements were full, including abduction of the left eye. Cycloplegic retinoscopy was normal, and examinations including anterior segment, pupils, and dilated fundus were within normal limits. So to summarize, a 13-year-old boy presented with a sudden onset of double vision and crossed eyes following prolonged reading on mobile screen. On examination, his unaided visual acuity was 6.6 in 6, 35 prism diopters of esotropia for distance and near. Pupils, anterior segment, dilated fundus, and cycloplegic retinoscopy were normal. So my diagnosis at this stage was acute acquired comitant esotropia. As the name implies, it is acute and acquired, and the magnitude of deviation is the same in different positions of gaze, which makes it a comitant esotropia. So this is my case, and now it's open for discussion.
So when you have a case of acute acquired esotropia, is neuroimaging and neuroevaluation mandatory? I think Meenakshi ma'am can give her opinion in this.
Okay, thank you. This is a very tough situation. To be honest with you, I have had one patient in all these, say, 20 years of practice that has actually turned out to have something in this kind of scenario, but I still investigate. for that rare possibility that you may miss something that is dangerous. And we have just started getting more and more reports of excessive smartphone use associated with acute onset esotropia. And there are some really very different and not described before kind of presentations. We've had patients where the distance angle is more than near, like something like a divergence insufficiency. It seems to be more common in young adults, that kind of presentation. We're definitely seeing more since the lockdown. But answering your question, I am still a bit old-fashioned. I do put them through an orthoptic examination to see whether they have excessive accommodation, try to do an MEM retinoscopy to see whether they are accommodating too much, look for, lead or lag or, one of those. But I still investigate. That's my answer.
I still remember, ma'am, I was your fellow at that time in that patient game. Even though it's very, very rare, we cannot miss such a case. And it is always better to do a neuroimaging when you see such a case. I think Abraham Putin sir can say whether there is any role for glasses or prism, especially when the angles are small in case of acute esotropia.
I definitely think so. As Dr. Meenakshi just said, most of these cases will have some amount of accommodation. Now this, if we go by the Barian and Francis-Chetty classification, this comes under the Francis-Chetty group of cases where the child suddenly develops comitant squint, and in addition to that he has a mild hypermetropia, though in this case the hypermetropia is negligible, and it's supposed to be stress induced, physical or otherwise. And in these cases, if there is the least amount of accommodative element, they are called as mildly accommodative. The full cycloplegic correction may help. And if that doesn't, then you go for the prisms. And prisms in a small angle squint should not be a problem because the child may not have very much difficulty in adjusting. But if it is a larger squint, then unless we have availability of Fresnel prisms, and Fresnel prisms do compromise the vision a bit, so you may find it a little difficult to sell it to the child. Then another thing is they also say that not talking about this case, in Blaskowitz type of cases where myopia is the presenting thing, in an overcorrected myopia also, you may have AACE, in which case you may have to give him the correct glass and reduce the overcorrection, because the overcorrection may be responsible for precipitating this. And in addition, the role of the prism comes when you are planning surgery. If you are planning surgery, it's better always to do a prism adaptivity test if you have the time, and see that you expose the maximum angle of strabismus. And in addition to that, they say that you have to overcorrect in the sense that you add 0.5 to 1 millimeter to all your other measurements to get orthophoria, because later all these children tend to get a recurrence if we do it in the conventional way. Thank you.
Recently, many publications are there regarding the efficiency of botulinum toxin in case of acute esotropias. So, Rohit sir, what is your experience in this?
So I'm sorry, I'm a poor person to answer this, because we are a strong believer that surgical interventions are, reduce the frequency of interventions as well as give a more reliable, more predictable outcome. So I would say that even for infantile esotropias, while there is, there are publications about Botox, I would still say that we've always felt surgical outcomes are much better, much faster alignment is possible, because anyway in botulinum toxin, you need to actually create an exotropia, although desirable in most cases, but a little unpredictable. So I would personally say there is very little experience in, long-term outcomes with botulinum toxin in acute comitant esotropias. So if we plan intervention, I would always definitely prefer surgical interventions because it is predictable and you can be more consistent and aim for whatever, as Dr. Kurian talked about, slight overcorrection. So I know how much to do and how much to expect in the long term. So I would definitely err on the side of surgery rather than botulinum toxin.
Rohit, if I may add, Dr. Rashmi, if I may just add one point. See, a lot of these publications that come from outside the country are from centers where any procedure is covered by insurance. That is not the case with our country. We are still fighting for insurance to cover anything strabismological. And our patients have only so much money. You cannot experiment Botox and then you see whether it's working, not working, and then you go. We can't do all these things. And like Dr. Rohit said, you want something definitive. You want something assured, you know, that it will work in our patients because they don't have a lot of cash to spare. So that may be one of the major drivers for why you get so many Botox papers from outside, whereas we go with something that we know will provide fairly accurate results.
Elizabeth ma'am, how long will you wait before you plan for a surgical correction? So will you immediately go for a surgery or wait for some time to see? Or
To answer that question, the chance of spontaneous resolution of acute comitant esotropia is not that common, although one or two anecdotal incidences are there. So most likely these conditions are going to persist. Acute comitant esotropia will not go by itself most of the time. So you have to do some procedure. Again, this child is suffering from diplopia. So that is very troublesome. And then after surgery, the potential for stereopsis is so good. So taking into consideration of all these factors, I think there is no need to wait for long. You wait for 2 or 3 months to get your neuroimaging and to make sure that the angle is stable and constant, and then you take it up for surgery. My preferred technique is surgery. From India also, from Aravind and all, there are reports of Botox. In our center also, we gave Botox as an to start with, because so many papers are coming with the injection of Botox. But in our condition, in our setup, we found that recurrence is more with Botox. Surgery means it's assured. So we don't wait much. After 2 or 3 months, we take up for surgery.
You prefer a bimedial decision, madam, or a one-eye surgery?
I usually do bimedial. That is my preferred. If the angle is up to 30 or 40 prisms or up to 50 prism, you can do bimedial. If it is much more than that, you can do a 3 muscle. That's my opinion.
I think recently we have been seeing a lot of cases after smartphone use, excessive smartphone use and esotropias. For the last 2-3 years, I think we are seeing so many number of cases. That is the main reason why I took this case for discussion. Can you share your experience, ma'am, in this?
Yeah, our experience also is similar. After the lockdown, the number of acute comitant esotropias has tripled, or it has become 4 or 5 times more than what it used to be. And one reason may be because of increased near work. There may be convergence tonus is increased, medial rectus is overacting, and that results in a convergence twinge. When you compare convergence tonus and divergence tonus, convergence tonus is more. That may be one reason. The other reason is decompensation of a small foria. So smartphone use definitely has increased the number of acute comitant esotropias.
So it's your experience in this?
Absolutely. I mean, earlier probably we were seeing one before the COVID. We were seeing about 1 case in 3 months or so. Then, of course, we understand the dilemma. Then there was no problem. You know that 1 in 3 months you investigate, do an imaging. Now we are seeing almost 2 or 3 every 1 or 2 months. So you know that the frequency has increased. It possibly is a breaking of the esophoria, which we know all children tend to have, and the fusional divergence gets overwhelmed because they're working for almost 6 to 8 hours. And I would say that the interventional algorithm should not change unless we have clear evidence to the contrary. So a cycloplegic refraction, we prefer atropine ointment at our center, followed by an imaging. So you first eliminate accommodative esotropias that may still present later in life. Then, of course, as you mentioned, an imaging, which again, an MRI to concentrate on the brainstem, because that's the place where the lesion should be. And if all that is okay, you just follow up for a while, 2 or 3 months, as Dr. Elizabeth said, to make sure that the angle is stable and there is no significant change. And younger the child, the earlier the intervention. So, and of course, manage diplopia by either prisms or patching, 1:1 patching in the intervening period. So huge increase, unfortunate, and we hope that we are looking at the end of COVID as children go back to school.
What about adults? I mean, a 22-year-old, 23-year-old coming with the same sort of complaint. I had one girl yesterday. When she passed her matriculation, she had a photo taken, perfectly straight eyes. She never had squint. And now she's come with a acute concomitant squint. Do we still have to follow the same?
I would say that you would still follow. I mean, maybe not atropine. You may use cyclopentolate in an older patient because you don't have that many worry of that many CNS issues. So maybe a full cycloplegic under cyclopentolate, you could do a refraction. And again, older the child, older the patient, more likely that you need to worry about a lesion. So an imaging becomes even more important in a young adult. And yes, interventions, then again, surgical interventions, because they become very, very aggrieved. So yes, we've also seen older patients coming with acute concomitant esotropia, which, initially we were also waiting for a bit longer, but as the number of cases has increased, our intervention time has markedly decreased. So 2 to 3 months would be our average intervention time.
Dr. Sanita can just show how we manage this case.
So we did the investigations. MRI brain was normal, and the patient was actually suggested alternate occlusion, but he was not very keen. He's a young boy and he has a lot of outdoor activities also. And the PRISM trial also, patient was not able to comply, but he always complained of troublesome diplopia. So actually I did a bilateral medial rectus recession of 3.5 millimeters under LA after 1 month. This was based on patient's request also, and based on my previous experiences also, as Elizabeth Madam has already mentioned. So this was his post-op picture. You can see that this is post-op 1 week. The eyes are aligned and there was orthotropia for distance and near. And you can see the resolving subconjunctival hemorrhage on the medial sides. And there was no limitation of any movement. So even at 6-month follow-up, patient had retained orthotropia for distance and near, and he had a stereopsis of 60 seconds of arc, which is very usual with this kinds of squints. So to discuss a bit, acute acquired comitant esotropia is one of the rare forms of strabismus, and Burien and Miller classification divides it into SWAN type 1, which is due to interrupted fusion by monocular occlusion or vision loss. Burien-Francisci type 2, which is due to physical or psychological stress, usually presents with large deviations, small refractive errors, and minimal accommodation. Bielchowski type 3 is associated with moderate myopia or might result from excessive near work activities. And there are other types also being mentioned, like a refractive accommodative type, those related to intracranial pathology and accommodative spasm. And nowadays we are seeing more of smartphone use associated AACE. So this case was presented here to show the characteristic presentation of AACE and its successful management. And the inciting factors like excessive near work and smartphone use are on the rise because of these pandemic times. And thank you, panelists, for your wonderful discussion. In fact, I have become more confident about the management after that. Thank you.
Dr. Sanita, I think almost thank you, panelists. Please stay. We will be having the consensus algorithm after the keynote presentation. Now over to Dr. Meenakshi ma'am for the much awaited keynote presentation, Ethical Dilemmas in Pediatric Ophthalmology. Madam, you can just share the screen.
I wanted to, while I'm getting ready, I wanted to, congratulate Sanita on a very nice slides, very nice and clear slides and nice presentation. I'm just curious why you chose to do it under LA. How old was the patient?
Patient was 13 years. He was, they had some financial issues also, madam. And I actually did it under LA plus edition. So he was okay with that.
I was going to say you're way more bold than I am. I don't.
Not exactly, ma'am. It happens.
And really, but well done. Well done. Good outcome.
Thank you, ma'am.
Okay. So I was motivated to give this talk because, this is a very forgotten topic, that is ethics. It seems to be increasingly forgotten these days. But I first wanted to thank Chaithanya's team, my fellow. I have visited Chaithanya many, many years ago. I have been experienced the hospitality of the doctor, the founder's family. Unni was our fellow. So we have very close associations for many, many years. And so I'm just very happy to be here and happy to give this talk. Now, even though this is ethical dilemmas in pediatric ophthalmology, a lot of my cases that I'm going to present are just, really fictitious, which I have made up to illustrate a point. Now, basically, we're going to look at ethical principles that guide our practice. And a lot of this is taken from the Code of Ethics published by the American Academy of Ophthalmology. So just to drive home these points, and some of these are adult patients as well, examples, and some are pediatric patients. I have chosen a case for every point to illustrate a point. Okay, so ethics address conduct and relate to what behavior is appropriate or inappropriate as reasonably determined by the entity setting the ethical standards. So an issue of ethics in ophthalmology is resolved by the determination that the best interests of the patients are served. If you ever have a question, ask yourself, when I do this treatment, when I do this investigation, am I serving the best interest of the patient? And if the answer is yes, and then you're very much within the limit of ethics. So ophthalmological services must be provided with compassion, respect for human dignity, honesty, and integrity. And it is the responsibility of the ophthalmologist to act in the best interest of the patient. So first case example, this is, let's call this, Dr. King of Phaco. He's a top phaco surgeon in the region. He has just bought a BMW and built a 5-bedroom villa. He does 10-minute adult phacos, and the family, the next patient that walks into his clinic brings a 6-month-old child with a unilateral cataract. What does he do? He aspirates the lens and places an IOL. 3 months later, the child comes back and now has visual axis opacification. No surprise here. So we're looking at the first ethical principle of competence. Competence, which means you work within specific training and experience. Not only that, you have to maintain competence by regular experience, continuing education like you're doing right now, and also learn and implement new skills appropriately, maybe first under guidance, under supervision, and then only on your own. Clearly, this patient was mistreated. He was a phacosurgeon, so he did an excellent aspiration and a lens placement, but the child really needed management of the posterior capsule and the anterior vitreous, which did not happen. So that is the first case. And the second case, this is a pediatric ophthalmologist. Well, the practice is slow. A 15-year-old child has come for regular visit. He recently moved to your town, and a history of PCIOL for congenital cataract 1 year back, and a mild PCO is seen by this doctor. And the pediatric ophthalmologist now wants to do YAG. The parent signs the consent, and the YAG is done. 3 weeks later, he comes back with some glare, and bits of the PCIOL from laser can be seen. Now he says, the doctor says, you know what, you moved during my laser, and so the lens is damaged. So really, what went wrong here? And what went wrong here is something called informed consent. Let's not even talk about whether really this patient needed that YAG capsulotomy, because the PCO was mild. And so that is a big question here. But more importantly, the process of informed consent, where a reasonable patient, a patient that understands, and in this case, he's a minor, so everything should have been clearly explained to the parent and has made an informed decision. Rationale, benefits of proposed treatment, risks and complications, alternatives, everything should be explained in great detail to the patient or the parent, and then only the procedure performed, even if it seems like a straightforward YAG capsulotomy. Just getting a signature is not informed consent. Let me see if this opens. I don't think it's going to open well, but I wanted to show you an example of really good informed consent. I'm sure all your institutes have excellent ones. So that ideally the consent needs to be read out to the patient, or the patient or the parent left with the consent in a quiet place, ask them to go through the whole thing in the language that they understand, if not translated. And then you ask them if they need any clarifications, if they have any doubts, and then only they sign, and then only the procedure is done. That's the way to do informed consent. The third case here, let's call him Research Raja. He suddenly, in the middle of a practice, developed interest in research. So here is a company called Cornell, is a pharmaceutical who's launching a new drug to reverse astigmatism. And this drug is called Astepin. So the trial is placebo versus Astepin. And so Dr. Research Raja explains the research to the next patient, and the patient refuses. Now he gets an idea. He said, only when I tell the patient the placebo versus Astepin, patient says, no, I'm just going to quietly hand over the medications without saying what it is. Now, what are your thoughts? Clearly, it is wrong. Why is it wrong? Because there are some ethics of research and innovation. First of all, anything that you're going to do, even in your private practice, needs an institutional review board oversight. And that needs a special informed consent. Your informed consent for treatment of the patient, which you take when the patient first comes into your practice, does not apply automatically to the research. Clinical investigations versus routine care. For example, just ordering Pentacam for all astigmatism because your thesis student is doing something on astigmatism is just not on. So that is not maybe part of routine care at all. And so this is not acceptable. And a research without patient's consent is clearly unethical. Okay, we move on to the next scenario, which is Dr. Anoy Malai, because he gets annoyed. He's a junior consultant, and the patient has already received Botox once for lateral rexus palsy. And Dr. Anoy now offers a new powerful drug for rupees 75,000. It's a new thing that treats the palsies fantastically. Patient looks shocked and requests if he can get an opinion from a senior doctor. Now Dr. Anoy is annoyed and gets angry with the patient. He says, you don't trust me? You can go wherever you want. We do see this sometimes. So this comes to the ethical principles of other opinions. Respect the patient's request for other opinions, obtain consultations as appropriate. Okay, we go on to another, Phaco Raja. He's 40 years in practice, well trained in Phaco. His children are doing, however, diamond business in obs-gynae. And now he has developed a tremor, maybe early Parkinson's. So the Phaco Raja engages a shadow Phaco surgeon. He talks the whole time while shadow does surgery. Everybody is happy. So we go on to the ethical principle of an impaired ophthalmologist. Impairment can be physical, mental, emotional. Ideal is voluntary withdrawal. And it is a duty from the ophthalmologist to act when patient safety is the first priority and rank does not have privilege. Okay, we move on to the next scenario, which is the Botoxic surgeon. A 68-year-old lady with sudden onset of double vision and diagnosed 6-nerve palsy of the right eye, chooses observation, which is the right thing to do because patient is an hypertensive. But meanwhile, he attends a seminar on the use of Botox in nerve palsy, and now he wants to try it on the next patient. And now he records there is non-resolution and does not record any measurements. Clearly, this is wrong because a pre-treatment assessment is very important by documenting accurately, because stretching is unethical and you should document without bias. Falsification or fabrication is unethical, is a serious legal risk, and so don't do it. Now, this is something some of us can relate to when you are in a training center. A 14-year-old student, decreased vision in the right eye, referred to pediatric ophthalmology. The senior resident is examining. Patient sees the young doctor looking into his eye. Now an OCT is ordered correctly, appropriately, because the
training senior resident sees something in the macula, but the patient is now questioning, where is the senior doctor? Why are you ordering the tests? So delegation of services is the next ethical dilemma. Delegation of services, not responsibility, it has to be underscored here, because you're a senior doctor supervising, you can delegate the service, but the ultimate responsibility is still yours. And so you have to make sure that even your resident who is examining has adequate qualification and has adequate supervision. And important, if you're going to involve them greatly in the care, that you have to explain their role to the patient. Okay, missing Dr. Singh. It's a 25-year-old patient. Post-op day 1 after complicated squint surgery, patient is waiting for 2 hours in the clinic. Assistant calls Dr. Singh, who is not picking up. Finally, she says, you know, I had a sudden program. I had to come to Native for a function. You better ask Dr. Know All to see. Okay, bye. Clearly, post-operative care issues are very important when you think of ethics. The operating surgeon is responsible for all post-operative care. Alternative arrangements have to be made before surgery after mutual consent of the providers. And the arrangements need to be disclosed before surgery to the patient. Okay, how am I doing for time? Tell me to stop if I'm going over time. So the next one is Dinero Netralia. This is Dr. Manav, and he has put behind his name MBBS, UMS, LOL, ROFL, GTT, phaco, glaucoma, laser, after cataract, etc. And he's got listed even the charges for every aspect of the examination, right from refraction down to fundus photo. And this clearly is misrepresentation of the services. You do see this in some private clinics. It's important to truthfully describe the services. Misrepresentation by omission, distortion, or using or avoiding specific languages, and inappropriate charges for services is all unethical. So here is another scenario. A 5-year-old patient brought by parents for esotropia for the last 15 days. Vision is 6/9 in both eyes. And this is Dr. GP, because he's a general practitioner, does autorefractor, prescribes +3, and patient leaves with these +3 glasses. Clearly wrong. Cycloplegic refraction has not been done. Another scenario, 25-year-old walks in with viral conjunctivitis, and now he gives a subconjunctival triamcinolone for super quick recovery, because in his experience, it works wonders. Under and over treatment are clearly unethical. Extent of the care must serve the patient's interests. Over providing care is unethical, and also under providing care is unethical, as you just saw in these examples. Now, we go on to where, so for example, this is Phaco Raja again is on an advisory board of a certain, company. The patient is interested in a different brand of a lens or a choice of multifocal. And then you have conflict of interest. Commercial concerns and conflict of interest are something that you should declare, and it must not alter the judgment, and it should be disclosed even to the patient. As you, are we going good for time, or should I?
2 more minutes, ma'am. I think you can continue.
Okay, so I think this person was actually arrested because where he says, corona flu preventive medicine available. So this was clearly wrong. Advertising, rules of advertising is no false, deceptive or misleading information, no deceptive omissions, no appeals to patients' anxiety, must not create unjustified expectation of results. You must disclose risks and must not misrepresent credentials, etc. So this is the last example, I think, where the two trainees are discussing a patient that they just saw on the lift, and the patient's boss is standing in the lift, and then he fires the patient the next day. Patient confidentiality is again a very important ethical principle, and it must safeguard it at all costs. I've not covered certain other principles because they don't directly apply here. And finally, do what is best for the patient in the interest of the patient. Beneficence, obligation to maximize benefit, obligation to minimize harm, non-maleficence, doctrine of primum non nocere, no deliberate harm. Justice, equals should be treated equally, and autonomy, so there has to be some self-governance. I refer you to these wonderful examples if you want to read more. AAO ethics, consent forms in ophthalmic practice, published by our own AIOS, and also an excellent CME series, Legal Aspects in Ophthalmology, all available PDF free on the internet. I thank you so much, Dr. Reshmi. You've made me so proud. You were my fellow so long ago, and you're carrying the torch. And I thank Team Chaithanya, a wonderful panelists. Such a vigorous, beautiful session and discussion on this lovely Sunday morning. And I thank audience for the kind attention. And thank you so much for this opportunity.
Thank you, ma'am, for the wonderful talk. I don't think this relevant topic can be said in a more interesting and humorous way. It's always a pleasure hearing from you. And I think we can now go to the consensus algorithm presented by Dr. Krishna Babu. He's a senior consultant in pediatric ophthalmology, Chaithanya branch, Toronto.
Good morning. Thank you, ma'am. Good morning, everyone. So, could you please share my slides, ma'am?
Yeah, it's visible, doctor.
Other one, first case, first slide. Yes, thank you. First one. Yes, thank you. So, to conclude both our cases, first about ectopial lenses. When a child is coming to your clinic with ectopial lenses, first of all, you see whether it is bilateral or unilateral. If it is unilateral, you have to think in line of trauma or child abuse, etc. If it is bilateral, you have to think in line of the syndromes. So, like Marfan's homocystinuria, wheel or wheel Marchesani. If the patient has tall stature, arachnodactyly, and if the zonules are elongated with supratemporal subluxation, it must be Marfan. Or if the zonules are short and broken along with infronasal subluxation with the mental retardation and all those findings, you have to think in line of homocystinuria. If the patient has short stubby fingers, short stature with microspherophakia, then it must be wheel Marchesani. Or if there is no systemic findings and there is a persistent pupillary membrane, it might be ectopial lentis et pupillae. So this is about the etiology of ectopial lentis. Next slide, please. So coming to the management depends on, as already discussed, it depends on the position of lens. If the clear lens is anterior to the pupil and it is causing an acute glaucoma, if the patient is presenting with acute glaucoma, you have to do a lensectomy. Or if there is no glaucoma and the lens is anterior to the pupil, then you can attempt repositioning by dilating the pupil, but most of the times it will fail and you will need a lensectomy. If the clear lens is behind the pupil, the management depends on whether there is a slight dislocation or the edge is crossing the visual axis or there is complete dislocation, more than 50%. If the dislocation is only slight and if the dislocation is less than 50%, then you have to correct the associated myopia, astigmatism, do frequent refraction, and do amblyopia therapy. And you have to prescribe glasses. So if as Elizabeth ma'am already told, if the edge is crossing the visual axis in the undilated stage and there is fluctuating refraction and there is amblyopia, then you have to do a lensectomy. Or if there is complete dislocation with aphakic area at the visual axis in the undilated stage, then also you have to plan lensectomy. Lensectomy you can plan either by limbal approach or part span approach with the help of a VR surgeon. Following lensectomy, depending on the age of the child, you can plan an IOL. If it is an older child, you can plan an IOL and with or without ionering, and mostly nowadays people are preferring SFIOL. If it is an young child, then you can leave the patient aphakic and correct it with posterior spectacles or contact lens, and you can plan a secondary IOL or SFIOL later on. Next slide, please. So coming to our next case of acute acquired committant esotropia, first of all, you have to rule out a paralytic squint. When the patient presents with committant esotropia, always do a cycloplegic refraction and rule out accommodating component. If there is hypermetropia, you give glasses. Otherwise, you have to do a neuroimaging, whether or not a neurological signs are present. Then following MRI brain, if there is any neurological problem, you have to refer to the neurologist Otherwise, if the MRI comes as normal, it must be either of Swan type or Franceschetti type or Bilchowski type, or nowadays due to smartphone use, other type. Then Bilchowski type is due to uncorrected myopia. Then you have to prescribe glasses or prisms. If it is Franceschetti type, mostly usually presents with a large angle esotropia with diplopia. Your conservative non-surgical treatment won't work most of the time, and you will have to do surgery, either bimedial resection or unilateral RBR, depending upon surgeon's preference. Thank you.
Thank you, Dr. Krishna Babu. And I think Meenakshi ma'am can just give a concluding statement regarding these two cases.
As we say, well, first of all, very nice algorithms. And it's a wonderful way to learn, is to capture everything in an algorithm. Very, very useful in the clinic because we all, I guess, think in algorithmic way. But as they say, proof of the pudding is in the eating. So both cases were excellently managed with great outcomes. And so I think that's the way to go. I tend to be a little bit more conservative in ectopia lentis. If the patient is fully aphakic, we don't go chasing behind the lens. We let the patient get corrected refractively. Because even though these lens, it looks scary to see one lens lying in the vitreous, but actually these eyes tolerate this extremely well. And very, very rarely you really need to go chasing after the lens. You have to be careful because these patients are all also highly myopic, especially the Marfan ones, and there is definitely a higher risk of retinal detachment. So intraocular surgery only if you really have to, especially in Marfans. Otherwise, I think wonderfully managed. Congratulations.
Thank you, ma'am. And from the bottom of my heart, I thank Dr. Meenakshi, Dr. Elizabeth ma'am, Dr. Rohit sir, and Dr. Abraham Kurian for the wonderful session and for all the inputs, giving a valuable time and for the wonderful suggestions that you have given. Thank you.
Thank you for the opportunity, and it was a wonderful session.
I think now over to the inaugural session. It's almost time.
Thank you, Dr. Rashmi, and all the faculties for that wonderful session. It was very informative to us, especially as postgraduates. We'll now be moving on to the inauguration ceremony of Synoptic 2021. First, I would like to invite Professor Dr. B. Sahasranamam sir, organizing chairman of Synoptic, to deliver the welcome address.
Respected Dr. Sushila Bidar Madam, Dr. Babu Krishna Kumar, President of KSOS, Dr. Abraham Kurian, Dr. Unikishan Nair, Dr. Mino Matan, Dr. Manoj, Dr. Anil, distinguished invited guest faculty, respected senior ophthalmologists, dear friends and delegates, and our dear PG students. Good morning to all of you and a warm welcome to this edition of Chaithanya's CME. On stage, all are in-house faculty except our dear Sushila B. Nair Madam. A warm welcome to you, Madam. And also we have Dr. Babu Krishna Kumar, our KSOS President, who is joining us from Thrissur virtually. Welcome to you, sir, also. So the Chaithanya academics have been doing CMAs for the last 20 years with very distinguished faculty, chosen topics, and an overwhelming participation. When choosing the theme and topics of this CME, we have kept in mind the interests of all sections of ophthalmologists, including the residents. This year, the Sushruta Oration Award is being awarded to Professor J.S. Titya, Head of Office Center, AAMS Delhi. It gives me immense pleasure to to welcome Professor Titial sir to this function. The Sushruta oration will be delivered immediately after this brief inaugural function. The oration awardee, Professor Titial, will be formally introduced by Dr. Unnikishan Nair after the inaugural address. And we have keynote address in the CME by masters in their respective fields, and we have renowned faculty and panelists for the case discussions. A warm welcome to our international keynote speakers, Dr. J. Chablani from the University of Pittsburgh, Eye Center, USA, Professor Dr. Ting Yang, and Dr. Ronald Yu from Singapore. Our national faculty keynote speakers include big names in our field: Professor Dr. Namrata Sharma from RP Center, Dr. Rohit Shetty from Narayan Nethralaya, Dr. Sudarshanas and Dr. Meenakshi Swaminathan from Shankar Nethralaya, Chennai, Dr. Partha Vishwas from BBI Foundation, Kolkata, and Dr. Chitra Ramamurthy from Eye Foundation, Coimbatore. A warm welcome to you all. Our panelists include renowned faculty, Dr. Sudarshan Kumar Kokar from RP Center, Dr. Abhishek Kothari, Dr. Dadayas Shroff, Dr. Rohit Saxena, Dr. Elizabeth Joseph, Dr. Sirisha Sinthil, Dr. Ramesh Rajan, Dr. Sai Kumar, Dr. Anil Radhakrishnan, Dr. Prakash, Dr. Nadasha, Dr. Kiran Gopalakrishnan, and Dr. Rushan Shroff. A warm welcome to all the renowned panelists. The Chaithanya faculty across all subspecialties have provided abundant clinical material for the CME and are presenting the challenging clinical scenarios and moderating the sessions. Due to paucity of time, I am not naming them here, but acknowledge their invaluable contributions, and a hearty welcome to all of them. And welcome to all the delegates who are online with us for this prestigious function. On behalf of Team Chaithanya, once more, a warm welcome to one and all. Thank you.
Thank you, sir. Next, I would like to invite Dr. Sushila B. Nair, ma'am, TOC Vice President, to give the presidential address.
Respected President of Kerala Society of Ophthalmic Surgeons, Dr. Babu Krishnakumar, Dr. Sastranam, retired Director RIO and presently Senior Consultant at Chaithanya Eye Institute, Dr. Unnikishan Nair, Medical Director Chaithanya, Dr. Abraham Kurian, Medical Superintendent and Senior Consultant Chaithanya, Dr. Anil, Dr. Manoj, Dr. Minu, and all esteemed invited faculty for the program, colleagues and my dear friends. A very good morning to all of you. This is a very happy occasion for me, and I am very pleased and privileged to be here today morning while Chaithanya Eye Institute is hosting this two-day academic program, delightfully named Synoptic 2021. Chaithanya is now a premier eye institute in this part of the country. The institution was established in 1995 and represents the vision and diligence of its founder, Dr. K.G.R. Nair, who was an excellent eye surgeon, a great teacher, and a source of inspiration to many. And above all, he was a fine, adorable human being. We all have fond and respectful memories of Dr. K.G.R. sir. The hospital started by him has grown into a large institution with many sub-centers and well-developed departments in all branches of ophthalmology. It is also an active postgraduate teaching institute. The surgeons trained here are now doing excellent work in many other hospitals in the state as well as in the country. Now to Babu Krishnakumar. Dr. Babu Krishnakumar, President of Kerala Society of Ophthalmic Surgeons, will be inaugurating this meeting today. The Kerala Society of Ophthalmic Surgeons has had its beginning in 1974 and has now over 1,500 life members. In spite of the pandemic, the society has been arranging and helping the conduct of webinars, continuing medical education programs, and in patient awareness programs. We were also actively involved in hospitals during the eye donation fortnight and the Glaucoma week. We are deeply indebted to our president who helped us in keeping our spirits high and hopes high during the pandemic by organizing several entertainment programs and literary activities which helped to unveil the hidden dormant talents of ophthalmologists in Kerala. Our heartfelt thanks to you, Dr. Babu Krishnakumar. I am here to represent the Trivandrum Ophthalmic Club. The TOC had its modest beginning with the premises of the Regional Institute of Ophthalmology, then called the Government Ophthalmic Hospital Trivandrum, about 30 years back. Its dimensions and activities progressed in the subsequent years. We have been holding regular monthly meetings which provided a great forum for presenting and discussing scientific data. It has also given us opportunity to know and understand one another in a better way. We have learned to live and work as a cohesive community under TOC. This program, Synoptic, promises to be an excellent and a comprehensive one. I am looking forward to this academic feast arranged by the Chaithanya Eye Institute. There is great opportunity to listen and learn to renowned national and international faculty. I congratulate Dr. Sahasranamam, Dr. Unnikrishnan, Dr. Minumathan, Dr. Manoj, and the whole team for conceiving and organizing such a novel program. I wish all of us will benefit greatly from the discussions and deliberations. Thank you all.
Thank you, ma'am. I now invite Dr. Babu Krishnakumar sir, KSOS President, to deliver the inaugural address.
Dr. J.S. Titial, Dr. Sahasranamam, Dr. Sushila B. Nair, Dr. Unnikrishnan Nair, Dr. Manoj, Dr. Minu Mathan, Dr. Abraham Kurian, faculties and delegates. Synoptic, a brave new idea has been formatted by Chaithanya Group. They are approaching challenging clinical scenarios in an algorithmic way that all of you are going to experience and appreciate. I am happy to be associated with this novel concept in CME. What else we can expect from Chaithanya Group, founded by visionary ophthalmologist Dr. KGR Nair and subsequently nurtured by his ardent followers. We are proud to have Dr. Jeevan Singh Titial, head of RP Center, for the Sushruta oration. Welcome, sir, to this august audience. There are reputed faculties from national and international fields to bless this CME Synoptic. In this CME, we have 9 keynote addresses and 13 case presentations to arrive at algorithms in 5 subspecialties. Remarkable Chaithanya and its organizers. KSOS has ventured to a new program that has started with Eye Donation Fortnight and extended to World Sight Day on 14th October 2021 to get 1 lakh eyes to be pledged. We have the website bepledgecampaign.com to have your eyes donated and download the certificate of donation. KSOS request all its members and dignitaries to spread the message and get maximum number of eye donations during the period. Thank you, Madam Dr. Sushila Nair, for your support from Trivandrum Ophthalmic Club. Once again, my sincere thanks to Chaithanya Group and organizers for the CME Synoptic for inviting me. It's my proud duty and I am inaugurating this CME Synoptic. Thank you.
Thank you, sir. Next, we have our traditional and auspicious lamp lighting ceremony. I invite Dr. Sushila B. Nair, Dr. V. Sahasranamam, Dr. Unnikrishnan Nair, Dr. Manoj S., Dr. Anil Krishnan Nair, Dr. Minu Mathan, and Dr. Abraham Kurian, sir, for this. Thank you all. We are now moving on to the much awaited Sushruta Oration Award. I humbly request Dr. Unikrishnan Nair, our Medical Director, to introduce the Oration Awardee.
Respected Dr. Babu Krishnamasa, the President of KSOS, respected Professor Sushila B. Nair, the Vice President of the Trivandrum Ophthalmic Club, the respected Dr. J.S. Chittial sir, who has joined us online as the head of RP Center and this year's Sushruta Oration Awardee, Dr. Abraham Kurian, the Medical Superintendent of the Chaithanya Group, Dr. V. Sasram sir, the Academic Director of the group, Dr. Minu Matan, the Organizing Chairman, Secretary, Dr. Anil and Dr. Manoj, the Scientific Committee faculty, and respected invited faculty, delegates, and our own team Chaithanya. Could I have the PowerPoint presentation? Yes. So it is my proud duty and honor today to introduce the awardee for the Sushruta Oration of 2021. So what we'll be looking at today is that we're finding out who the honorable awardee is for this year. Professor Jeevan Singh Titial is a professor, Chief of Cornea, Cataract, Refractive Surgery. He is the head of the RP Center and the chairman of the National Eye Bank. He is a thoroughbred Aimsonian, which by this you will realize that other than being not born in Ames, he has completed virtually his distinguished, extremely distinguished career, now rising to the helm of the institution. You can see this, that when you say, they say that each wall and each pillar has of Ames, echoes of Dr. Titial, and these pictures are very characteristically show how involved he is in one peeping through the other stalwarts in Ames. He is an astute clinician and researcher with more than 400 publications. He has invited faculty to innumerable national conferences, delivered over 1,000 lectures with 30 orations and keynotes, and a huge, enviable amount of best paper, best poster and video awards at these forums, and bears 2 patents in his name. And this is what he does best. He teaches us to look up and forward, next please, and shares everything with a smile to all his colleagues. The man, in the least possible way we can see, is a humble overachiever. That's what we can see. He has just received just the Padma Shri. That is one of the highest honors in the country. He has got achievement awards from the American Academy, the Asia Pacific Academy, and has been a large splattering of awards from the All India Society and the Delhi Ophthalmic Society. This is a characteristic picture of Dr. Titial. He's a dedicated teacher, and you see he is always surrounded by his students. All these pictures show that he's a center of attraction in academic and all teaching forums. Next, please. And very popular amongst all his Aimsonian colleagues. Next, please. Next, please. So, one thing extremely great about the man, Dr. Titial, is that he knows how to be great and also be one amongst us. Knows how to be a standard to look up to while looking cool and casual while doing it. And this is what I mean by that, an extremely cool, casual and composed personality in the theater or at play. Next, please. So the real question is, with all humility and humbleness and with no sensitivity, I'd like to ask this question. Next, please. Who is a man standing next to Dr. Titial? In all ophthalmology circles, this is what we think of Dr. Titial. He is a towering figure, an instant recognizable personality. Next, please. And I am proud to present to you the 2021 Sushruta Oration Awardee, Professor Dr. Jeevan Singh Titial. Thank you. Dr. Titial was kind enough to send his acceptance video. We'll play that now, and then we'll hear a few words from Dr. Titial. I think there was some problem with the audio, but we have Dr. Titia live with us, and so we request you for a few words.
Yeah, thank you. Good morning to all my friends. Indeed, it's a great honor and pleasure for me to receive this very prestigious honor, Sushruta Award, Oration Award, especially from a Chaithanya group of people who have worked so well for the entire state and country. And being a great friend of Mr. KGR, who's been, in fact, one of the, you can say, an important person in my life. He was been a teacher for me also. Learned so many things from him. I've been to his institution, his OR, long time back, and it was one of the best places I had done surgery also, live surgery. And he was a great person, not only as a human being. I know we all know he was a great personality, but he always thought about extending his knowledge, his thinking, the well-being for a human being, which we always thought about, and extending that to an entire state. A wonderful person. And I am very thankful to the entire organizing committee, headed by Dr. Sahasran Ma'am, and the KSOS and TNO, TOC getting this award for me. I know that before me, many big people have already delivered this oration, and including my name into that list is a great honor for me. It will be a pleasure for me to be delivering this oration today with you. And thank you again.
Thank you so much, sir. Thank you. I think we'll go to the vote of thanks by the organizing secretary, Dr. Midhu Mathan.
Respected KSOS President, TOC Vice President, and TOC President who is joining online, and all the other dignitaries on and off the dais. It is my proud privilege to express my gratitude to all those wonderful souls who have contributed to the scientific fest. As someone said, the highest appreciation is not to utter words, but to show respect. So first of all, I would like to express my sincere thanks to Professor Jeevan Singh Tityal, who is a recipient of the Sushruta oration for this year from Chaithanya Eye Hospital. And it is indeed an honor to have you with us today, and we are looking forward to hearing from you right after this. And next, I would like to thank our KSOS President, Dr. Babu Krishna Kumar, and Dr. Sushila B. Nair, TOC Vice President, for gracing this inaugural function. We are indeed honored to have you with us. And next, we will I would like to especially thank our international keynote speakers, Professor Ting Ong, Dr. Ronald Yo, and Dr. Jay Chablani. And we have a lot of national faculty who are delivering keynote addresses and being expert panelists, including Dr. Namra Sharma, Dr. Partha Vishwas, Dr. Chitra Ramamurthy, Professor Rohit Shetty, Dr. Sudarshan, Dr. Meenakshi Swaminathan, and all the national faculty panelists, Dr. Sudarshan Kokar, Dr. Ramesh Durarajan, Dr. Rohit Saxena, Dr. Sirisha Senthil, Dr. Abhishek Kotari, Dr. Darius Shroff, and all our KSOS faculty also who are joining us in the panel. So after that, I would like to thank the presenters and moderators from the Chaithanya group who have made this CME very lively. And I would especially thank my senior colleagues here, Dr. Abraham Kurian, Dr. Sarasanamam, and Dr. Uni and Anil for all the support. And let me take this opportunity to thank all the delegates and participants who have joined us via Zoom, YouTube, and Facebook. And your participation will motivate us to do better next time. And thank you, Chaithanya team, for the excellent execution and the logistics. It's always a conference to have such a strong team by your side. And last but not the least, I would like to thank Sun Pharma for all the support. Thank you all very much. And now we come to the end of the inaugural session, and we move directly to the prestigious Sushruta oration being delivered by Professor Jiva Singh Zizia. Over to you, sir, for the oration.
Okay, I think my screen is visible.
Yes, sir.
Okay, thank you again for a kind invitation and extending a warm welcome. And I am indeed very, very honored to deliver this very prestigious Sushruta Oration Award. And thankful to Chaithanya team, especially Dr. Minu Mathan and my own student, Dr. Anjana. And apart from that, dignitaries today present for this function, Dr. Babu Krishna Kumar, the president of Kerala State Ophthalmic Society, and Dr. Susila B. Nair, who is the vice president of TOC, Dr. Unni Krishnan, Dr. Manoj, and my dear friend, Dr. Sahasranamam. And before I start this oration, I think it is my duty to express my thanks to our late Dr. Nair, KGR Nair, who's been a great mentor for all of us. And it's really a pleasure for me to speak on the oration from Chaithanya Hospital today. Customization of life is we all do every day. But our life as an ophthalmologist depend on a cataract surgery because that's the most important and most often done surgery done by all of us. Therefore, a customization will definitely improve your way of thinking towards the patient and optimizing the outcome of these surgeries to our patient. I have no financial disclosure to be made. The only thing I would say, I'm very privileged person to have worked for All India Institute of Medical Science in New Delhi. And being a student of that place, I owe to my teachers. And the greatest teacher for my life has been my students and my patients. All of them had made me today what I am as a person. And I'm very thankful to all of them. And this is my journey in cataract surgery. How did I progress? How would people in my age group would have gone through the entire gamut of cataract surgery per se? The first intracapsular cataract surgery I did was 1984. By 1987, we started doing microscopic extracapsular cataract extraction, from where we started doing IOL implantation also. But it was around 91, 92 when we started phacoemulsification. That changed the entire concept of microsurgery. because before that it was a macro surgery because your incision was so large and you only thought about how to deliver the things from inside the anterior chamber. Then close the wound in such a way you have a very nice apposition. Never thought about astigmatism, never thought about early rehabilitation in those patients. Suture removal was mandatory for most of the patients, and that had its own problems. It was phaco which made us to think in terms of various steps in a very customized manner. And over that, it was foldable IOLs, which gave us the idea of decreasing the incision size because the amount of distortion in a corneal curvature was directly related to the size of incision. It was phaco and the foldable lenses which made the incision size getting smaller and smaller to a size now which is supposed to be astigmatically neutral. Subsequently, we had another addition on our phaco surgery that was a femtosecond laser assisted cataract surgery. And in our place, we acquired in 2013. Subsequently, major surgery were done in those group of cases. And similarly, in 2005-06, multifocal, basically the bifocal lenses came into market. And you know that things could be customized because you had image-guided surgeries. Now you have lenses which can be targeted to a person by person to give them a good outcome, and other devices which make surgeon more comfortable. The customization would be in a two-sided story. One is the patient's own point of view and surgeon's point of view. So which are those points where we look for as far as we and patient are concerned? Patient requires a visual correction. They come to us not for a surgery, they come to us for a visual improvement in a way to improve the quality of vision. And patient's own preference will be there in terms of a distance, near, intermediate, type of work, the profession patient is going through. And the most importantly, in a country like ours, affordability of a particular surgical kit is also an important factor for deciding what type of customized surgery can be done for that particular person. Surgeon point of view, we look for a patient as such. We look for a type of cataract, type of IOL to be selected for a patient, depending on the three parameters I talked about for patient point of view. Then the challenging scenarios and the practice which you are in. Are we in a private practice, or we are in an institutional practice, or we are in a government setup practice? So those things will decide the customization of your things. So as I said, patient point of view is important. Patient perspective is the most important thing for customizing your delivery of a cataract surgery to the patient. Then type of surgery and surgeon's own way of which type of surgery patient does, how comfortable he is in a particular type of surgery. That will make all those important things. Patient wants sutureless surgery nowadays, would always look for the latest technology to have a best outcome, if possible laser-based surgeries. Anesthesia, most patients may not desire to have an injection to be given in the eye. So topical anesthesia surgery may be desirable. And over that, the finances is also an important part in these cases. Surgeon would always think if they have a device like a femtosecond device, they would always convince patient for a femtosecond laser surgeries and look for challenging scenarios by doing a good clinical examination or added by anti-segment OCT. Then toric IOLs, especially multifocal, trifocal toric, image-guided surgery might be beneficial, and always think of sustaining the institution practice by his own practice to make it a self-sustainable practice area. So let me take you through the important steps. The first step will be corneal incision, capsulotomy, nucleotomy, and after that, the implantation IOL to really improve the visual outcome and look for your own comfort during surgery also is very important aspect for these cases. Every step of your surgery can be customized to improve your cataract surgery outcome. Incision-wise, we all talked about temporal versus superior or the nasal sometimes, which were actually because our incision was larger. Now the incision size is so small, as I said, astigmatically neutral. The people might locate them to one comfortable area, and most of us have shifted to temporal incision in these cases. Type of incision may make a difference. Size definitely makes a difference for us. Today, sub 2 millimeter incision is possible if the IOL is available which can go through these small incisions. And look for customizing your location of incision also important. Like you have a case of radial keratotomies where you have hardly any space to make a clear corneal incision. Then you have to shift posteriorly towards the scleral side to make a scleral tunnel and making an incision to avoid incision opening up. The type of case will also make your decision to make incision appropriate for that particular case. But most importantly, look for architecture and the proper sealing of incision after surgery. That means we should not be damaging the incision, which may alter your position subsequently, and minimize the post-operative astigmatic change, which can happen in some cases. So basically, we create with a keratome, which is the most commonly done, or you have an option of femtosecond laser. So would femtosecond laser make a difference in incision making? Maybe yes. So this is what we did. We studied the conventional versus femtosecond laser incisions, looked into morphology of these incisions, both the proximal part and the distal part. The most important part of incision was the proximal incision, that is towards the corneal side. So if you have a clean incision, we call it a slit-like incision, the chances of a damage to descemetes at that area is less. So we have a lesser chance of descemet membrane detachment. And femtosecond laser would give you that clean cut. If you see here, this is a anterior to the corneal area, absolutely clean cut. The chances of descement detachment towards the end of surgery is also less. If you do a manual incision in these cases, normally you get a uniplanar incision in most of the cases. And wound side descement disturbance is much more in a manual keratome related incisions. But yes, in a keratome also, we can achieve the same type of very nice anteriorly clean cut in incision by using a sharp and disposable keratomes or diamond knives, which can give you a similar incisions. So it's not the size, it is the orientation or the morphology of incision, which is very important in terms of decreasing the complication. Now, I would always like to customize my incision in such a manner where I get a clean biplanar incision with a keratome or a triplanar with a femtosecond laser application. The second important surgical aspect for all of us is the capsulotomy, which we have learned once actually the CCC, which is invention after the phacoemulsification surgery. Before that, we used to do capsulotomy only, which could be any type. We started with the bear can type or a Christmas tree type of capsulotomies. But now CCC is mandatory to complete your phacosurgery. So it can be done by manual CCC, femtosecond laser, plasma blade capsulotomy, or now people talk about JEPTO. This is a precision pulse capsulotomy. So these are various options we have for getting a good capsular opening for completing your phacosurgery and subsequently implanting IOL in the right place. So customization is important because CCC, if covers the entire peripheral edge of the IOL, we believe that subsequent PCO would be less, especially in a square edge lenses, 360 degrees, or rexis, which is well centered to IOL, especially for our multifocal premium IOLs, will be having a better in the bag orientation of lenses, and the effective lens position, which we calculate before for IOL calculation, may be appropriate for such. So if you have a broken rexis or a rexis which is eccentric, the lens might shift not on the table or next day, but after a few months with the fibrosis happening in the capsule, the entire lens can shift to one side, and toric and multifocal lenses may not have the same effect in these cases. Difficult cases like small pupil subluxation, their customization of capsulotomy is absolutely important. And you have to modify your approach in a cases like a wide cataract or intermittent cataract, depending on your type of things available. This is one of the first publication on femtosecond versus manual, where femtosecond would give a better same thing. We did a study on a wide intermittent cataract, where we compared cases of intermittent wide cataracts with femtosecond laser capsulotomy versus the CCC, which we do manually, single stage versus multi-stage procedures, or looking for additions which may be there in a laser application. And two areas were looked into. That is this is a femtosecond laser in a wide cataract, where the explosion does happen in these cases. We may have a little bit of additions, and you may have to do a little bit of rexis pattern in these cases. Manual, depending on our intumescence, we do a single stage or dual stage, where we aspirate the intralenticular cortex to decrease the pressure to complete rexis subsequently. And we realized that chances of achieving a good diameter is much more with the femtosecond laser application, which was significantly better. Similarly, the circulatory index of capsular access to a capsulotomy laser, the femtosecond gave a better circulatory index. So both were better in the cap. But if you look at the ultimate outcome in terms of achieving good central rexis size and complication attached to these wide cataract capsulotomy capsular rexis, they were comparable, not much a difference. The only circulatory and size were much predictable with the femtosecond laser. The wide cataract, we can customize wide cataract again by looking into a very short. This is the femtosecond laser, small video here to see how the laser application will actually create the release of pressure on the table. This is a closed eye, therefore the capsule extension doesn't happen. People have asked me many times, would capsule get extended in these cases of wide cataract, the intumescence? Because whatever thing is happening in the closed eye, therefore chances of extension of even you have addition is less in these cases. So this is a manual surgery on an intumescent wide cataract, where you can see OCT does show there's an intumescence here. But surgically, if I just make a nick here, so this is a higher magnification. There's a sort of a dimpling or nippling of anterior capsule here, which is the anterior bulge here. As soon as you make a nick, they can radiate to periphery. So if you have a high viscosity viscoelastic may prevent extension to periphery. So this is one thing if I remove my capsulotomy needle, the pressure might change. So I thought what to do here. So I did a cruciate incision in this particular case. I did one radial incision. The pressure changed now into 3 directional pressure. And then another radial incision nick from a superior to this side. So it has a 4 cruciate incisions. And that subsequently decreased the pressure radiated to 1 unidirectional to a 4 direction, which may have prevented extension to peripheral area in this case. So if you look into other way of customization of capsular access, so this is a device which is available in LENSAR femtosecond laser device, where it has the refractive capsulotomy can be possible, where it gives you a sort of a nick or a tongue-shaped area on capsulotomy, which may be at the same axis of implantation. So this is how you can have image guided, as well as you don't need to have the anterior overlay for putting IOL in these cases. This was just to compare my overlay and this refractive capsulotomy in the device, and it's absolutely matching in these cases. So if you have these devices, you can see this is a tongue and my 3 dots are IOL absolutely over this tongue. So these can simplify your results. Similarly, in a phakic IOL situation also, you can do a capsulotomy without opening the eye to remove the phakic IOL, and laser sometimes helps you in these cases. But this is my patient who had a cataract subsequently after implantation of a phakic IOL. I could do capsulotomy in a closed chamber and remove the capsule without disrupting the pupil, which can happen. So I can't again make it big. Sorry. And subsequently remove the entire lens with these cases. In terms of looking for other way for on the table, intraop OCT attached microscope will give you a much more visibility of what is happening in these cases. Especially, it gives you a dynamicity of each step with the anterior capsule, and subsequently you can see what is the spectrum wide cataract you're dealing with. If you have this type of cataract, even your intumescence, you nick the anterior capsule, it may not release the pressure as such. So this is a type 1 where everything uniform and capsulotomy can be done very, very easily in these cases. This is type 2 wide cataract, what we described, where they have a sheets of hydrated capsule. After making a nick also, the sheet doesn't get disrupted, the pressure doesn't relieve. So these cases have to be aspirated after making a small nick in the capsule. And that will decrease your pressure subsequently. So once you make a nick, aspirate the cortex subsequently, and that will allow your subsequent release of pressure in these cases. Similarly, this is a combination of a sheet and a fluid. So as soon as you make a nick, the fluid comes out. And in fact, you can aspirate a needle also in these cases and decrease the pressure and continue your surgery subsequently. This is type 4, which is like a Morgagnian, where as soon as you make a nick, the entire milk comes out and pressure goes down very effectively in these cases. But the back pressure also goes down, your capsule becomes loose. So you may have to refill the chamber to initiate the rexis with the improper pressurization. So I can say if you have IOCT, you can customize your surgery according to the type of white cataract you are dealing with. This can be seen in an intersegment OCT preoperatively also. But what happens on the table after making nick cannot be appreciated in these cases. So that is only on the table you can see the entire morphology would change after you make a nick in the anterior capsule. And accordingly, you have to change, you have to customize your rexes in these cases. So I would say, apart from the rexes, I think nucleotomy can also be customized. Manually also, we do various types of nucleotomy techniques, stop and chop, or you have nuclear fractures or multi-chops, direct chop versus stop and chop, or a vertical chop versus horizontal chop. You have many types. But femtosecond laser gives the right customization of various types of nucleotomy which can be done at different types of cataract, hard to soft to case the difficult cases also. So this is what we studied in a grade 4 cataract. We compared 2 patterns of a femtosecond laser application in the nucleus softening. One was matrix pattern and one was a chop pattern. And we realized the matrix pattern gives a better nucleus emulsification. The amount required, energy required is less. So if I have to customize for hard cataract, I'll go for matrix. But if I have to really go for a difficult cases, sometimes you can combine both. Hybrid technique can be done. In soft cataracts, we'll do just a circle pattern. If you see here, this is a soft cataract pattern. You have multiple rings happening. The same thing can be applied to the femtosecond laser in cases of posterior polar cataract. This is my technique where we make 3 safety rings and 8 chops, gives a blocks of a nucleus, and each block can be subsequently taken off. You can see this is the 8 chops and 3 safety rings. If you see on the table, you can take one by one. Each block can be aspirated very easily in these cases. And this technique is very suitable for a grade 3 nucleus or plus. But if you have a very soft cataract, simple safety rings can be done also, which is described by Dr. Abhay Vasa in our cases with the posterior polar cataract. So anyway, these can be done. In femtosecond laser also, flex is a very, very helpful technique where you can see without opening the eye, without disrupting the anatomy of entry chamber, you can do a capsulotomy like with the laser in an area of concern, and you can do a nucleotomy in these cases in terms of making a various chops and softening these cases, and you can do incision. The 3 important steps are done in a subluxury cases without disrupting the anterior chamber. If you make an opening with a manual incision, the entire lens diaphragm comes up and the subluxation can increase. So this is the advantage we see in a femtosecond laser application in a subluxury cataract. I'll just go through, I'll avoid this video. And if you look into a femtosecond laser, I think true customization can be done in a femtosecond laser. IOCT again does help in posterior polar cataract by making various classification. This is all description in JCRS where it describes 3 patterns of types of posterior polar cataract. The 4th one was when a capsule is totally open. Accordingly, you can describe. So this is a type 2 where periphery can be visualized, the posterior capsule. Center is not visible in these cases. And type 3 where entire extent of a disc, you can't see the posterior capsule. The type 2, type 3 is very difficult to do. You should avoid doing a hydro dissection. Type 1 where you can see the entire capsule, you can do a hydro delineation as well as dissection. So this is hydro delineation, this is hydro dissection in a type 1. So type 2 and type 3 are the one where you have more chances of a posterior capsular dehiscence. So you can customize your procedure according to various types of a posterior polar cataract seen in IOCT. Outcome-wise, we all know clinical assessment will give you what type of image-guided surgery you're going to do for toric IOLs. Subsequently, you can augment your consideration for patient by looking at a patient requirement, spectacle-free or patient desire near or distance, intermediate. Accordingly, we'll select the IOL for these patients. As far as surgeons are concerned, we look for angle kappa, angle alpha, amount of astigmatism, anterior, posterior, any comorbidity, post-refractive surgery patients, or a patient having ocular separate disorder. Accordingly, we'll select the type of IOL for these patients. So all 3 factors will assess the lifestyle of patient. Accordingly, we can give an IOL for these patients. The significant amount of lens opacity, yes, surgery to be done, especially patient with a hyperopic patients. Multifocal IOLs does give a better option for a patient earlier than actually having a significant cataract. So refractive lens exchange is an option for these patients of high hypermetropic patient or high myopic patient as such. Always look for a contrast. Or nowadays we have, if you have eye trace, that can also give you a dysfunctional lens index that can also give you an idea of what type of patient rehabilitation you have to do for these patients. The patient having too much of corneal aberrations, these patients should be avoided with multifocal IOLs. Patients who have a large angle alpha, again, you should avoid multifocal IOLs in these patients. Astigmatism more than 0.75, you have to correct that for a multifocal IOLs. In fact, even for a monofocal lenses also. Consideration of posterior astigmatism is very highly debated issue nowadays. If you have IOL master, that can take care of your posterior corneal astigmatism as such. There are various devices by which you can measure the posterior corneal curvature. This is one example. One of my patients for a trifocal IOL. So if you just look into anterior corneal astigmatism, it's less than 1 diopter. You might think, simple trifocal would do here. But if you see the total keratometry, it is more than 1 diopter. Therefore, this patient will get, undercorrected if you just go for anterior corneal astigmatism. The patient may not be happy. So you look for a toric calculation of this patient. You know that the actual requirement is a T4 for this patient to correct this astigmatism. And that will give a better post-op outcome, because both you can see the anterior corneal curvature ATR against the rule, and that will require a higher correction for a patient who has a posterior corneal astigmatism, which is significant. So T3 would have given 0.55 diopters. If you go with T4, gives a 0.02 diopter of cylinder residual. So that is how we normally looked into it. All these extended range of vision, trifocals, multifocal, why should we put them in a patient? Are they going to improve quality of vision? That has to be assessed. Visual acuity does improve distance and near. So this is our study on a stereo acuity of lenses with extended depth of focus as well as for a trifocal lenses. And we realized that stereo acuity is better with the multifocal lenses, as good as monofocal lenses. Therefore, these lenses are acceptable for patients. And the spectacle independence is always very good, 96%, 94% for intermediate, 62% for near. This is for a extended depth of focus lens. This is far better with the trifocal lenses, which we subsequently studied in our patient. And we found that trifocal lenses gives a better visual outcome for a wider range of vision. Intermediate vision, which should range from 40 to 70 centimeters of depending on a patient work profile, and that is achieved by the newer generation trifocals. So anything which can give a range from 40 to 70 centimeters gives you a better visual acuity for distance and near, because light distribution with these trifocal lenses are very good for all the distances. And any lens which can give more than 88% light transmission would be the good lens nowadays as such. And in future would be a better extended depth focus lenses give you the quality of vision for these cases. Little bit on toric IOL. I already talked about this. The image guided surgery will give you a better concept of customization. That is customization incision, main incision, side port incision, rexis customization in terms of size. And in fact, you can change with the angle alpha and kappa also the centration of rexis in these cases. But if you have devices which can actually give you a right orientation of your lenses subsequently, can also make life easier. After I complete my nucleotomy in these cases, then see how these lenses do. Like see this gives you my incision every time in the same incision I'll be doing for my all cases with toric scenario. I don't change incision as per the steeper axis. It should not be done also. And subsequently, after you complete your axis as per the desired size, you can implant the lens in an area which is actually gives you a absolute zero orientation or a zero deviation from the required axis. So these three lines give you the area of consideration. After I hydrate my own, make the chamber comfortable, by the time lens also opens up very, very effectively. Then you just tuck the lens, you leave lens around 3 degrees anti-clockwise, and then come clockwise to complete the orientation with this lens. This is axis is well oriented. This is little away. I'll hydrate my own. So this makes the back stiffer and in a better position. Normally lens will not rotate even you do increase the pressure. So just one tuck and now it is effectively done in right in the center. So this will give you a better orientation for all our patients. The toric IOLs, especially for multifocal toric IOLs, it is very important. And we did assess cases, manual versus image guided. Image guided gave a better contrast sensitivity, better quality, lesser higher order aberration, and these patients do well. As far as surgeons' comforts are concerned, you look through the oculars, gives you a lot of neck rigidity, sometimes pain in the neck. Now, if you have off microscope surgery like heads-up display with the 3D systems, will give you advantage of if you have attachment of OCT also, and Callisto if you are using a Zeiss RTPO 800. So it gives you all in one go. In fact, your toric implantation is much more accurate because this is a routine microscope distance of 3 lines, and this is 3 lines under the heads-up device, which is much narrower. You're going to achieve a much centralized orientation of lens. Magnification can be done very, very high, and you can have OCT attachment also. To summarize my entire talk, customization can be done in all aspects, right from the patient point of view to a surgeon point of view in all aspects. Surgery, yes, we have done customization. We need to do further also. The days are gone where we only thought about a traditional approach of a one size fits all. It's not true. We have to really customize and predict, prevent, and precise your care to the patient. And approach should be case-to-case based, not only in a chair time which you give in an OPD, also on the table also when patient is lying under your blade. That should also be customized, and it can be changed for the surgical pattern you are seeing with these cases. I would say customization is the life. It's going to improve your future also, and we should always look for innovations and customize our surgeries. Again, I'd like to thank the entire organizing team for giving me this opportunity and the time to deliver this talk. And very, very thankful. I can see people would have some questions. I'll be very happy to answer them. Thank you again, the entire organizing committee.
So, thank you, DDL sir, for that wonderful oration. Dear friends, we were hearing words of wisdom, knowledge, and experience from a master. So it's not about not only details are doing cataract surgery from 1984 to 2021. It's about the history of cataract surgery, at least in India, and probably many parts of the world for that matter. So Didiyal sir was a person who walked along with and ahead of history of cataract surgery during the last maybe 4 decades, close to 4 decades. And not only he has worked not only with cataract surgery, he has worked along with the history of cornea and refractive surgery in India as well. So that was great hearing you, sir. So we are really honored.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. Thank you, Dr. Didiyal, sir. It was a privilege and an honor to listen to you and to have you with us today. Since there was a technical glitch with our audio before, we'll be replaying the presentation of award once again now.
Chaithanya Eye Hospital and Research Institute is proud to honor Professor Jeevan Singh Titiyal with the Sushruta Oration Award 2021 in acknowledgement of his extraordinary clinical acumen and exemplary contribution to the development of ophthalmology in India, and in recognition of his dedicated teaching services in molding the careers of eye surgeon in the country. CEHRI is honored to award him the Sushruta Oration Award of 2021.
I'm greatly honored to receive this very prestigious oration, that is Sushruta oration from Chaithanya Eye Hospital and Research Institute. And they've been doing such a great work in that part of the country where the eye services were lifted to a standard which we see today long time back by my dear friend KGR Nair. And I remember he's being with my family multiple times in Trivandrum, and I respect his legacy. He has set up for such a big institute in Trivandrum, and it has served the entire population of Kerala. I'm hopeful that the people working in a Chaithanya hospital will do much more than what he has left and take his name to greater heights. I'm extremely thankful to entire people, the scientific committee working behind this prestigious work they are doing, and especially this scientific program, which is programmed in such a manner which highlights the difficult scenarios. And if I see the list of faculty which has been called to deliver talks, is truly international, and I hope that people will enjoy this entire session. Thank you again. I'm greatly honored.
That is in silver.
So,
yeah, I would like to thank Dr. Anjana, for taking us such a pain to come to Delhi and deliver this oration plaque there, and it was my privilege to have it from my student, and it was a beautiful day for me.
So once again, thank you, sir, and also thank you for your fond memories of Dr. K.J. Nair, sir, and your words of encouragement about the Chaithanya group. Once again, thank you, sir.
Thank you.
Thank you, everyone. We are now moving on to the glaucoma session of Synoptic, which is the session 4. I now invite Dr. Thomas George, Senior Consultant in the Glaucoma Services, Chaithanya Trivandrum, to moderate this session. Over to you, sir.
Good morning, everybody. It is a great privilege at Chaithanya to have such a eminent faculty for the glaucoma session. The international faculty we have is Professor Ong. Professor Tin Ong is a clinician scientist with research interests primarily in angle closure glaucoma and glaucoma genetics. With over 600 publications, Professor Ong is a member of the editorial board of prestigious journals like the Ophthalmology, the Eye, the Journal of Glaucoma, Graphics Archive, etc., to name a few. He is a past president of the World Glaucoma Association and serves as a board member for Asia Pacific Glaucoma Society. And this year, he is one of only 2 persons to be honored by the WGC with the Founders Award. Dr. Sirisha is well known all over India. She is the head of the glaucoma service at the LVP Institute from 2012 onwards. She is big enough to have received the American Academy of Ophthalmology Achievement Award in 2018. She is a respected presence in the glaucoma faculty at the national and international levels. And Dr. Kiran is the other faculty we have got, who has earned his MD in ophthalmology from the apex institution of the country, RP Center, AIMS, where he graduated as the best resident. And he did a senior residency there, and subsequently he's been working with our town, Trivandrum, in the last decade as one of the dynamic glaucoma and anterior segment specialists, presently at the Precise Eye Care Hospital. The rest of the faculty are my colleagues here in Chaithanya, Dr. Meena, Roshni, and Harsha. Without much ado, let me go on to the session itself. We'll go on to the keynote address by Dr. Ong on current management of angle closure glaucoma. Professor Ong, kindly share your slides and deliver the keynote address for us.
Thank you so much. Can you hear me?
Yes, sir.
Thank you. I would like to thank Dr. George for inviting me to give this talk, as well as Chaithanya Hospital. I think, can you let me share the screen?
Please share.
Okay, can you see my screen now?
Yes, sir. Yes, sir. See.
Okay, thank you so much. Yeah, it's a great privilege to give this talk in your symposium. And I'd like to say hello to Dr. Senthil and other friends from India. I come from Singapore, and these are some pictures of Singapore. And this is my hospital, the Singapore National Eye Center, which is the main eye hospital in Singapore. So my talk today I was invited to give a talk on current management of ankle closure glaucoma. And of course, we have to firstly mention that the fact that you have to do a gonioscopy to make the right diagnosis. You should assess the eye for PES, for intraocular pressure, as well as to look at the optic disc and visual fields. And the conventional management of ankle closure glaucoma has been to do a laser iridotomy as the first step, and this is because it acts in relieving a pupil block. And this is an example of an eye before and after iridotomy. You can see the reduction of the iris convexity and opening up of the angles. However, we also know that there are many eyes which do not open after iridotomy. The example on the top is one that opens, but the one below is where there is no effect at all. And studies have shown that certain eyes do not respond to iridotomy. For example, narrower angles, those with the anterior iris position, those with the thicker iris, a plateau iris, of course, large lenses. And of course, we know that the lens plays a major role in ankle closure glaucoma, and it's part of pupil block. And you can see this example here with this kind of big lens, especially a big lens vault. It is no use actually doing an iridotomy. You need to take out the lens. And so the first point I'd like to make is actually for the current management of ankle closure glaucoma, the first question you should ask is there a significant cataract? And if so, you should consider doing phaco as a first option in patients with a significant cataract. We know the role of phaco also works after you do iridotomy and the angle remains closed and the patient has cataract. Of course, you can also remove the cataract. The second question to ask is to look at the severity of the ankle closure glaucoma. And if it's very severe with a lot of disc damage and visual field loss and synechiae, should you consider doing a phaco trabeculectomy with mitomycin rather than just doing a plain phaco alone? So that's the second question you should ask. And in those with not so severe ankle closure, but with a lot of synechiae, should you consider doing a phaco GSL or goniocephalic lysis? So of course, phaco alone should be considered in eyes with milder degrees of ankle closure, with not so bad optic nerve damage, and perhaps those who are not on maximal medical therapy. But for those more advanced cases, you worry if you just do a phaco alone, whether there'll be IOP spike or poor IOP control after surgery, until you may need to do a second stage procedure subsequently. So this is consideration for such eyes, or whether you should do a phaco trabeculectomy with mitomycin C, as this would be a 2-in-1 procedure and may help in both lens removal as well as to help with the glaucoma pressure control after surgery. But of course, the cons are that you may have more inflammation and perhaps the outcomes may not be as good as you're doing a separate stage procedure. And as mentioned earlier, you may not need a bleb in all cases. So generally speaking, there have been several studies that looked at phaco versus phaco trabeculectomy. But generally speaking, you would say that phaco alone is effective in improving IOP control in most cases, especially the milder ones. But for the severe ones, you consider doing a phaco trabeculectomy. But of course, there are more risk of complications. Let's talk about the other issue about whether you should do a phaco goniocephalic lysis. And this is, of course, in cases where there's extensive synechiae, but not so severe ankle closure glaucoma. And actually, we did a trial recently where we compared phaco versus phaco GSL. And what we found was actually surprisingly that the phaco group alone did very well. In fact, they did almost as well as phaco GSL, and it was not significant in terms of complete success as well as qualified success. And in terms of IOP lowering even, they were similar in the phaco group and the phaco GSL group. So this was a little bit surprising, and we were a bit surprised. We thought that the phaco GSL would do better, but we found that both groups did well, but phaco alone was just as good as phaco GSL. And so this was perhaps shows you the limited extra efficacy of GSL. And why was there no difference in phaco GSL compared to phaco alone? Well, perhaps some were cases with long-standing synechiae, and we know that if you have long-standing synechiae, sometimes the angle may not be functioning well, although you may anatomically have opened up the angle with the synechialysis, but they may not be functioning well. And this is because studies, for example, from Ramanjasiota showed that there's fibrosis of the trabecular meshwork in the areas where there's underlying the synechiae. And another possibility is that in certain eyes, for example, those who had just a recent attack of acute angle closure, in which the PES was more of recent onset, they may be more effective, but those with long-standing PES, they may not be so effective. And Dr. Tanuj Dada also did a similar trial of phaco versus phaco GSL recently in Delhi, and they just published this paper last year in Ophthalmology Glaucoma. Also, they found no difference between phaco and phaco GSL. What about cases of angle closure without a significant cataract? Should you consider clear lens extraction? Well, recently there was a trial performed called the EAGLE study, which stands for Effectiveness of Early Lens Extraction for a Treatment of Angle Closure Glaucoma. And this was a multi-center study involving 5 different countries. Most of the cases came from the UK, and they recruited people who were more than 50 years old, either with primary angle closure with IOP more than 30 or primary angle closure glaucoma. And these people did not have any visual complaints, and so they were thought to be clear lenses. Although they did not define clear lenses, they just mentioned that they were not symptomatically poor in terms of the vision. And they were randomized to clear lens extraction or standard of care. Standard of care means LPI and topical treatment. And the main outcome measure was actually the patient-related health status or quality of life using the EQ-5D questionnaire. And the secondary outcome measures were intraocular pressure as well as the quality of life gained. And in this study, they enrolled more than 400 patients, and they found that the primary outcome was better in the clear lens extraction group. The health status was better, and the IOP was also slightly lower, 1 millimeter better than in the LPI arm. And so there was also a less need for glaucoma medications or further glaucoma surgery. In a subgroup analysis, they also found that there was better quality of life gained for clear lens extraction compared to standard of care. So this was a very big study which concluded that clear lens extraction was superior than standard of care for such patients, and that you can consider clear lens extraction as an initial treatment of PAC or PACG with high pressure. But there were some issues with the EAGLE trial. Firstly, not all patients with really clear lenses. As I said earlier, they defined them as people who were not symptomatic. And many of the cases actually were quite mild, so they didn't have many severe angle closure glaucoma, and that's why perhaps they could get away with just a phaco alone. Another issue of the trial was that most of the surgery were done by experienced surgeons, so the complication rate was quite low. And finally, quality of life is very difficult to translate into clinical practice. What do you mean by quality of life? It could be just mean that because they have less hyperopia or their vision is a bit better, they translate that to a slightly better quality of life. So it's difficult to really translate this finding directly. But certainly, I think the EAGLE trial has given good evidence for clear lens extraction, and certainly has moved our practice towards earlier lens extraction rather than clear lens extraction. And I think that at least in Singapore, we would consider clear lens extraction still to be a very aggressive approach. But of course, you should discuss the option with the patient. But we tend not to do clear lens extraction because of the risk of phaco of clear lens extraction. As you know, these cases are often difficult. They often have a shallow anterior chamber, big lenses, and they have risk of complications, including corneal decompensation and suprachoroidal hemorrhage. And so you need to be done by experienced surgeons, and certainly not done by juniors or people who have not much practice in such eyes. Now, let's move on to the example of patients who have either no cataract or mild cataract, or they're unwilling to undergo phacoemulsification. As I mentioned earlier, the treatment would then be laser iridotomy. Now, studies have shown that if you do a laser iridotomy as a treatment for angle closure glaucoma, many patients require further medication or surgery in the long term, usually within 6 to 12 months. And this suggests that laser iridotomy alone is not sufficient to control IOP in many cases of angle closure glaucoma. And these patients should not be discharged. They need to monitor them and follow them up for the IOP control and consider early cataract surgery if the IOP control is poor or the angles are more progressively closed or they develop glaucoma. Now, let's move to the scenario of after laser iridotomy and the pressure is not controlled, what should you do next? So as I said earlier, many cases do not respond to iridotomy alone, and you need to have additional medication or surgery. And we know now, many studies have shown that prostaglandin analogs have good efficacy in chronic angle closure glaucoma with high IOP post-iridotomy. So this was the first trial done in angle closure glaucoma where they did compared latanoprost with timolol, and they showed latanoprost had about 8 millimeters of mercury lowering compared to timolol of 5 millimeters of mercury. So this was an early trial back in 2003. And since then, other studies have shown the efficacy of the other prostaglandins like travoprost, as well as bimatoprost, showing that for chronic angle closure glaucoma with raised IOP and after LPI, prostaglandin analogs should be the first-line treatment. Now, if the angles are opened up, should you do SLT? Now, this is another option. If you have done a laser iridotomy and a part of the angle is opened up and the trabecular mesh is visible, should you perform SLT? Well, we did a study published about 5 years ago where we looked at such cases post-iridotomy, after which the angles had opened up to some extent and they had high pressures. We randomized patients to SLT or prostaglandin analogs. And we found that they had similar IOP lowering compared to prostaglandin analogs, but overall, the success rate was a little bit lower in SLT group compared to the prostaglandin group because, as you know, there were some people who do not respond to SLT. Just like in open angle glaucoma, there are about maybe 20% of patients who do not respond to SLT. And similarly, in angle closure glaucoma, we also found that there was about 20% of patients who did not respond to SLT. And this is, we don't know why this happens and why some people respond well to SLT and others do not. Certainly, the light trial showed a much lower non-response rate, maybe less than 10%. But we think that in these patients, you need to monitor them and also explain to them that there are some patients who do not respond well to SLT. But whatever it is an option in patients post-iridotomy and pressures high in which you have some amount of open angles. Finally, the last part of my talk is on the management of asymptotic narrow angles or PACS. Now, we know this is fairly common in Chinese populations. Maybe about 7 to 8% of people are PACS or primary angle closure suspects. But the prevalence of angle closure glaucoma is about 1 to 2%. So from these numbers alone, you would can deduce that most PACS do not progress to PACG. Now, the progression rates are unclear. From Ravi Thomas's study in Vellore, he found that perhaps 20–30% of patients, if you were left untreated, progress from suspects to PAC, and similar amount will progress from PAC to PACG. And so this was thought to be quite a high rate of progression. And so we did a very large trial called the ZAP trial to really quantify this risk and compare LPI versus observation. This was a trial published 2 years ago now, called the ZAP trial. ZAP stands for the Zhongshan Angle Closure Prevention Trial because the study was done in China in a center called the Zhongshan Ophthalmic Center. So in this trial, patients with PACS were randomized to LPI in one eye and observation in the other eye and followed up for 6 years. So this was an intra-patient control arm. And the primary outcome measure was the incidence of PAC defined as IOP more than 24, or the development of PAS of at least 1 clock hour, or the development of acute angle closure. Well, the ZEP trial followed up patients for 6 years and found that overall, the progression rate was about 4.19 per 1,000 eye years in the LPI arm compared to about double, almost 8 per 1,000 eye years in the control arm. And if you put it in raw numbers, it's about 2% progressed in 6 years compared to 4% if you were untreated. So this was a very surprising result, certainly much lower than what we thought from the Vellore study, where they thought maybe 20-30% will progress in 5 years. And in the ZEP trial, they only found 4% progression in the observation arm. But when you do an iridotomy, it reduced the risk of progression by half. Okay, so there was a surprising result of less than 1% per year progression. And of course, the iridotomy was found to be safe with no long-term adverse events. And remember, the main outcome measure was PAC and not PACG. There were very few people who developed PACG. Most of them who reached the endpoint was PAC. And so the conclusion of the ZEP trial, or recommendation of the ZEP trial, is that PACS can be observed because the risk of progression is really quite low. And certainly as a programmatic level in countries like China, where they have a lot of people with PACS, they do not recommend systematic or community-wide screening for ankle closure suspects, followed by prophylactic laser PI. Now, of course, the ZEP trial was in a Chinese population, and so may not be applicable to those in India. And they were also a slightly younger population, in the mean age was in the 50s, compared to those who are older. But of course, we wanted to recruit people in the ZEP trial who did not have significant cataract. As I mentioned earlier, those who have significant cataract should just undergo cataract surgery. So it was intentionally then done that the trial was a younger population in which they were PACS with not much cataract, in which you would then answer the question of whether you should do a PI or observation. And of course, finally, the ZEP trial, they recruited patients from a community setting in China and not in hospital setting. Now, Singapore also did a study called the Analyst Trial. This is now a paper that's in press in ophthalmology. And we had the same protocol as a ZEP trial. In fact, we started even before the ZEP trial, but our recruitment was so much slower. As you know, in China, there are so many more patients and they're much more organized than Singapore. And so we started earlier, but finished later. But what we found was similar to the ZEP trial, overall low progression rates, but higher than the ZEP trial. We found 10% progressed to PAC in the observation arm versus 5% in the laser arm. So again, the risk of doing the laser, the risk reduction was about half, but the rate of progression in our study was higher than the ZEP trial. ZEP was 4 and versus 2. We found 10 versus 5. Okay, but similarly, again, our endpoint again was PAC. Very few people developed PACG. So has the ZEP trial affected management? I think both studies, SAP and Singapore Analyst, provides evidence of the low risk of progression of PACS and raises the question of whether we're over-treating PACS when we do LPI for everybody. So right now, when I have a patient with PACS, I discuss with the patient the option of LPI versus observation. I will give them data, for example, like Singapore, saying 10% will progress versus 5 after iridotomy. And who should I do an LPI among those with PACS? Well, of course, one group is, of course, the fellow eyes. If the fellow eye is PAC, PACG, or acute angle closure, of course, you would recommend LPI. But among those with just bilateral PACS, I recommend LPI for those, for example, who are symptomatic. That means they say that they keep getting eye pain and headaches, which is not verified but could suggest intermittent attack. People who need regular pupil dilation, for example, those who have diabetes or other macular problems. Perhaps people who have poor access who may not come back for follow-up. And the question mark, those with a family history of glaucoma, I would also consider doing an LPI. But for the rest, I'll give them the option and then let them decide. So in summary today, I've given an overview of the current measure of angle closure. Particularly, I've stressed you about the role of lens extraction, particularly as the primary treatment outcome, treatment option, particularly for those with significant cataract, and also the fact that you should consider phacotrabeculotomy for more severe cases. And I've also given you an overview of current management of medically raised IOP after iridotomy and the measurement of asymptomatic narrow angles. Thank you for your attention.
Thank you, Professor Ong. That was a wonderful, enlightening talk, and actually you made the algorithm for us already from that talk. We will go on to one case where we managed angle closure. I would ask Dr. Roshni to please share her slides and go straight on to the case, and then we'll discuss both the case and in relevant to management of glaucoma.
Thank you, sir, for the introduction. So I'm presenting two similar cases. The first one being a 62-year-old diabetic female who came for gradual defective vision. She was on anti-glaucoma medications in both eyes since 9 years. And there is a history of acute angle closure attack in right eye in 2013, and YAG PI was done in both eyes. As the acute attack did not resolve, she had undergone surgical PI in right eye 5 days later. The best corrected visual acuity in right eye was 612 N8 and left eye 69 N8. On examination, she had surgical iridectomy in right eye and patent PI in left eye and visually significant cataract in both eyes. Gonioscopy was open only to PTM, and intraocular pressure was 10 and 12 millimeters of mercury. And right eye had glaucomatous disc, and left eye the disc was normal. Anterior segment OCT, there was a large nucleus with a high lens vault of 1.6 millimeters in both eyes. She underwent a phacoemulsification with the PCIOL in left eye, and the IOP is staying normal, and she's off AGM in her operated eye, and we are planning fellow eye cataract surgery. Postoperatively, the gonioscopy and ASOCT angles widened. To summarize, a 62-year-old female, PACD both eyes, she status post peripheral iridotomy on AGM, detected visually significant cataract, and on evaluation, thick lens and high lens vault were identified, underwent phacoemulsification with PCIOL in better eye, and she is off AGM, and IOP is well controlled postoperatively, angles widened postoperatively. Moving on to second case, this is a 53-year-old female who is on antipsychotics since 2 years. She presented with a gradually progressive defective vision in right eye, and the recently detected faint shadow in front of left eye. Right eye had only hand movements vision, and left eye the vision was 6/6 and M6. She ignored the right eye defective vision, though she was aware. Slit lamp examination revealed clear corneas, Van Herrick's grade 1, and clear lens in both eyes. Right eye had 48 millimeters of mercury pressure, and left eye was 42. Gonioscopy, no angle structures were seen, and it was opening to PTM on indentation with Syneque in right eye. Right eye had a glaucomatous optic neuropathy with corneal cupping and pale disc, and left eye had a minimal disc pallor only. She underwent YAG peripheral iridotomy in both eyes, and she was started on anti-glaucoma medications. UPM and ASOCT were done, which revealed a plateau iris with a relatively high lens vault in both eyes. On follow-up, IOP was uncontrolled with anti-glaucoma medications, and considering her one-night status and with absence of Syneque in left eye, and there is need for good IOP control, she underwent a clear lens extraction with PCIOL in her better eye. Postoperatively, the IOP is 10 millimeter mercury. She is nil AGM after 2 weeks, and gonioscopy, the angle widening was noted compared to pre-op. ASOCT also revealed iris falling back to open angles postoperatively. To summarize, this 53-year-old female with bilateral PACD, which she was unaware, underwent LPI after detecting chronically elevated IOP, but the IOP remained uncontrolled. Evaluation revealed plateau iris and high lens vault. She underwent a clear lens extraction with PCIOL in better eye. Angle widening was noticed postoperatively, and we could take off AGM, and now the IOP is under control. Thank you.
Thank you, Roshni. it is obvious that in PACS, we really have no problems. The patient decides whether he needs a PI or be observed, and as has been elaborated by Dr. Ong. But Dr. Ong, once he comes to PAC and with a PI, the angle does not open up, what would we go on to? Not take PAC.
Say again, in what patient? PACG?
At the level of PAC. It's a few Siniki already.
Yeah. Okay. So if the patient after LPI and the angle is still remains closed, okay, I think the scenario depends on what kind of closure, the synechial closure or appositional closure, right? And the next thing is what is the pressure control, right? Is it poor or good, right? Now, if it's appositional closure and the eye is still, and the angle is still closed, you can consider doing an iridoplasty to open up the angles. Now, I used to do that a lot, but lately I'm becoming less aggressive. If the pressure is controlled and although there's appositional closure, I may just watch the patient, because sometimes you do iridoplasty, there are also side effects. You may get corneal decompensation, patient may get visual disturbance, etc. So I'm not really sure whether you should be very aggressive in doing an iridoplasty in this oppositional closure. Yeah, I mean, if the pressure is normal, I may just watch them. Yeah, if the pressure is high, then yes, I may try the iridoplasty as an effect and perhaps combine it with medical therapy as well, because to lower the pressure if it's high. For the synechial ones, of course, there's no use doing iridoplasty because you have synechial closure. Iridoplasty is not going to work in those with synechial. And again, you have to consider whether you want to do phacoemulsification. And we used to do a phaco with GSL, but as I said earlier, GSL got very limited effect. So, you may be doing it just for your own satisfaction of doing a GSL, but I mean, obviously, studies have shown that the efficacy is just as good as just doing a phaco alone. Yeah. So, I mean, these are some of my thoughts. Thank you.
Yeah, I have one query to Dr. Ong as well. This lens vault, the high lens vault was actually quite well documented in the two cases described earlier. So one was actually a lens vault of almost 1.6. That's quite a high lens vault. I suppose, are there any landmarks of lens vault that can be used as a criterion? I mean, because we are talking about clear lens extraction here in one of the cases. Yes. Obviously, that she was on antipsychotics that would make the surgery a little challenging as well. Plus the fact that she was one-eyed. So you basically wanted a one shot and possibly the best outcome. So in that case, it seems with the lens vault and one-eyed status and everything, the clear lens extraction seems to be justified well. Yeah. But is there any lens vault parameters that you can use?
I think it has to depend on your population. And I'm not sure what is the population norms for lens vault in South India, but I think in Singapore, we looked at our Chinese population, and I think there are some cutoffs, but usually we say anything more than 1.2 is considered quite high, But again, whether that translates to doing a phaco or not phaco is very subjective. We don't have clear, a criteria. You say this number, you should do a phaco. I think it's quite you have to make a judgment. Yeah, but certainly in those cases that they shared, the lens vault was quite significant, and certainly you should consider doing a phaco because that's the main component to those patients. Yeah, but if you do an ASOT and you find that the lens vault is nothing, then perhaps it is not such a big lens component. I mean, I would say that's one of the consideration. Yeah, but unfortunately, I cannot give you a clear cutoff where you say you should do surgery. Yeah. It also depends on the population.
Right, sir. And also about iridoplasty in that specific case, maybe of that one-eyed patient?
No, I wouldn't do iridoplasty. In that patient with a big lens vault, just take out the lens. Yeah. I wouldn't do that. But anyway, the pressure wasn't high, right? I think, it was high, right? It was high.
It was in the 40s, I think.
Yeah, it was high. Yeah. I don't know, any comments from Trisha?
Yeah. Hi. So the question that I had was why one would not consider using pilocarpine. Because if there was a cataract, I would actually remove it even if it is very early cataract. A 53-year-old lady, generally there is some amount of nuclear sclerosis. So I would be comfortable doing a cataract surgery. But even for that, I think we need to bring down the pressure. The other thing that I would consider, and we quite often use, is pilocarpine. We underestimate the utility of pilocarpine, and initially just the first or second day patients have some amount of headache, and for me it actually helps. I tell them, if you have a headache, that means the medicine is working for you. So they're quite happy to say, okay, yeah, I did have a headache, but yeah, 2-3 days I took a painkiller and I'm okay with it. And once it works, it really works well. And one of the things that we do is, just like how we use pilocarpine prior to the YAG laser peripheral iridotomy, we actually make the patient sit in the clinic and ask them to use pilocarpine for about 3 or 4 times. An hour later, we record the pressures. So we actually see whether the pilocarpine is effective or not even before they go home. So that way we have proved to ourselves as well as to them that it is working. And in the presence of even an earliest posterior subcapsular cataract, I wouldn't use it because it's going to be difficult for the patient to take, and then also the vision will be an issue. So in that situation, then I think I'm quite clear with my decision that I would be able to help them with a cataract extraction. Oppositional angle closure, especially one-eyed patients, I would be very skeptical leaving them alone, because at least in our situation, we've seen that when one eye is lost like this, they go and come back a year later, and this eye also has an advanced glaucoma. So I'm very skeptical to leave them. I generally put them on, even if the pressures are well under control, even if the pressures are, let's say, about 15, 16 or so, I will put them on at least bedtime pilocarpine, so that mydriasis that occurs during the night time also can be taken care of.
Yeah, I agree with Shrisha. And I think that patient had plateau iris as well, so pilocarpine would work well. But unfortunately, that patient also has cataract, PSC cataract. So there are pros and cons, yeah. But certainly, patients with a plateau iris, I do a nighttime pilocarpine is also would be quite effective, I think. Yeah, thank you.
So this patient, for need of time, we didn't present the entire thing. We did do a therapeutic trial in the OP with pilocarpine, and the pressure went up by 4. So that's also been tried. I want to ask you another question. This lens vault, you have a situation where you got a plateau iris and trying to throw a stone in the harness nets with a questionable lens vault. Would you take the lens out or go for a trial?
So the more and more I'm seeing this patient, recently we published our RCT comparing phaco with phacotrabeculectomy. In fact, I would say that that particular study changed the way at least I have been managing the angle closure glaucomas. In fact, this was a very difficult study to do. In the beginning, we had a lot of exclusion criteria. We did not include the ones who were one-eyed. We did not include advanced angle closures. And I also had this opinion that if somebody had a severe glaucoma with central fixation being involved, even in one quadrant on visual fields, I'll have to do a trab and things like that. So in the initial, I think about first 25% of the patients that we recruited and did, and I mean, you can't be masked because you are operating both the cases and you're following them up. So I found that these patients, just like what you said, even if they were on 4 medications prior, their pressures post-operative used to be 10 and 12 off medications. And if you significant angle closure, maybe about one quadrant of angle being open, so the rest of it is senescently closed. So it was a big surprise to me, and I could not explain how. I thought it was, okay, this one-off case and then the second case and things like that. But then the more and more I started doing, I realized that just the phacoemulsification alone, a good phacoemulsification, meaning look, no complications and things like that, is definitely helpful in these patients. One caveat is these patients who have had high pressures, especially those with acute angle closure and things like that, I would definitely advise for a specular before you touch these eyes, even if you're doing a good phacoemulsification, because that's one thing that you never want to get into. Okay, so this apart, I would say lens removal has a huge role to play, even if it is questionable vault. So if the vault is high, it definitely helps, but it doesn't mean that if the vault is not high, it does not help, because you have an oppositional angle closure, or even in a senechial angle closure, part of your angle is still open. It would open up after you remove the lens.
We need to move on. And thank you, Dr. Ong. I know that you got other engagements. Thank you for joining us. We are very privileged to have you. And thank you for your inputs.
Thank you so much. So I hope you well for the rest of the conference and hope everybody enjoys the meeting. Thank you so much.
Thank you. Thank you so much.
Okay, bye-bye. Hope to see you again soon. Thank you.
Yes, sir. We move on to the next case where we managed a failing filter or post-trabeclectomy bleb. I would ask Dr. Harsha to please share her slides and give us the details on that case.
Yes, sir. Thank you, sir. I'll be presenting the second case. It was a 66-year-old male who presented with history of diminished vision in the left eye of 5 years duration. He was already on maximum medical treatment for glaucoma, both eyes from elsewhere. On examination, his best corrected visual acuity was 6.9 in the right eye and 6.18 in the left eye. Anterior segment showed a cataract in both eyes. In left eye, he also had RAPD. IOP was 17 millimeters of mercury in the right eye and 15 in the left eye, and the angles were open on gonioscopy. This is a fundus picture which shows 0.9 cupping in the right eye and 0.9 to 0.95 cupping in the left eye. The fields showed by arcuate scotoma in the right eye and advanced field defects in the left eye. So he was diagnosed to have open angle glaucoma and cataract in both the eyes. As cataract and glaucoma was more advanced in the left eye, we went ahead with a phacotrabeculectomy. On his first week post-operatively, the patient had a well-diffused bleb. IOP was 20 millimeters of mercury, and he was on tapering doses of Predfort 8 times. And second week post-op, we noted congestion around the bleb, and hence the topical steroids were not tapered, and he was asked to review in a week. At third week post-op, the bleb started to encyst and become more localized. And at this point, we tried suturolysis, but the sutures were not clearly visible due to early fibrosis over them. So Predfort was continued at 8 times and was not tapered. At 1 month post-op, this is the clinical picture and ASOCT images, which shows a dense scar formation at the edge of the bleb. At this point, we planned for a needling procedure. This is a short video of the patient. The needling was done under topical anesthesia using a bent 26 gauge needle, which was inserted about 8 to 10 millimeters away from the scleral flap and slowly advanced under the tenons, dissecting out all the episcleral fibrosis. Care was taken not to buttonhole the conjunctiva. And at this point, we can see the ballooning of the conjunctiva and the aqueous seeping out. Now the eyeball has also become soft. Now at this point, the needling is complete. The needle is withdrawn, and 0.1 ml of 0.4 milligram per ml mitomycin C was slowly injected away from the bleb area so that the acidic mitomycin formulation do not enter the anterior chamber and cause damage to the corneal endothelium. 4 days post-needling, the patient had a good diffuse bleb. IOP was 8 millimeters of mercury. And 1 week later, again, the AC was well formed, but shallow peripheral choroidals were noted. The IOP dropped down to 3 millimeters of mercury, and so atropine was added. At 25 days post-needling, the patient had a good diffuse bleb. The choroidal effusions were less in height. The IOP rose to 6 millimeters. These are the pre and post needling pictures where we can see that the encapsulated bleb has now become more diffuse. And these are the pre and post needling ASOCT images which confirm the findings. Now at 30 days post needling, the patient has a diffuse bleb, IOP is well controlled, there are no choroidals, and we stopped atropine. So needling is a simple procedure which when done carefully at many times, we can revive those failing blebs. The ideal endpoint is a good bleb and controlled IOP. Thank you for your attention.
Thank you, Harsha. One thing that I feel is rarely talked about in failing blebs is the amount of congestion and the hiking of steroids. Kiran, what did you say would be the frequency of steroids that you need, and how long would you give the steroids in a routine trap patient?
Right. First of all, I start the patient on quite intensive steroids topically. At the same time, I also sometimes, especially in difficult cases, at the end of the surgery, give a little subtenance of triamcinolone at the end of the surgery itself, after the trabeculectomy. And topical steroids, there is a standard taper, but we see the patients pretty much every week. And if everything is going well, even if everything is going well, I give steroids for as much as 3 months topically. And some people actually give more, some people give for less than 2 months. But I think steroids would be a very important mainstay. And therefore, even in a standard case, I would give topical steroids for at least 3 months in tapering doses, obviously. In cases like this, when you see early signs of encapsulation and early signs of increasing blood vascularity, I think obviously you can decide not to taper off the steroids and even hike up the steroids quite early. But I think in such cases, topical steroids hiking may not have a huge impact once the blood starts to insist. And in such cases, aggressive needling might be required, as was done in this case. This was, I think, done at 3 weeks, in fact, isn't that? Is that right? Yeah, 3 weeks. So my only thing about needling and then subsequently injecting mitomycin or 5-FU is, where do you inject this mitomycin or 5-FU? I think I've noticed that you have done it quite close to the bleb, slightly away, but quite close to the bleb, which used to be my practice earlier, but over the years become more circumspect, and I now do it almost a few clock hours away from the original bleb, though the reports of any of these agents seeping into the anterior chamber is very rare, but it can happen. It has happened to me once. It was 5-FU, so it did not create a huge problem. I could wash it off very early, but after that, I've been very circumspect in giving the antimitotic agent very close to the bleb. That's all.
Dr. Sirisa, I know you also do needling. Is there any way of controlling your needling, in the sense that you do land up with choroidals and things like that quite often? Your immediate post-needling IOP is quite stormy sometimes.
Yeah, I think that is difficult. But I guess we need to anticipate. And yeah, for me, so what I do is on day one, I put them on really intensive steroids. So if somebody's day one IOP is 12, then I know that this needling is not going to work really long. So you see that the bleb is good, but then generally you expect a hypotony in the early postoperative period and put them on intensive topical steroids. In the elderly, I see that they tend to develop choroidals quite often, and young patients, they generally recover very well. There is not much of an issue. And what I do is for whenever I do a needling, whichever port I use, even if it means it's a 26 gauge needle entry, I always tend to close that opening. I never would do that earlier, but then I do it now because of a certain reason, that in the post-operative period, depending on how the bleb is, I advise them a digital massage, not in the early post-op. So by about 5th day or 1 week, when they come back, based on how the bleb is and based on how the pressures are, if I see that the bleb is elevating just with a little massage, then I just leave it there, or the pressures are on the lower side, I don't tell them. But so let's say pressure builds up to 10 or so, and I know that the bleb is not very well elevated, then a digital massage actually helps. I ask the patient, I teach the patient by about a month or so, for about a month after the needling. And after that, you see that the bleb, I think the track is quite well formed and they do very well in the long term. So for that reason, I have seen that once when I did that massage, from that area of the tiny conjunctival opening, I could see a leak. So I just don't want to have that problem. So I use a 10-091 needle there. And I agree with what Kiran said, that I would also use mitomycin 0.04% and above, so not from the same incision. So I use a different needle and a syringe and do it about 3 or 4 clock hours away. So that's the only difference. And we cannot control needling. Needling is an all or none procedure. So it happens, and then hypotony is expected. Rarely, I've also had terrible hypotony on table where I had to open up the conjunctiva and suture the flap, especially if it is a single suture early post-op. So just fibrosis around the flap, and when you cut it, there is so much of a fluid that drains. And if you have already cut that single suture that is there, very difficult to control the hypotony. On table, severe hypotony, then I tend to use one releasable or one additional suture just to make sure that you don't end up having serious problems.
So, madam, would you then take up the case for needling under topical anesthesia? Because rarely, if you do have to consider opening up the flap.
Yeah. Yeah,
so,
under topical anesthesia. So this situation where I had a lady who required resuturing, I could manage it just about a little bit of Loxicard subconjunctivally should help. And she was very cooperative for me. So what I took in between two cases, thinking that this will be over and then, I can take up a big case, I ended up spending about 45 minutes having to manage that patient. And fortunately for her, she's about 7 years post needling. She still controlled pressures in that eye. So sometimes they can be very difficult.
The other question is, how much needling should you do? In the sense that, for example, in this case, it was 3 weeks. The moment you entered and started breaking up the subconjunctival adhesions, you could actually see the bleb forming. If that is not the case, and the bleb is not forming as well as you expect, and the pressures are not going as low as you are hoping, would you then obviously consider going under the sclera also to enter the ostium? I mean, how much do you want to do that?
Yeah, so I think yes. So first, subconjunctival fibrosis is cut, and all around the area of the scleral flap, I tend to clear up so that I also want a diffuse bleb. And once that itself helps the bleb to form, like in the early postoperative period, as was seen in this patient, then I don't go under the scleral flap. Otherwise, it's under the scleral flap. And you actually, each of us who's doing a needling realizes that when we cut the suture or when we lift the flap, that the bleb forms. If that doesn't help, I go into the anterior chamber. I do that, and the only problem when you do that is sometimes when you enter to the anterior chamber, microhyphemas is not uncommon at all. So there is a reverse flow of fluid, so that can occur. But that apart, in fact, how late can you take it up for needling? I've taken up patients 10 years, 12 years later also after trap. So the longer it is, just the subconjunctival dissection will not help. The longer it is, then once your ostium is patent, of course, that we will anyway check pre-op, that you require to go into the anterior chamber. Rarely, one additional thing that I do is also if there is sometimes there is a pass which is formed, or the pupil is peaked in some cases, especially in children, because of overfiltration in the beginning and then later they sending. So I also make a side port and then try to do the remove, synecholysis in that area. So that also helps the fluid to drain well and helps to stabilize the pupil and also remove that, the peaked pupil and make it round and comfortable for the child. Otherwise, sometimes it's peaked and then they get to have some kind of a chin elevation and things like that. So that helps in children.
Thomas, you're muted.
He's muted again.
Thank you, Sirsa. I need you to give the final remarks after the algorithm is presented. Dr. Meena, please present the algorithms as we have it now on both the cases. Please share your screen.
A very good morning to the esteemed faculty, my colleagues, friends, and dear delegates. Moving on to the algorithms and managing the two cases presented today in this session. In the first one, we just listened to what Dr. Roshni told about two patients who, despite a patent laser iridotomy, the IOPs could not get controlled. So in general, when in angle closure, primary angle closure disease, gonioscopy is the most important thing. A good gonioscopy will reveal the angle status. And that not only determines the classification of the disease, but also determines the further management of the disease. In the set of patients classified as PACS from the ZAP and the analyst trials that Professor Ong listed, we know that laser iridotomy is not mandatory, but should be done in the highly select patients, like those who are not available for a follow-up, those who are diabetics need a lot of dilatation, and those whose fellow eye has had an acute closure. While coming to the acute symptomatic PAC or the chronic asymptomatic PAC, like it was discussed, laser PI is mandatory, but post PI, you have to document the Sine-K. If it is appositional, it will open up. And if it is Sine-Kill after the PI, a lot of it may not be open up. So you have to follow them closely. And Professor Ong brought in the concept of in the open to do with the concept of iridoplasty. And in those who are close to think of a phaco versus phaco with goniosynovitis having similar outcomes. Now moving on to our case, which is both of which are PACG, and wherein the IOP after LPI, the IOP was not controlled. So after the discussion, we came to the conclusion here that you have to think of the synechiae. You have to consider lens parameters like the lens thickness, lens vault, anterior positioning of the lens, the iris configuration, the anterior insertion of the iris, and the rotation of the ciliary body, which you can, that is the plateau iris, which you can detect by gonioscopy and document with UBM, and the presence of any cataract. So coming to them one by one, if the IOP is controlled and there is no Sine-K and the other parameters are okay, you can just afford to follow up. But if the IOP is, if there is Sine-K, depending, medical treatment has a place, and Professor Ong has shown us the difference with latanoprost and prostaglandin analog effects. So add medical treatment, and if the Sine-K is less than 180, consider lens extraction in angle closure disease group. If the Sine-Kill closure is more, consider filtering surgery. The concept of high lens vault and the benefits of lens extraction was discussed in the discussion. Coming to plateau iris, as well as in pupil block cases like Dr. Shirisha and Professor Ong agreed upon, is the use of nighttime pilocarpine and other medical treatment options. Iridoplasty not useful in Sine-Kill closure. Any cataract, we again discussed, even if the vault is not high and there has some, but even if there is some Sine-Kill closure, benefits from early cataract surgery. Coming to the post-PI uncontrolled IOP, if there is cataract, go ahead with cataract surgery. If there is no cataract, go for aggressive medical treatment. Sometimes IOP will get controlled because the timing of cataract surgery in such eyes, as we already discussed, that post-acute angle closure attack is not the right time to remove the lens because of the added issues due to inflammation. If the IOP gets uncontrolled, Professor Ong also suggested about the role of SLT, but again, he said that less than 20% may not benefit. So coming to the lens vault, we already discussed, consider lens extraction. If there's Sine-Kill closure, depending upon the extent of GON and extent of IOP, either consider trap or combine it with cataract and trap, cataract with, that is phaco trap. So as a footnote, in angle closure, consider lens extraction early. When there is very high IOP and advanced disc damage, add a filtering surgery as well. Just for the information of the delegates, if they want to know in a horizontal ASOCT, what is this lens vault? The line joining the nasal and the temporal scleral spurs, that the line drop from the posterior corneal surface is the lens vault. The AV stands for absolute vault, which is lens vault, plus the anterior chamber depth. So this is a concept which has evolved and has promoted early cataract extraction in angle closure disease subset group. Moving on to the second case. Here, Dr. Harsha presented a patient post-trabeculectomy who was having high IOP, and so you can have either a diffuse functioning bleb or you can have a flat bleb. So a flat, you have the most important thing is to look for early signs of a failing bleb. Look for look for the corkscrewing of the conjunctival vessels. Look for a rise in the bleb with massage. So digital massage is the most crucial step. If with digital massage, if the bleb forms, you can continue the digital massage for 2 weeks. And at the end of 2 weeks, if the IOP is controlled, it's fine. Just follow up the patient, but continue massage. But if after 2 weeks, the bleb doesn't form and the IOP is not attained, try releasing the releasable suture or doing a laser suture lysis. So all this was done in this patient presented. And after the laser suture lysis, if the bleb does not form, you have the option between subconjunctival 5-FU injections or needling with mitomycin C. So here we have seen, and if the needling fails, like it was discussed, you can needle again. If you have a well-formed bleb, on the other hand, in the postoperative functioning bleb, postoperative period, IOP rise, you can think of chronic inflammation and steroid responder effect and manage medically. So with digital massage, if the bleb does not form, gonioscopy is the key. Do it and look for a block occurring at the internal ostium. This is again to highlight that it is established, like Dr. Shirisha said, it is established that needling, the upper limit can go on to late fibrosis at any level, several years after the primary trap. But it is the needling in the intermediate and rather early, where in this case it was done at 4 weeks, the benefits were observed. So needling is a very useful procedure in the early and intermediate postoperative period. And a lot of modifications in the technique have been discussed in this discussion today, using mitomycin C 0.004%, changing the needle and injecting a few clock hours away, suturing the site, and advocating digital massage for a month or so after needling for good results. Flat bleb in the immediate post-op, please do look for tight sutures and continue massage, and also do a gonioscopy to always rule out that the ostium is patent, because only if the ostium is patent, your needling will work. Again, needling in the late stages will need additional maneuvers like entering the anterior chamber as well. With this, I think the salient points in today's discussion have been covered. Once again, to say the digital massage is critical and needling effectively rescues an early fading bleb. And this is just an article which has come up from the institute that our guest faculty, Dr. Shirisha, has come from, to show in their paper publication, they have shown slit lamp needling with adjunctive mitomycin in Indian eyes. Thank you.
Dr. Shirisha, can you give us any closing comments?
No, I think Dr. Meena put them up very beautifully, and I think it's covered most of what we wanted to tell. Thank you. Thank you so much.
So that brings us to the end of the session. Thank you all. Thank you, Dr. Shirisha and Kiran, especially because you're outside the institution. Thank you once again. It was a very fruitful session. I'm happy with how it's gone. Thank you all.
Thank you so much. Yeah. Have a good day.
Thank you, Dr. Thomas, and all the faculties. That was a very enlightening session. That brings us to the end of the glaucoma session. Next, we have the final session of Synoptic, the cataract session. I invite Dr. Matthew Kurian, Senior Consultant, Cataract and Refractive Services at Chaithanya, Cochin, and Dr. Minu Mathan, Senior Consultant of Cataract and Refractive Services at Chaithanya, Trivandrum, to moderate this session. Over to Minu, sir, for the introduction of the faculties.
Good afternoon, everyone. And let us start straight away this session on cataract. This will be for 2 hours. And we have a stellate panel along with us, and it is my great privilege to introduce each one of them. Can you see my slides?
Yes.
Okay, so it's my great pleasure to introduce Dr. Ron Yeo. He is a clinical associate professor at Singapore National Eye Center, and he was a past president of APSCRS, and he is in the board of the American Society, the Cataract Committee, Program Committee of the ASCRS, and he is a elected member of the International Intraocular Implant Club. Welcome, Dr. Ron. And
Hi.
then our next keynote speaker is Dr. Partha Bishwas. We all know him. We don't need any introduction for Dr. Partha. He is the Chairman Scientific Committee, AAOS, and he is the Director of BBI Foundation, Calcutta. He has, from Colonel Rankachari Award, numerous national and international awards and publications, and his I would say world famous court martial in ophthalmology, which he has conducted all around the globe. Welcome, Dr. Partha. We move on to our third keynote speaker is Dr. Chitra Ramamurthy. She is the director of the Eye Foundation group of hospitals from Coimbatore, and she presently is the chairperson, academic research committee of the AAOS, and she also has received numerous national and international awards, and is a pioneer in refractive surgery and also a leading cataract surgeon in Tamil Nadu. And we know her in the academic field. She has been so active after she has become chairman ARC. So many programs have been conducted back to back. Every other week we have her intense programs which are so scientific and knowledge imparting. Welcome, Dr. Chitra Ramurthy. And we have in our expert panel Dr. Sudarshan Kumar Kokar. He is a professor in charge of the lens clinic services in RP Center, AIMS, New Delhi. He is an expert in pediatric and complicated cataract surgery and refractive surgery, conducted multiple courses at American Academy, ESCRS, APO, and over 80 index publications and different chapters in different books, and more than 25 years of teaching experience at the AIMS. And he has many new and novel techniques which he has published, and welcomes her to this program. And again, we have Dr. Ramesh Durayarajan. He's a great friend, he's a great person, very dynamic cataract surgeon, very innovative ideas. He works in Chennai, and he has films which are very innovative and thought-provoking, which he presents in multiple conferences, and I like so much discussing with him about the finer details of cataract surgery. Welcome, Dr. Ramesh Durayarajan. And this program will be moderated by Dr. Matthew Kurian, Medical Superintendent of the Chaithanya Institute, Kochi, and co-moderated by me. So without much ado, I think we will pass on to Dr. Matthew Kurian for the rest of the course.
Thank you, Mino. I now call upon Dr. Ronald Joe. Thank you, Ron, for joining us. And I would request you to deliver your keynote on cataracts from a different angle.
Thank you very much, Matthew. Vanakkam. All my friends, I miss all of you in India. You know, I used to go to India many times every year, but you'll have to make do with Zoom for now. But I look forward to joining you guys very soon. Thank you very much for inviting me to join you in this meeting. It's my pleasure to really speak on this topic, which is very dear to my heart. Let me get myself organized here. Okay, so I'm going to talk on the topic of cataract from a different angle. Now, we're all familiar with this microscope down view of a cataract eye when we're operating. But as you all know, the eye is a three-dimensional structure, and actually, eye elevation view may actually be more useful. Now, several companies make live online OCTs on their microscope, but you know, these inbuilt live OCTs were originally designed actually for corneal and macular surgeons, and not really for cataract surgeons, which is an underutilized thing. I really want to explore the uses of IOCT in cataract surgery, and I've been doing this for a few years now. And whenever we're using a new imaging technology on the eye, we really need to appreciate the normal surgical anatomy. And here we see the normal anterior capsule very clearly demarcated on the right. We see the posterior capsule is just as easily shown. We can see cortical cataracts. You can see those lamellar structures easily on the OCT when you correlate it to the cortical opacities on the left. What about nuclear sclerosis? Can we see it? Well, indeed we can. If you look at this on the right, you can see that the center of the lens is much denser than the periphery. But it's really looking at the posterior capsule that it becomes more interesting. When you have a PSC cataract, as you see here, we can see the thickness of the opacity there. And you can also compare it with what a posterior polar cataract looks like and whether it's gone through the posterior capsule or not. Here, I'm grateful to my friend Jiwan Titiyal from Delhi, who lent me these images on pediatric cataract posterior polars. And in this posterior polar on the right, you can see that the posterior capsule is actually intact in the sort of posterior capsule curvature. But this next picture shows that the polar cataract has actually gone through the posterior capsule here. So it's actually quite useful to help you decide how severe this posterior polar is. We can actually also image Mittendorf spots, as you can see here. But really, let's ask the question whether intraoperative OCT is useful as a surgical aid. Now, I can't cover all the sort of different steps of cataract surgery, but we'll cover several of them. Now, the first area where I found IOCT useful was really in helping me understand hydrodissection better. So if you look at this, this was one of my early cases, and you look at the two images, particularly the bottom right image here, you will see as I start the hydrodissection very gently, you will see a thin sliver of fluid coming in on the bottom right and upper image. There it is. You see on the bottom right, that sliver, and the top right, also that sliver. That was a small hydro. Now I'm going to complete it by injecting much more fluid more rapidly, and you see that that narrow gap opens up really widely. And at the same time, this, of course, lifts the nucleus upwards, which we're going to see here. Now, one of the things I teach my residents in terms of hydrodissection is that if you've got a good hydrodissection, the nucleus comes upwards. And this helps us understand why that is, because when you see that wave widen up dramatically like that, that's why your nucleus lifts. And when you push the nucleus down, as you will see here, you will find that that gap disappears, and that actually helps complete hydrodissection. Now, we also know that in soft cataracts or polar cataracts, we like to get this golden ring we see on the left, and on the right, you see what that actually means. It means that you have actually isolated the nucleus into that golden ring, making it easy to remove that nucleus en bloc without disturbing a posterior polar, for example. Now, many of us were aware that Howard Fine, many years, 20 years ago, taught us that cortical cleaving hydrodissection, in which you've cleaved away the SLM, means that after phaco, there is no need for IA of cortex. But, you know, I've tried for many years to effect this consistently, but it's very hard to achieve. And the reason is, you know, even though I'm injecting subcapsularly, as I think in every case, you can see on the right image here, although that's my plane of fluid, there's still always a little layer of cortex there, and it's actually very hard to get that separation that Howard taught us. So the second area where I'd like to look at in terms of its use is really in nucleus management, the depth and width of sculpting. Now, this is, of course, something not for the experts on this panel, but for the beginning resident who is always worried about, are they deep enough? Are they long enough? Is the shape of the trough adequate? So when you do this and you turn on the OCT, you can see on the right-hand side, there's a trough that's nice and deep with only a little bit of nuclear material left in the base. And the bottom picture shows the shape of the trough, which is a nice one. And showing this, I can tell the resident, this is when you're ready to crack. And when you crack, you will see here on the top picture that the crack will extend down to the posterior capsule there. You can see that gap there and the posterior capsule just behind it. So I think it's very useful as a teaching tool for residents in helping to understand how to do a groove properly. And here's another example of a cracked nucleus plate. Okay, the next area which I looked at is really how the IOL is related to the posterior lens capsule. You know, is the IOL in the bag? How much OVD? Do you need to remove OVD? Now, when an IOL is first injected into the eye, you can see it sits on a bed of OVD and it's tilted often. And this is, if you don't remove OVD, this is how much OVD that can be left in the bag. And after you've removed it, you like to see this really contact between the lens and the posterior capsule. Now, here's a case in which a trifocal lens has been implanted, and some surgeons remove OVD only from the front, saying that in a cohesive OVD, it'll come out in one big glob. But here, only front removal has been done, and you can see a lot of OVD still there. And only after I go behind the lens and remove it, do we get this nice contact, reducing the risk of toric rotation. This also shows us whether the lens is in the bag, and you also see how close the lens is to the posterior capsule. A quick word or two about incisions and its architecture. Here's what a side port looks like at the end of IA. It's actually not too bad. And with this fairly good apposition, just a simple massage means that you can close this side port very easily. Because if you hydrate an incision, you get this very swollen looking side incision. Looking at a main incision, you can just see this virgin main wound. In other words, I've just made the incision, I haven't done anything through it, and you can see that the wound apposition is beautiful and there's no issue here. But at the end of surgery, it looks very, very different. you can see here in the top picture, there's a gap in the incision, and you can actually see the iris is way up against the back of the cornea, perhaps better seen in the bottom picture where the inner lip is gaping and the iris is up against the incision. So for this, you need to hydrate it. And after you've hydrated it, you can see that those gaps almost disappear completely and the iris is pushed away. So if you don't hydrate a main incision, it looks actually quite nice. But if you do have to hydrate, you end up having this dumbbell looking incision at the top and at the bottom. So that's our standard cataract surgery. What about its use in complications? Now here, when we remove the phaco tip, we quite often see the posterior capsule rise forward towards the cornea. And you can see here there's cornea endothelial touch with the posterior capsule and cortex. What's worse is when after removing OVD and removing the IA tip, when removing OVD, the IOL will come forward and actually hit the corneal endothelium. If you have an anterior radial tear, and you can see here whether your lens is properly in the bag or not. And here I'd like to share with you my experience of OCT imaging of the posterior lens capsule, and in particular, share with you a new sign. And I'm going to concentrate on posterior capsule rupture. We're all familiar with the awful feeling when we see a PCR on the microscope. But what of the IOCT view of a PCR? So for many years, I didn't have a PCR and I couldn't image it. I got frustrated. And finally, I had a case in which I needed to do a primary capsulotomy because of fibrosis of the capsule. So I did that primary capsulotomy, just a little nick in there, and opened it up. And then we turned on the OCT to see what the edges of the PCR would look like. And you can see here in the top right picture that the edges of the PCR are clearly seen, and they are slightly everted and slightly rolled. So I was very pleased with that. Now, of course, having wished for some PCRs to image, and not having for so many years, my wish was granted shortly after that. So I had a couple of cases here in which I just went to remove the OVD from behind the lens, as is my normal routine. Excuse me. And shortly after I removed the OVD, and as I was coming out, I noticed that line. And I think you can just about see that line going right across the eye. And I said, oh dear, this is a PCR. And the lens was already in the bag. So I just sort of prolapsed the lens forward above the capsular rectus opening. And here, if you look on the right, what's the appearance of this large tear? You see there's a little scroll here in the top picture on the top right. And you can see that the lens is above the anterior capsule there because I prolapsed it forward. There you can see the scroll in the top picture. Okay, we'll look at this. And at the bottom picture, you can see that the edge of the tear actually rolls up into this very distinctive scroll-like shape. So I thought that was quite interesting. And here you see it better in both cuts. Okay. So this is what I call the scroll sign of PCR on using the OCT. And of what use is it? Well, we had this other patient who was stung all over his body and eye, and actually had corneal melt and endophthalmitis, vitrectomy, and then we had to do his cataract surgery. And here you see that the view of his lens and all that was very, very bad. And I was doing the IA when I saw that dreadful line. I think you just make that curved line above my IA piece. And I was operating with Donald Tan at this time because he was taking care of the cornea. And I said, I think there's a PCR. He says, I don't think it's a PCR. I said, well, let's turn on the OCT and see what the OCT says, because the view was bad. And you see in the bottom picture, you see that scroll there. I'll show you a still image in a minute. So having found that it was a PCR indeed, I put the lens in the sulcus and did a capture of the optic. And here we can see that the lens optic is actually in the bag, while the haptics are in the sulcus. And here is the sign that I saw confirming the presence of a PCR. Now, how do we know that these lines behind an IOL aren't a PCR or just a fold? Here we see two lines that are suspicious looking. And on the OCT, you can see the continuous posterior capsule. In other words, there isn't a break. It doesn't end in a rolled up scroll, but you got that little fold there. And of course, when you push on the optic, as you see on the left, those folds disappear. And that's one way you can distinguish a PCR from just a crease in the posterior lens capsule. Okay, so this is the sign that I'm just suggesting to you that if you have an IOCT, it's a pretty useful sign. So I think it is a pretty useful surgical aid confirming PCR and also confirming IOL capture. I'd like to share with you this last case before I end. And this is a 50-year-old highly obsessive myopic patient whom I lasered a left retinal tear. But then he was very bothered by his floaters. So I did YAG laser vitreolysis on each eye, and he was unhappy after each time. So I had to repeat it and repeat it. So I did 3 times in each eye for 2 months until I finally told him, I think that these floaters aren't really going to be disappear. Leave it alone. See me in 6 months' time. Unfortunately, he came back a month later, and I saw his vision had dropped in the left eye to 660. And I was telling myself, oh God, what have I done to this fellow now? And I was about to apologize to him and say what's wrong. And he apologized to me because he said that he'd gone to seek a second opinion for his floaters. And somebody else had further YAG laser to his left eye. And after the YAG laser treatment, the vision blurred at once that same evening. Here's his good eye, and here's his bad eye, the one that had been lasered. And you can see that there's posterior subcapsular opacity, the 2 suspicious looking lesions there. And so I suspected that the YAG laser had actually hit the posterior capsule. I wasn't sure, of course, but you know, it was highly suspicious because of the rapidity of the development of cataract. So here I'm with him in the OT, being very suspicious, and I turn on the OCT, and if you see that, you can see on the right-hand side of those images, clear breach of the posterior capsule in one area that we can see there, and I'm going to move the crosshairs to a different part of the lens to check, and I believe that there was one other area here on the left. When I move my crosshairs over, there's another puncture. So I reckon that there were at least 2 ruptures of the posterior capsule from the laser. So I'm sorry, let me just move this on a little bit. So during surgery, I noted that the lens matter starts going down. And here you can see there's the posterior capsule has opened up. Luckily for Juan was forearm, and I had prepared him for the possibility of needing a vitrectomy. And because of the dropped nuclear fragments, we carried out a transpars planar vitrectomy to clear the gel there and retrieve the nuclear fragments that had dropped. And ultimately, we were able to put a lens into the sulcus and capture the optic through the intact capsular rhexis opening. So this is the picture of what we saw. And so the moral of the story is beware of YAG vitreolysis in the phakic eye. Okay, so at the end, I would just say that live OCT is useful. Let's repurpose the technology as a teaching aid, as a research tool, and as a surgical aid. Thank you very much, and I'd like to welcome all of you to next year's APACRS 10th June in Seoul, Korea, and COVID permitting, it'll be a physical meeting. Thank you so much.
Thank you, Ron. That was an excellent presentation. Truly, now we can look at cataracts as a 3-dimensional structure and not just an on-force view. And you have been able to illustrate beautifully with your videos the new insights that 3D OCT gives us during cataract surgery. And like they've said in the past, what the eye cannot see, the mind doesn't know. This is truly an interesting and unfortunately currently very expensive technology to implement in routine clinical practice. Mino, any questions from your side?
Yeah, nothing. That was quite new, and this has been shown for the intumescent lens and the anterior capsule and the posterior capsule also when in posterior polar cataracts, but the intraoperative one and the scrolling back is really new. And thanks for that. Very enlightening. And I take this opportunity to,
It's expensive technology, but I think if you're in an institution where your retinal surgeons, your corneal surgeons, and then your cataract surgeons use it, then it becomes more manageable in terms of a teaching and research.
True, very true, sir.
And I would like to welcome Sudarshan, sir. He has joined. We were not able to welcome you when you were not there. So carry on, sir. Please, please.
I just want to add on something. Ron showed very well. In fact, I do lots of pediatric cataracts. So we've got 2 machines at the epicenter. One is dedicated for the pediatric cataract. So when you're doing the posterior capsular rhexis, you can actually see the patient There's a certain set of patients which is the herniation of the vitreous through the opening. So the moment you make the posterior rhexis, in the certain sets, you don't have it. So that means there's a liquefaction of the vitreous, and that can be very well picked up on the IOCT microscope. So I got one IOCT dedicated to my pediatric cataract patients. And I agree with Ron, if your institution allows, if you have money, one should have at least one machine and use it, because it just shows you the things where you can't go. I mean, you can't visit otherwise. So I think one should have it. Of course, the money permit. I mean, the economics is not the issue.
Sure.
Thank you very much. We'll now move on to our next keynote. Welcome, Dr. Partha Biswas. We request you to proceed with your keynote address on cataract surgery in post-refractive surgery eyes.
Thank you very much, Chaithanya Eye Hospital, Minu and Matthew. Thanks a lot for having me in this program of yours. And it's been wonderful listening to Ron. And Ron, thank you very much for the invitation. But I must say, I returned that invitation, and you have to be here in Mumbai for our AIOC, which we will have possibly by June, definitely. So you have to promise that you will be with us in Mumbai.
You can't pull me away, Partha, for one of your meetings.
Thank you. So today we would like to discuss about the post-refractive surgery, the cataract solutions. And this is actually a challenge every one of us is facing, and more is yet to come, because the number of refractive surgeries are increasing in numbers, and thereby when it comes to the cataract, the challenge to the cataract surgeon is there, because let us remember this patient has been used to spectacle independence and can have these unrealistic expectations. And where we are faced with the problem is the current biometry formulas. Are they accurate enough? Have we reached the zenith? Yes or no? Let's see. So the traditional formula, of course, lose their accuracy in these patients, and the post-myopic refractive surgery patients end up at times with post-operative hyperopia, and that's a crisis. And then we need to deal with these very unhappy patients and do what is required. And post-refractive, the post-hyperopic refractive surgery patients can end up with post-operative myopia. This again is a problem. So let us quickly look into the sources of the error. And the most important source is the corneal measurements that are taken from the central 2 or 3 millimeter zone, which has been flattened after keratorefractive surgery. And there, the assumption that the spherocylinder cornea leads to an overestimation nearly by 15 to 25%. And the relation between the anterior and the posterior cornea becomes altered, and therefore the assumption of the refractive index also becomes quite fallacious. So we have errors in the formula. However, the new generation formula utilized the relationships between the K and SCT and the estimation to help in the ELP. And with this, the underestimation of the IOL power causing the post-operative refractive hyperopic surprise is something that is evident. So what formulas do we use in these patients? So the historical method is actually a history now, and we have discarded it. The double K method also is quite not very well taken up. The ASCRS online, and this is a very important, and it is freely accessible in the website, and multiple formula are available. Also, the average of all the formula is also displayed. So this is an important formula, but I'm going to give you an example where there can be a fallacy even in this. Tomography is again very important and helpful in analyzing the anterior as well as the posterior corneal curvature, which are altered. The intraoperative aphakic calculation. Now, this I would like all of you to spend just a minute on this. A simple on-the-table retinoscopy after extracting the cataractous lens when the eye is aphakic can give us a very accurate estimation of what the right lens could be. Of course, we have the intraoperative aphakic aberrometry, which also is important, but the limitations include the alterations of the IOP, patient fixation, and the pressure of the speculum. ELP prediction, of course, is not very accurate. Now, this is what I do for all my refractive surgery patients when I'm doing a cataract surgery for them. The cataractus lens is out, the patient is aphakic, and my best optometrist comes in and does an on-table retinoscopy. And then on his calculation, which of course the aphakic retinoscopy needs to be doubled and a little leeway given to have the patient a little on the myopic side, that power is checked and that is taken into consideration with the calculations that we have always made. So with that, as of now, we have not got a refractive surprise post-cataract surgery in these patients for the last 10 years. So I would really request all of you to have the simple tool in place so that the surprise element is not there. The preoperative counseling is very important, and the importance of the patient understanding that it might not be possible to get that very, very clear, crisp vision without glasses might not be possible. So that a patient has to accept. A presbyopia correcting IOL, could it be a correct choice in these patients? Really not, because in these patients, the chance of error and the possibility of the error happening is much larger than in a normal patient without a refractive surgery. And there could be the possibility of a residual irregular astigmatism, and this needs to be discussed as well. So let's look at the intraoperative challenges that we have. And this is a post-RK eye. And in this eye, we have these multiple incisions, and thereby what we need to do is to have the incision on the scleral aspect. The scleral incision is such that it will not penetrate into the already RK incisions. You could see that side port incision that I'm making very gingerly is in between those two radial cuts of this hugely numbered incisions of the radial keratotomy that this patient has undergone. But the main incision definitely needs to be in place in the scleral part, unless a 2.2 millimeter incision can go through between these radial incisions. So after this is made, and then of course it is usually quite a simple happening. Usually these cataracts are not very hard, and the nucleus management and the rest of the surgeries are not so difficult. So once this is done, it is important that the parameters of the phaco emulsification procedure has to be in the low parameters, and the importance of seeing that the RK incisions are not opening up is important. Some systems which have an IOP control is very, very useful in such cases. And it's important to remember that it's a thin diaphanous posterior capsule that we are dealing with, and we must have proper precautions while dealing with this. Even at times, one of the RK incisions might open up. If it opens up, these RK incisions definitely need to be sutured. Otherwise, you'll end up with a very large astigmatism. With the intraocular lens in place, things are much better. And then once again, our optometrist comes in and does a cross-check of the retinoscopy on the table once again, just to make sure that the surprise is not there. And if he gives a nod, which in 99% would be so, then this lens stays and you do not have a post-operative surprise. So what I was saying is here in this photograph, the RK incision has opened up, and it can be quite a difficult incision if it opens up, and it might make the phacoemulsification difficult as well. Now let's look at this mystery case, and this is a 43-year-old lady who presents with her husband with diminution of vision. She says that there's no medical or surgical history, and then we plan a phaco with an intraocular lens, and we do all our biometric calculations, and then ultimately she's all booked for surgery. And then later she comes alone to say that some 19 years ago, she had a surgery in which to remove the thick glasses that she was wearing. And we do a pentacam at this point of time, and we see that, yes, there is a marked flattening of the anterior cornea. Then we go on to our calculation, and we see the calculation and look at the calculation that we have, the average IOL power with all the available formula, and we get an average of 12.17. So we are now in a fix. So when we do the surgery on this particular patient, my optometrist says that, no, sir, I would not accept a 12 in this patient, not even a 13. What he says is, with my retinoscopy, this patient should get a 15 diopter lens. So I'm in a fix, but I go with my trusted optometrist, and we put in the 15 diopter lens in this patient and look at the postoperative result in this patient. So it is just a 0.75 with a 1 diopter cylinder, and that's it. So the formula, the ASCRS formula, was overridden by our optometrist's assessment, and we still go ahead with this assessment even today. Now, post-LASIK phacoemulsification, one another thing that has to be kept in mind is the flap and the hinge, and the corneal incision has to be planned well, and therefore the flap should not be disturbed because the possibility of the epithelial ingrowth could be there. Now, post-ICL phacoemulsification, and the ICL is a very thin structure and therefore does not really affect the biometric calculation, and refractive surprises are not really seen. Let's look at this quick video, and this video is of a patient, quite an interesting patient, and had an ICL and got back 6/9 vision post-operatively. But 9 months down the line, he presented to us with a retina detachment, and the retina detachment was fixed by our VR surgeon. And but 3 months later, this patient again presented with loss of vision, and look what has happened. So we knew what would have happened possibly there would have been a lens touch, and so the ICL has to come out of this patient, and which is not a very difficult proposition, but you would note that there are certain amount of synechia to the lens, which usually does not happen. So could anything go wrong? So we removed the lens hand over hand, and that is not so difficult a proposition. And once the lens comes out, the rest of the part is the more important part. So we stain despite the viscoelastic after washing off the viscoelastic, and we get a more or less a good stain for this patient. Now, the capsular excess is important, and I know I could be in trouble. And we milk out the excess of the fluid, decrease the intralenticular pressure, and now with the high molecular viscoelastic, I'm going ahead to do the anterior capsular excess, not doing it too well, and not very happy with because now I realize there's an amount of thickness of the anterior capsule, and very, very gingerly I'm trying to complete it. But now look what happens. The anterior capsule runs out, and not in one place, but in 2 places. So we have the anterior capsule run out in these 2 places. It's a cataract that is not very hard, so we need to get this out. But I'm also remembering the fact that there could be a posterior capsular dehiscence in this patient. So if the posterior capsular dehiscence is there, then we definitely need to take a call. And of course, the pupil now is coming down on us. And what we find is there's fibrosis there in the posterior capsule. So removing all the cortex, remembering the fact that this patient will not get back good vision unless that fibrotic element is taken off and we clear up the central part of the visual axis. So what we do is, now what lens to put in? Of course, we don't have a proper bag. Therefore, we put a 3-piece lens, and this is placed into the sulcus. I hope it is in the sulcus, but I cannot be sure at all. So once the lens is placed inside the sulcus or in the bag, so the next part would be to remove that part of the fibrotic element. So if this fibrosis has to be removed, it has to be done very, very gently. We can do it through the posterior route. Also, we can do it through the anterior route. So we did it through the anterior route in this case, lifted up the IOL, and with the MVR, we make an opening right in the center of this fibrotic capsule. And with the central opening made, then we need to remove that amount of the fibrotic capsule beyond, not going beyond the perimeter of the fibrosis, because once we go into the clear posterior capsule, we might end up in ripping this posterior capsule and thereby completing the anterior capsulorhexis run out to the posterior capsule and thereby losing the whole bag. So we do this, and God willing, we stay within the precincts, and we create this opening in the posterior capsule, and which is good enough to get back. The patient got back approximately 624 vision, of course, dropped by about 2 lines, and the near vision was just about N10. So these post-operative challenges are there, the small residual refractive errors to be managed either with glasses or contact lenses. If there is a large refractive error, LASIK or PRK may be offered if the parameters permit, and the piggyback IOL or the IOL exchange is an option reserved for the large refractive errors. Thank you very much for your patient hearing.
Thank you, Partha, for that beautiful and extensive coverage of the topic. As usual, there was very great clarity in the thought process and in the suggestions for management. Thank you.
So can I ask one question on this, sir? What do you do the retinoscopy on the table after placing the IOL or before placing the IOL?
Both, Minu. Both before placing the IOL, and thereby the IOL calculation is made. So if he gets a retinoscopic reflex of about 10, so it is doubled, so 20, and push it a little to the myopic side. And then after I implant the lens to be 100% sure that the surprise is not there, so he does one more retinoscopy to say that yes, things are fine. Of course, if it is an RK incision, we do not actually take up the cylinder part unless it is very, very high. And if the cylinder component is very high, then at times we need to find out whether we need to put in a toric lens to debulk the cylinder. But I've done it in 1 or 2 cases, but stopped after that. And if it is a very large cylinder that I have to tackle post-operatively, then we tackle it with a piggyback lens, which is a better proposition, more accurate as well.
Poker, sir, you are about to tell something.
Yeah. Do you have time? Can I take 2-3 minutes on this? Okay, sure. So starting with the first one, like he said, Aura is a good option. Again, as Ron said, it's an expensive tool. And we are doing a study at the RP Center in which we just published that Aura does not mean that patient has to be topical. So we picked up a group of patients who were post refractive surgery and they wanted block. The soft cataract, but they wanted block. So we blocked and unblocked patient. We matched and both the data was same. So Aura can be done. And Aura basically is depending on the lower order aberration. So spherical and cylinders only. It doesn't take into consideration pistils, comas, and all those. So basically it's a retinoscope, which is expensive retinoscope. I mean, you can just do the retinoscopy and get away with that. Okay, so we are just finishing a study on a pediatric cataracts in which we're using Aura. And you'll be surprised, I think once I published it, we'll decode it that time, but it works wonderfully well. It's an expensive thing. I don't suggest anybody to buy it, but let's wait for the results. Now coming to the RK, radial keratotomy has taught us too many things. First, it has taught us the geometry back again, that 2 pi r is the circumference. So 2 and pi is 22.7, that is 3.14678, and r is the radius. So if you take the number of incisions which are given, 2 pi r divided by the number of incisions, it's 8 incisions, 16 or 32. The moment it's 16 or 32, the distance between two incisions becomes about 2.5 or less. If it's 8, you can do a routine surgery from the cornea between two incisions. But if the 2 pi r is divided by 32, that is incisions with 32 in RK, then you have to go scleral. Otherwise, there are 80% chances that the incision slaps.
So you
got muted. But majority of the sutures will splice open up. So be ready with the suture. Please do not hesitate to put a suture on the radial one, which you can remove maybe in a week's time. But on the table, if you want to have a pressure control, it's better to have, because if you don't suture it, it might override and heal up. So you might have a hump in the periphery, which we had in earlier cases, but we started doing splicing. So all my residents, everybody is doing suturing in these patients. I think that's a must now. Now, recently we came out with a study in which we used Aura to do post-RKIs. What they recommended was more than 8 incisions. It's not correct. But till 16 incisions, we were able to get good result with Aura. So I'm not saying you go ahead and buy it, but if you have a good guy who can do a retinoscopy on the table, it's a perfect thing. And retinoscopy is in the aphakic mode, and that's how you get the refraction. And thanks, Partha, for quoting the ICL. ICL, the excellent and the ICL does not make a difference. We published this work about 8 years back in which we did the ICL patients, we did the excellent before and after putting implant. Every time they used to come to us, we used to measure the excellent. We realized that the excellent, if you measure through the thin central cornea of the lens, the calculated anterior excellent factor is minimal. So you can just ignore the factor and just whatever excellent you get with the ICL in situ can be taken up for the surgery. The only thing you missed out is the iris claw lenses. Now you have varices or veriflex. We have operated few patients in which there were varices in the eye. So either you take the lens out and do the surgery, or you can do the surgery with the lens in situ, going behind it and doing it. That's what we do in the center, and at the end remove the lens. Now people might say that you can you can cut the section, remove the lens first and then do the surgery, but the chamber then becomes very, very fluctuant, and all these patients are anyway myopes. Even if you put sutures, it doesn't work very well. And last thing is that if there's he showed very well, if there's a plaque in the posterior capsule and you already implanted the lens, please go with a vitrectomy probe either from pars plana or go under the lens and just with a high cataract, just cut in the center and leave it alone. If you try to pull with the needle or the forceps behind, it will definitely go away, because these are the eyes in which the lens is bigger, they are myopic eyes, and the posterior capsule is ultra thin and it will run off. And try to keep some element of the fibrosis intact in the ring, in the periphery, if it's possible. Just open right in the center and you should be happy. I think otherwise Partha has covered up very well. I'm sorry, I'm teaching in the college, so I've become a teacher whenever given a chance. I'm really sorry I took extra time, but this is what I wanted to add on this. Thank you
very much, sir. Thank you.
Those are very great tips, sir. You should please tell all those.
Yeah, sir.
Yeah.
All right, great.
Okay, so now we'll move on to our next segment. That will be 3 case scenarios, which the initial one will be discussed by Dr. Matthew, and then by me, and then Matthew again. So over to Dr. Matthew. And we have all our 5 panelists ready to comment on this. Go ahead, Matthew.
Thank you, Mino. My case is intumescent mature cataract, where the contralateral eye had a posterior polar cataract. So I'm starting this case assuming that this is potential for open or openable posterior capsule. Because it's intumescent, I stain with trypan and then get rid of the trypan using viscoelastic intumescent cataract requires a heavy molecular weight viscoelastic to tamponade the anterior capsule and push it down. And then I'm preventing a rhexis runoff by using the microrhexis forceps to do a small controlled capsulorhexis. Once I'm fairly sure that it is under control, I'm continuing it in a spiral fashion to get it into a slightly larger but less than 6 millimeter diameter lens. My choice of phaco technique is in situ rotational lens chop, and this is what I do for all my posterior polar cataracts as well as for anything where there is a suspicion of open posterior capsule. So as the first quadrant comes up, I notice this line on the posterior capsule. And at this stage, I would pause and I would request my panelists to discuss what would be the signs that there is a potential rupture or vitreous in the anterior chamber. Question to Dr. Ramesh Dorairajan.
That was a beautiful chop which was done in situ. Thank you, Dr. Matthews. Just before you froze that particular movie, there was a fraction of a second where we had a clear circular zone without any cortex. And yes, just before this, we saw a zone where, yes, a little beyond this, where there is an absolutely clear jet black zone. So that is a hint to us that we don't have any cortex against the posterior capsule and you already have a pre-existing rent. Can this go forward slightly, a little bit more, and then, okay, just before this you had a flash. So,
yeah,
fantastic. So in the early years, we generally know that vitreous is there only when the vitreous comes out of the wound. With a little more experience, we know the vitreous is there when we have ovalization of the pupil. But in a situation like this, you will find it difficult to turn the nucleus around. It will become a little more sticky. And to confirm it, you have to use intracameral triamcinolone. That's the only way of finding out. Thank you.
Dr. Partha, any thoughts? What other signs? Where would be the situations you would be careful about? Ron was able to show me something which I hadn't thought of, which was the vitreolysis as a potential culprit for a pre-existing PC rupture.
So apart from that, looking into that deep black area, the other thing that, the emulsification of that fragment, taking up that fragment would be a little more difficult. And that would be something that an experienced surgeon would understand, that it with the parameters that he has set, and he knows the way that that fragment would be going into the tip of the needle would be much slower if there's vitreous in the wound. However, this might elude a newer surgeon, and it might be because of the viscoelastic. So he might be fiddling around. And then, of course, the next step would come in when you are rotating the nucleus, and the rotation of the nucleus with the blob of the vitreous coming in would not be as smooth as with the viscoelastic just in the anterior chamber. So at this point of time, these two things are of importance.
Right. So here, because it is an intumescent cataract, there was no need for hydrodissection. Rotation is something that we would want to avoid. So I'm actually prolapsing the nucleus and using the nucleus itself using a Sinskey hook to bring the nucleus into the anterior chamber. The presence of a lot of residual cortex actually makes it easier. It's a smaller nucleus, and a lot of soft cortex allows me to do this. The last portion, again, I tip it up. And at this point, you can see that the posterior plaque, posterior polar plaque has lifted off the posterior capsule. You can see that at the back, there is the clear zone, which suggests, and now it is visible on the other side, which suggests that this is a posterior capsule rupture. So what are the steps at this stage, Dr. Kokar?
Yeah, I think I'll want to add that if you have seen the first opening, I would have used a viscoat there and then, because viscoat is a dispersive viscoelastic. And once you go and you can actually make a layer under the nucleus, even if there's not a rent, you're not going to do any harm there. So once you put that, you floated the piece. You're an expert surgeon, so the rent did not increase in your hand. But by and large, whenever anybody else is doing, I think most of the guys will have an enlargement of the rent and the piece might fall down. Luckily, this was a younger patient, as I presume, because the cataract is soft. It's not a hard cataract. And if it was a little harder, the piece would have gone down without the help of viscoat. It just falls down. So viscoat I would have used here. And when you said, I'll rotate the piece only after I plug the opening with viscoat. And if you plugged it properly, the nucleus will definitely rotate very well. And of course, you have to collapse it into the chamber and do it. I mean, that's what you did wonderfully well. So for the beginners, rather than using a Sinski to tip it up, it's better to go with the viscoat behind and lift up from there. And that works like a third hand. The moment there's extra fluid, it will break into smaller dispersive elements and it will float the nucleus up. And I think that's what I'm teaching my residents. Thank you.
Thank you, Dr. Kokar. That's a good point. Dr. Chitra, what would be your suggestions with regard to phaco parameters at this stage? How would you manage heminucleus with a potentially open posterior capsule?
See, I would, of course, like to say that I would have injected a viscoat right in the beginning there. And if I do not see the obvious signs of vitreous, I would have got the piece out of the bag if the rhexis was large enough to do, because it was a soft cataract. As far as beyond that, I would ensure that the AC is quite deep, it doesn't shallow it. And I've taken a call that I'm going to remove it with phaco. I would keep it at as low as you have kept it. The phaco parameters, I keep an IOP, I could bring it down to 30 and keep my aspiration flow at this. And then the vacuum should be fine. And I call it an epinucleus mode. In that mode itself, sometimes I would take it off. If the nuclear fragment was a little larger, I would definitely nudge it out of the rhexis up and then place an IOL scaffold. And then I would be courageous to get the large pieces out.
So let's proceed and see what's happening now. So at this stage also is when I finally decide to go with the viscoshield technique. I'm using the viscoat, no financial interest there. Intact anterior hyaloid is there at this stage. Okay, but some of the viscoat has flown off. And at this point, you can see that flicker. And that flicker tells me that the PC has opened, vitreous has come anteriorly. And you can see that, it is much more difficult at this stage for the fragment to be emulsified. So this is something actually that's been just alluded to. Between the choice of viscoat, is there any other chemical or molecule that any of you would prefer in a potentially open situation, or between a viscoshield technique and an IOL scaffold, or which is the more appropriate technique in such a situations?
See, in this particular situation, a viscoshield would suffice. But I would be a little scared that there'll be some droppings going into the vitreous. But if it's a little larger piece and a little denser, I would definitely use an IOL scaffold.
Professor Ron, Dr. Ron?
I think I agree with Chitra that that's what I would do. I would perhaps use some triamcinolone to also just image and see how much gel there is. But I agree entirely. The use of visco is probably the first line of choice for most people, because there are issues when you put in an IOL scaffold. You do the scaffold, you remove the nucleus easily, but then actually the cortex becomes a little bit more challenging to remove if you just use the IOL scaffold unnecessarily.
Dr. Ramesh, any thoughts on the matter?
Yes, in this particular situation, the size of the PCR is quite large, and you had an intact anterior hyaloid face even after putting the viscoat. I presume that the vitreous had not entered the capsular bag till we saw the jerk where we saw the something like a pupil snaps knife. So in that situation, my personal choice in these eyes is to put a lot of viscoat behind, blow out the posterior capsule and deepen and fill up the anterior chamber and the capsular bag. And at that point, I will extend the incision a little bit and do something like a visco expression of the balanced nucleus, because that way I'm fairly certain I will not enlarge I will not break the anterior space. So today I have a low threshold to enlarging the incision and taking out the nuclear fragments. And I don't continue with phacoemulsification when I have a PC rent of this size.
So you can see the visco actually flows off there. And
yes.
This is probably, I think, the point where, the last point where I should have placed the
yes.
IOL scaffold, because now it is already too late and the vitreous is in front. Okay. So anyway, protecting the lens matter from going down, I have been able to complete the nucleus removal. Next is managing the vitreous. And Dr. Coker, what are your thoughts on vitrectomy settings and in the newer machines, especially compared to the older machines?
Right. So let's start with the Centurions. First, I'd like to say that once you have a rent, and I won't agree with Chitra that your vacuum should be low when you're doing IA, like with the phaco, when the nucleus, you just had a rent. Because if you reduce your vacuum to 180, what you had kept, the piece will not come to you. If once you put in visco at the back, your anterior parameter suction can stay the same, but the IOP goes to about 30. So you're not putting too much of fluid. With these high-end machines, vacuum works separately from aspiration. So your low aspiration still can give you a good vacuum. So vacuum, I don't reduce actually. But coming to the vitrectomy now, my parameters cut as I keep 4,000 always in these ones, because we need, this is the maximum this Century can take it. And the pressure stays again about, I don't keep pressure of 46, I keep about 30, 35 here. Aspiration stays about 20, 25, I keep a little higher, but my vacuum stays about 100 when I'm doing a IA cut, when I have to cut the vitreous. But when I have to aspirate, my vacuum stays at 500. So I'll just give you both the parameters. I have two parameters. One is IA cut, when the suction comes in first and the cutter comes later. In those ones, I keep my aspiration as good as a bimanual aspiration. So 500 aspiration, and the cut is about 100, which is minimum. That is I'm using for aspirating the cortex from the bag. But once I see the vitreous coming to my tip, I convert into a cut IA. That means the cut comes first, cut is about 4,000. In that mode, my vacuum is about 100. I don't keep more than that. I don't want too much traction on the vitreous. And the rest of the IOP stays about 30, between 30 to 35, depending on the chamber. Yeah,
Dr. Partha, what are your thoughts on settings for people who are not having access to this higher end machines where there is cut IA and IA cut options?
Yeah. So the first thing is, of course, understanding whether there is vitreous into the anterior chamber and how much it is. So once immediately with triamcinolone, if we can stain it and then going on to the cutter, whatever is available with the machine, that needs to be taken in before the aspiration starts off, before you go into the IA. So once the cutter has taken off the amount of vitreous from the anterior chamber, then I would, in such a case, do a dry aspiration and do it with visco inside the anterior chamber and just using the irrigation, the aspiration to take off the parts of the cortex. So that works well. And of course, the replenishing time and again, the viscoelastic methyl cellulose at that point of time. So dry aspiration with methyl cellulose assisted to take off all the cortical matter. And all the time, keeping an eye on the ruptured posterior capsule, because it is very important that the ruptured posterior capsule, you are able to see it very clearly now. So if that rupture is opening up, means again vitreous is coming in. So the moment the vitreous comes in, stopping the aspiration, doing again a vitrectomy, going ahead with methyl cellulose again into the anterior chamber, again removing the part of the cortex, whatever has to be done. This, of course, is somebody doesn't have the newer generation machines.
Thank you. So I think it's all agreed that we have to proceed with bimanual vitrectomy, where we are separating irrigation from aspiration and with cutting. Now, the next question is, once you notice something like this in the posterior segment, Okay, this is a small chunk of cortex that has gone down. What would be the anterior segment surgeon's do's and don'ts in this kind of a situation? Dr. Chitra.
I wouldn't go fishing after this. So I would ensure that the vitrectomy is done adequately. And then if the rexus support is good as it is here, I would place the 3-piece IOL on the rexus and of course inject tricot to see whether there is no vitreous which needs to be handled. The whole thing is quite clear. And I would suture the wound and send it to my retina consultant to deal it from the pars plana route.
Thank you. Dr. Ramesh, considering that this is just small cortex, would you choose to manage conservatively, expecting that it will resolve, or would you still go with a vitreoretinal surgery for this one?
Okay, so this particular chunk is probably in the anterior vitreous to mid vitreous. I would still keep the infusion towards the opposite limbus, not pointed down, and I would still put my vitreous cutter into the anterior vitreous, focus down and see how far down I can see clearly, and I will do a small anterior core vitrectomy, and in 1 in 3 cases, I will expect it to float and come away. In the remaining 2/3, leave the eye alone, don't do too much, and I will do exactly what you're doing. I will, what Dr. Chitra said, I will put the lens and I will wait. Now, if it is fluffy cortex like this, and the patient is willing to withstand a very large floater, a pie in the sky, then it will absorb. It will take a few months. In my experience, cortex like this in a clean surgery never causes inflammation. It just causes a very large floater. If the patient is bothered, you can send him for a vitrectomy, but it will absorb. It's a matter of time.
So this is actually fairly deep because I had to completely defocus down, and you can see the rexus, conjunctiva, iris, everything is completely blurred out for me to be able to focus. And sometimes even the retinal vessels are clearer. So this is fairly deep. So I think the choice of not fishing after this would be more appropriate. What do you say, Professor Ron?
Matthew, I think this perhaps looks more epinucleus to me than cortex. We see that sort of very linear, angular shape of it, which cortex just doesn't look like that. And I think if it was cortex smaller, I would leave it alone. At this size, I think you need to remove it subsequently with a VR surgeon. Otherwise, your cornea can decompose. They'll work their way all over the place. Yeah.
Thank you. So now we proceed. And then the choice of IOL. I'm going with a multi-piece IOL here. Since I have my rexus margins intact, I place the haptic into the sulcus. And what are your thoughts on choice of IOLs? Smaller rent versus this kind of a rent and a larger rent? Dr. Coker?
Yeah. Okay, so if it's a small rent, just ignore it and you can put a single piece into the bag, right? Provided when you inject the lens, make sure that you don't push the lens onto the posterior capsule. Once the leading haptic has gone in, press the trailing haptic down, the leading haptic will go upwards. It's something like when the aeroplane is landing, it comes nose down, but nose never touches the ground. If the front wheel comes, and it comes and goes off. The front nose goes up before it touches the ground. So similarly, you can manage. But this kind of rent, that huge rent, I think it's the best to put a 3-piece lens and without a capture here, because capture in this patient, if you do, there could be issues because it might just extend the posterior rent further. So I'll leave it in the sulcus. A 3-piece lens is what I'm going to do. And if I don't have a 3-piece, I might just put an all PMMA lens in this one and put 2 sutures in this patient. Thank you.
Dr. Rowe, what about Ron? What about your thoughts on IOLs converting a smaller rent into a primary posterior capsular rexus?
I think that's the sense. I think if it's a very small rent, I would agree with Dr. Coker. I would just put a single piece lens in the bag, and even if it's a multifocal or a toric lens, I think you can still do it. Sometimes you can, of course, capture the optic. But I think the safe thing for residents and fellows is that if you've got a largish rent and you're not sure, and this is what David Chang teaches us, of course, is You're not never going to go wrong by putting the haptics in the sulcus and capturing the optic in the rexus. So I mean, it's nice to have both those options available, really.
What about
Can I just chip in here once?
Sure.
Matthew, in this case, if we consider this one where there was a linear tear right across and you detected it in the periphery. So this tear, inadvertently, part of the nucleus could also have gone down. So at this point, it's my suggestion and my advice to all our residents and our newcomers to do an indirect ophthalmoscopy and see, is it only the cortex or the epinucleus, or is there more to it? If there's at times, even a half nucleus or a quarter of a nucleus could have fallen inside inadvertently, and you do not know. And what you're seeing is just the part of the cortex or the epinucleus. If there is a large piece of nucleus in the vitreous, then maybe the IOL does not need to be put, can be placed by the VR surgeon when he has completed the vitrectomy. But otherwise, also the IOL can be placed, and usually the VR surgeons take it off by the fragmentome and remove the rest of the nucleus and the epinucleus, whatever has fallen in. So an indirect ophthalmoscopy by the anterior segment surgeon, I think, would be mandatory.
Thank you.
Can I add one thing in this, please?
Anyway, this one completed like this with multi-piece IOL in the sulcus, the haptics in the sulcus. I had completed an optic capture. The chamber was formed, and subsequently the patient was taken up by the vitreoretinal surgeon to complete the epinucleus removal from the posterior segment. Thank you very much to all the panelists. And I hand over now to Minumathan for his second case. I'll stop sharing.
Yeah, thank you, Dr. Matthew. That was a great discussion on a PCR. We are slightly on short of time, so we will go fast on this. This is regarding small pupil toolkit. Am I seen?
Yeah, your videos.
Yeah. Okay. So, my first question, I would direct it to Dr. Ron. How small is small?
Well, I think that you can actually do a pretty decent rexus if you've got 4 millimeters, But, many a time you may see 4 before you put the knife in the eye, but then when you visco dilate the eye, it's much more. But 4, you can actually do a rexus just beyond the edge and end up having a 5 millimeter rexus.
Okay, Dr. Coker, do you have?
I think it depends inversely to the experience of the surgeon. A great surgeon with a 4 millimeter can also manage, and vice versa. Even a 5 millimeter can be, gone into problem. So otherwise, between 3.5, less than that is a danger zone. With elastic, it goes to about a 4 to 5. I think that's good enough.
Okay, so this actually looks small, but in some cases where you have a large white to white, they are not so small as we think. See, this is a 4.9 millimeter rexus, 4.9 millimeter capsulotomy, which is going easily into this. So this is easily a 5 millimeter pupil, though it looks small. But again, it is depending on your experience. So the next point will be, if you see a case like this with definite small pupil which is not dilating on your table, on your slit lamp, Dr. Chitra, what would you counsel? Is there any difference in pre-op counseling for this kind of patients?
Yes, I would say that there would be some extra manuals needed, and since the pupil is not dilating, we would need accessories like iris hooks. Depends if the patient is quite intelligent, then I would go to that extent, or I would say that it will be a little more time consuming surgery, but we'll take all the right measures. But for an intelligent patient, I would say we would be needing iris hooks and further steps to be done. And this also looks like it could be a post-uveitic eye, because I see posterior synapse there. So then, of course, I would get very much on the vigil. I would ensure that the patient takes tropical steroid drops a week prior. I would definitely go into the history of the patient, whether they've had recurrent attacks, whether the eye is quiet. There has been a period of quiescence of 3 months at least. So then all those things would also have to be factored in, and then accordingly with a full plan of how I was going to manage it intraoperatively, and a post-operative management also becomes very critical in these eyes.
Yeah, thanks, Dr. Ron. Would you add on anything regarding the post-op management, especially IOPs, inflammation, low-grade inflammation persisting? Would you add on anything on the pre-op to the patients?
No, as she mentioned, I think you want to make sure that the uveitis is very well controlled before you do it. And at the end of the surgery, I mean, just make sure you get a good steroid and make sure that the steroid treatment is enough. But what I would say is, before you do any of these small pupils, you want to make sure, is this a pharmacologically non-dilated pupil with the drops? You want to see, is there synechiae, as we've seen in this case? Is it a structural myopia or not? And if it's neither of those two, then you can actually viscodilate most of them without resorting to the.
Okay. Thank you. I think we'll go on to the next one. So when we decide in a case that we will go ahead without pupil expansion devices. So my question will be to Dr. Coker. What is your medical management initially, if you want to try to expand it more?
Okay. So if I take a history and I find out this patient is on prostaglandin, is on the treatment for his prostate, or he's on prostaglandins for glaucoma. So these are the patients which are potential to have problem in the pupil. So I start them on a appointment 2 days before. That's my protocol. And otherwise, when the patient comes to me, and in the outpatient, we always dilate the patient fully. So the patients which do not dilate, we put a red mark on the corners that these are the ones which we need. So what we do in these ones, we use tropicamide. So pre-operative, a day before, they are on the hometropine eye drops. On the day of surgery, after putting Paracan on the eye, we find that it causes a little toxicity and the penetration of the medicine is better. We put a phenylephrine if patient is not hypertensive, 2 drops at the gap of 10 minutes, that's all. And tropicamide. Tropicamide plus or tropicamide depending on the hypertensive. If the patient is hypertensive, we avoid the drosin, the plus, and use plain. And majority of the people will open. So if they don't open, then on the table, do I tell you about the surgical also? How we open?
Yeah, please.
Okay.
Yeah, please. Yeah.
So my first thing on the table, what I do is I put in a dash of air in the chamber, and all these people who are about 3 to 4 millimeter. And if you see there's no synthetic tear anywhere or any patches of atrophy on the iris, I always bet with my resident that I'll put a dash of 1 in 10,000 EDRI, will the pupil dilate? So 99% I win the money. So the moment you put in, because all the receptors are not saturated yet. So the moment your adrenaline goes in, if the pupil opens from 3 to 5, these eyes, you do not need any expansion device. No iris hooks, no Malligans, no Bhattacharya's hooks, whatever. So that's what I do on the table.
Okay. Dr. Ramesh, would you like to add on? You're muted.
So I also do something extremely similar to that. I don't like to operate in small pupils. I feel getting a 5 millimeter pupil at the end of surgery should be our goal, and not try to manage with a smaller pupil than that. I prefer adrenaline, and I'll see whether this particular patient dilates. There's not much of a fibrosis, so it may dilate. If it does, I will proceed. Otherwise, I'll put hooks. I'll make a decision now.
Have you been using phenocaine, which is available right now?
I have not used it yet because, like Dr. Kosha said, I'm also quite happy with adrenaline. But I guess phenocaine will work much better than that. Yes.
Okay, so we'll move on. So this kind of a small pupil, I have done a rhexis. So it is relatively okay, 4.5, maybe close to between 4 and 5. So technically, after this, what all basic precautions should be used? Would you change anything in your PECO parameters and your technique wise? So Dr. Partha, would you like to comment on this, please?
Yes. So the first thing that you are doing now after creating the rhexis is the hydrodissection. So the hydrodissection is a very important tool to tell us whether this pupil is now going to shrink or not. So the moment you do a gentle hydrodissection and see the fluid wave, and in this one, you won't be able to see the fluid wave. So to tap it in between, not to let the gush of fluid come in and make the pupils shrink. So to tap it and then to watch for that. Yes, the fluid wave has gone, and now you can see that the pupil is shrinking now. So at this point of time, it's very important, and that depends upon your confidence, your caliber, your experience, whether you should go in and do it without the devices or put in the devices now. So again, after the fluid has settled, the high molecular weight viscoelastic definitely needs to be placed and stretched. If you think it is a very soft nucleus which cannot be divided well, so there again, or can be you cannot go in with a straight chop, then is the time that you need to put in the devices and then go ahead. But if you feel that you can chop this nucleus, once the chop is done, then it becomes much easier for the nucleus management. But if you're not got a chop and with a small sized rhexis, then prolapsing that nucleus or managing that nucleus becomes more difficult.
Can I make a comment here, Minu?
Yes, sir. Yes.
In this case, what Partha mentioned is very important. So the density of the nucleus. If this is one of those actually more difficult ones, this is perfect for doing a pre-chop. Akahoshi's pre-chop technique, where you just put the paper into the middle, you will have a complete separation, and sometimes you don't even need 4 quadrants, just 2 quadrants. I split it in half. It's easy to remove. And I think for the denser ones, you probably want to do a direct chop. I think in this pupil, I still probably wouldn't need a hook or a device. I think direct chop or a pre-chop.
Can I add on?
So, Dr. Ramesh?
Can I add?
Yeah.
Please.
Yeah, please.
No, let Dr. Ramesh come.
So
yeah, Dr. Ramesh, if the nucleus is harder, not indirectly this, maybe you should tell about this and then tell about a harder nucleus also.
Okay, but even in this particular patient, I no longer try to manage with a pupil of this size. I will be putting hooks.
Okay. Yes, sir. Kokar, sir.
Okay. So small pupil does not mean small rhexis, and large pupil does not mean large rhexis. So fully dilated pupil doesn't mean you make a rhexis of 8 millimeter. You still make 5.5. So small pupil also, when you're making the rhexis in these ones, try to go under the pupillary margin. I think that's a very important point. When you want to stain it, whatever amount of the rhexis coming back to you, the tissue which is coming out will tell you how big the rhexis is. So try to go a little under the pupil so your rhexis is a little bigger, same size as 5.5. So small pupil does not mean small rhexis. One should not get trapped into a small rhexis thing in these patients, because if you have a small rhexis, as Partha mentioned, then the hell will break loose, because then your superior zonules will definitely go off, because you'll be trying to push and the lens will go. So don't make very small rhexis. That's what I was trying to say.
Okay, sir. So that is well taken. And then we move on to expansion devices. So once you are uncomfortable, we will definitely use either hooks or rings. So that is agreed upon. And so once, Dr. Kokar, do you have any preference? Which case would you use rings? Which case would you use hooks? Anything like that?
Okay. So all these patients who are floppy, in which I know it's a floppy iris. If I put hooks, it will stretch the iris at 4 places. The rest part is still fluttering. So those are the patients which definitely gets the Maligan from me, always these ones. And Maligan, where I don't put is when the chamber is on the shallow side, I put not 4 hooks, I can put 5 or 6 hooks to make it as circular as possible. So the area distance between 2 hooks is less, so the tissue will not, iris will not come into my phaco. But with all the floppy irises, ring is my choice with the chamber depth being normal. Now, using iris hooks, you have to be careful that you don't use hooks which have sharp tips. So I've seen my resident with a sharp tip causing tear on the capsule. So what you can do is like a Yamane's technique, all your iris hooks, the tip which is bent and coming backwards, you can actually burn it with a cork and make it round or smooth. So there's no sharp edge which can tear it. I mean, that's what I started doing in all my new iris hooks, which I burn the tip like a Yamane's technique. And iris hooks, when I'm putting 4 for a routine surgeries. But if I find the iris, the iris is more floppy and it's coming in between, I'll stop and put more hooks so that I have almost a pentagon or a hexagon or a circular pupil to work with. Yeah. Okay.
I think Dr. Partha, would you like to add on your preference for hooks in which cases?
Yeah, sure. So if I'm going to place in hooks or devices or rings, so if the capsulotomy has not been done, and I want to place it, I know that I will not get along with this smaller pupil, I will place a ring. So it could be a Bhattacharjee ring, or it could be the Malugan ring. But when I have done the capsulotomy and the pupil has shrunk in on me, then I would like to place the hooks, because with the hook, I can be very sure that the hook is hooking only the iris and not the capsule and the iris. Because once you go in and then make it a little obtuse, you can just take up the iris and pull it up. And you can also graduate it as much of the pull as is required. Whereas in the ring, at that point, at times, you might not have that whole control, and the flanges might go actually under the rexus margin, and then there is a problem there.
Okay, so we'll move on to one specific situation where you see this is a post-strab case with a membrane, partial membrane sitting on the pupillary margin. Dr. Chitra, is there any specific few tips which you would give in this kind of a particular case?
The post-strab case, if there's a pupillary membrane, of course, I would go in with the viscoelastic and inject it and deepen the eye, see whether the viscodilatation occurs, and then I would take off that pupillary membrane. I mean that not pupillary membrane, that fibrin membrane which is overlying. And if the pupil doesn't look as if it's going to get floppy, that impression comes, which invariably when you're going to tease out this membrane, the pupil is likely to get floppy. Then actually nowadays my threshold for using iris hoops is so low that at any point of time when there is the least bit of doubt, rather than having a challenging case, I would use iris hoops and carry on with the surgery. When I use iris hoops, I would ensure, do I have to tell that now or maybe later?
Yeah, please continue.
Yeah, I would ensure that it's a little posterior placed on the limbus, and it's a snug fit. And I would like to place all my hoops 4 or 5 as the size of the pupil. And then I would tighten it, but I wouldn't over tighten it because I wouldn't want sphincter tears in these cases. And once that is done, then it becomes a very simple, straightforward case, going about making your rexus and doing your surgery. Of course, it always makes sense to keep your parameters on the lower side and make it a very gentle, safe surgery.
Okay, Dr. Ramesh, would you add on anything in this?
I will agree with Dr. Chitra totally. Just make it a very easy case by putting in the hooks and making the pupils larger. Don't delay putting in the hooks. And in this particular surgery, there's a beautiful subincisional hook. So that is a very important position, especially when you have IFIS and you have a floppy iris syndrome. So minimum 5 hooks, very beautifully demonstrated here. I too have a very low threshold for putting in hooks. Regarding the membrane, small thin membrane, I don't think it matters. I nowadays leave them alone. Thicker membranes I will remove, because if I don't remove them, then once I put in the hooks, it will tend to tear, and the membrane will prevent the remaining pupil from expanding. So we'll tend to have a large sphincter wherever the hooks tear to. So I remove membranes only if they're a little thicker, not the small ones.
So those are to avoid very, very ugly looking pupils post-op. So if you remove off the tight membranes around the pupillary margin, you get more cosmetically better pupils. Dr. Ron, to apply hooks on, just to mention the specificities, the size of the hooks, the location of the hooks, how do they matter to you?
You know, I mean, this is a subject that I'm very interested in. In fact, I just made a movie with Professor Chi for this year's Oscars called Humble Iris Hook, in which we really look at all aspects of usage of the hooks. And I have a slight preference for the hooks compared to a Malugan or a Bhattacharjee ring. I mean, sometimes your shallow chambers is very hard to deploy the devices, whereas the hook gives you that flexibility. You know, I think what you just showed in that video was beautiful, using the sub-incisional hook for the iris cases. And that's the advantage of the hook. You've got the flexibility of putting it far apart, as close as you are. You're not constrained by the design of a ring. And you can use it also to hook a capsular bag. If you think that the lens is a bit stated, you move it from the iris into the capsular bag. That's very, very useful. So my vote is for the iris hooks, really.
Thank you. Thank you very much. Yes, Dr. Chitra.
The thing is, like, when you location of the hooks, if it's going to be a diamond shape, then I would put it on the 4 sides. But if the pupil is not large enough, I would put a subincisional hook. If it is, I want to place more hooks, then I would place 2 hooks on either side of the incision, and then place the 3 hooks, one on the apex and on the either side.
Okay. Yes.
Okay. So if you're using MST, sorry. Go ahead, please. Go ahead, Partha, you go ahead.
No, sir.
Okay. So if you're putting an MST hook, which is a malleable soft hook, it's expensive. You can actually be at the limbus and do it, right? Because it's got an angulation and keep the iris parallel. But if you're using the Indian make hooks, it's best to go about 1.5 millimeter behind the limbus and go parallel to the iris, so that when you hook the iris, when you go with the probe, you're not rubbing against the probe, against the stretched probe, which is pulled upward. So please do not tent the iris upwards. Try to keep it at the physiological plane. For that, your iris hooks, especially the Indian make iris hooks, should be about 1.5 millimeter away from the limbus, going just parallel to the iris.
Sir, would you go through the conjunctival attachment or leave the conjunctival attachment? But sometimes
we go through.
So what do you do to the fluid egress which can happen through that in the conjunctiva ballooning up there?
Okay, so you're going at an angle. You're not going stab incisions. You're making an angle in this one. And at the end of the surgery, if there's an egress of the fluid, you can just keep it pressed with a soft stick for a few seconds. It seals up.
The trouble with those coming in behind and having the straight hook out is that it can catch on the eyelids and the speculums when you're moving around. So one of the useful tips is really the bit that's sticking out of the cornea, just bend the protruding bit upwards, and that saves a lot of grief.
Yeah, you can cut them also.
I also noticed that it was written Urimax in one of
Yes, I was coming to that. I am coming to this one. So this is a tamsulosin patient on tamsulosin. So Dr. Chitra, would you continue on this? It's looking like it is a well dilated pupil. See, now just by rhexis itself, it has started coming down. Yes, please.
Yeah, if it is pre-op, I would definitely ensure that the history is taken and it is being taken very regularly with in all our patients. Then I would start pre-operatively, because that will prevent meiosis of the pupil on the table. But I feel that, of course, iris hooks are going to be used, but using a phenopain also, it ensures the tautness of the dilator muscle. So that could also be added on along with the hooks, and keeping the eye soft is very necessary, and low flow parameters is necessary. We've gone on to the details of the hooks. So low flow parameters is necessary, and then it should be all right.
Okay. Dr. Ron? This one I'm not using any hooks. In the technique wise, chopping and the aspiration part about the fluid, what would you suggest?
Well, you're very skilled at this, Minu, so that's why you're making it so easily. I would pre-chop this one, because this doesn't look that dense. I'm not sure whether it's deceiving me, but I would pre-chop this through that smallish pupil, and I think that would work very well.
So again, the point is that I do not allow this fluid to go underneath the iris too much. Keep the irrigation over the iris, and then once I see it coming down dangerously, I can always put in hooks at any point of time, as we had suggested. Especially coaxial IA, when I use it, it has to go under the iris sometimes, and then pupil again tends to below and come down. So bimanual would be a good idea to use in these kind of cases. And even see, now you can see the flutter of the iris, so much of iris flutter, and then comes into the port. So these are the problems we face in IFIS. And regarding rings, could you let's go in 1 minute and finish this regarding how different do you feel, Dr. Partha, Maligan ring and BHEX ring?
Yeah, so both these rings are pretty easy to implant, but they have to be done, and they have to be learned also. It might not be as easy as it is seen. BHEX ring is a little more, soft, and the stretch on the pupil will be adequate in most of the times. But if it is a tight pupil, then it is a Maligan ring that has to go in.
Okay, regarding the BHEX ring?
I think, sorry.
Yes, Dr. Chitra.
No,
Yes.
I just felt that if it is a floppy iris, DX ring, it's a more thinner material structure. So the iris would still continue to be floppy. So DX ring is not the solution for a floppy iris for a regular surgeon.
Okay, so that,
Peadiatric acts quite well. I mean, you can see the floppiness and the up and down movement while you're doing your phaco, but it will not let the pupil crowd down.
Okay, so here the technique of using it is again has been modified, and the use of Sinski or the manipulator is now avoided. Using to put it on this, we are suggesting using forceps to hold all the three flanges, and then get the flanges underneath, alternate flanges underneath the iris, and before implanting we would stretch a little bit if it is a 2 millimeter or a very small rigid pupil before trying to get the flanges underneath, and this is also working very well, except in IFIS. Even both these rings you can get iris prolapse through the paracentesis and the main wound, and iris hooks are better on that. So I think with this we will stop this because we are running short of time, and we'll go to the third case of secondary IOLs from Dr. Matthew.
We'll start a session on secondary IOLs with first question to Dr. Ronyo. What would be your preoperative evaluation in a patient with aphakia?
Well, I think the first thing I would look at is, I mean, you do the normal thing, visual acuity, to check that the retina macula all is healthy before you embark on the surgery. But I think one very basic point is that many of these people actually may have had a PC rupture, but there's actually enough of a capsular rim left behind that you could actually just implant an IOL in the sulcus rather than have to go through a Yamane or a sclerosing of the lens. You also want to make sure that the endothelial cell counts are good for the surgery to come.
Dr. Coker, what about you? What are the peroperative considerations during secondary IOLs?
Okay, so three things which I look at. First thing is the BCVA. If the best corrected visual acuity is poor, we're not doing these cases. Second, how's the support of the rim. So rim, BCVA, and third is specular count. These are the three essential for secondary. So first, I think everybody understands. If the vision is not good, you're not going to get something great out of that. Second, if the rim support is good, if the support is good, three pieces of the sulcus is the most physiological way to go. If the support is not good, I see the pupil shape dimension. If the pupil sphincter is healthy and not being damaged, I do a retro iris claw lenses a lot these days. I've done recently started about a few years back, and no regrets on that. Thirdly, if your specular is poor, those are the patients in which I think you have to decide whether you want to keep this patient on a contact lens basis or do the surgery, because you can burn your fingers. But in these patients in counseling, it's important to tell them that you're putting a secondary implant with the understanding in case the endothelial decompression which happens, we might take you off for a corneal transplant surgery.
Thank you. So we'll start with what Professor Ron said, to check the quality of the bag. So here we have a large zonular dialysis superiorly in the subincisional area, and there is vitreous, sheets of vitreous which is actually coming into the main wound, which I am cutting with my anterior vitrectomy. And then when I inflate the bag, you can see that the bag is actually intact. And I am putting viscoat into the bag and inflating it, intact bag. And so instead of trying to do something very exotic, what I'm doing here is to simply place a capsular tension ring. Since the defect is superior, the open end of the capsular tension ring is placed inferiorly using microforceps, and then make a opening, and a foldable intraocular lens goes into the bag, and that finishes the case.
This is not a secondary implantation.
This is a secondary implantation. The primary surgery was done many years ago. Okay. So
Congested eye, that's what I thought.
Beautiful surgery, doctor. Fantastic.
So now another situation is where, like, we are able to assess and see that there is adequate capsular support. There was a large iridodialysis on this side, and a PI was performed on that side. And because of the posterior synechia, we were not able to see preoperatively whether there was capsule on that side. But intraoperatively, once we have released the synechia there, we can see that the nasal portion, there is adequate support, and there is some amount of synechia which I am struggling to release in the subincisional area. And then I am able to place the IOL into the sulcus quite comfortably over here. Here again, this is a multi-piece lens that is being tucked into the sulcus, and the optic is captured by the rhexis margin.
Matthew, if you had done a UBM this patient pre-operative, you would have picked up what is happening behind the iris. So I think that's a small technique. If you can do a UBM, take a picture, it can tell you what is happening behind the iris. So you can plan better. Yeah.
This is another case of pediatric cataract. Some 10-15 years back, a lensectomy has been performed, and there is a good amount of posterior synechia. The synechia are released, visco-synechiolisis, and then Sinski is used. You can see that there is a good amount of Sommering's ring that is developed in the interim since the surgery, but the visual axis is clear. So the plan is to, because the Sommering ring is so bulky, the plan is to release the Sommering's ring, get a flat capsule contour, and the whole 360-degree ring is prolapsed into the anterior chamber and phaco-aspirated. And then initially I plan to put a multi-piece lens without adequate pupillary dilation. So at this stage, this is just a blind procedure where I am placing the lens into the sulcus. But then, like what was highlighted just before, I use hooks to now ensure that the lens is in the sulcus. The visual axis, there is a fair amount of capsular fibrosis that I cut and open up, and then tuck the IOL into the larger opening with capsule with the optic capture by the posterior capsule. Now the haptics remain in the sulcus. The iris hooks are removed, and a reasonable 5 mm pupil is available at the end of surgery. What seems to have gone out of fashion now is the anterior chamber IOL. Dr. Ramesh, your thoughts? Dr. Chitra, would you prefer anterior chamber IOL in any situation?
I wouldn't prefer, but I'm not backed by scientific data, which does tell that there are a number of a series of cases where these have done well. I truly believe that the ACIOL went out of dispute mainly because the sizing errors were there and the primary surgery was not well done, and there were so many complications that it didn't do well at all. But however, I would prefer to use an iris claw comfortably if I were doing it. But if it's going to be a scleral fixated lens, it automatically goes to our retina department.
What about you, Dr. Ramesh?
So I still use them, and in my lifetime, I had 2 patients who needed to have a corneal transplant done after ACIOL. One patient was a young patient. So one thing is a myopic patient where it's going to be loose, and especially if they're going to be young and going to live for the next 40 years. Please don't put a AC lens. And secondly, when the primary surgery is done by somebody else and you have no idea about how healthy the cornea is, please don't put a lens. If you're the surgeon, you'll know what you have done, and you'll probably do well with it. So personally, I feel ACIOLs can still be used. There's nothing wrong in using them.
I have limited personal experience with the iris claw. What about you, Dr. Kokar?
Yeah, I think AC lenses and iris claw. The confusion is iris claw started on the front of the iris, and all my cornea colleagues used to look at me badly, like you're damaging the cornea. But if you see the studies, the longest study of 14 years follow-up in 13 patients in which pediatric traumatic cataract was done. This was for 14 follow-up, they found out there was no change in the iris claw. So I think that was a beautiful done study. But now what we do is, to please them, they started going posteriorly. So there are two advantages of going retro. Retro works wonderfully well. Retro claws do not get disengaged that easily. And retro claws do not cause any endothelial loss as much as posterior chamber IOL. It will be the same, not as compared to the anterior chamber lens. So I started using them. I agree with Dr. Ramesh when he said the anterior chamber lenses. I use a lot of anterior chamber lenses earlier. And all these lenses, the ones which had problem were in which the sizes were different. Now, the sizes which are available are 12.5 and 13. So any eye which is less than, say, 11.5 millimeter or more than 13 millimeter, you can't put these lenses. If the eye is small, you put in a big lens, it will erode through the cornea sclera to come out. So we've seen all kind of complications, but if the sizing has been done properly and a good PI and you've done the surgery yourself, as Ramesh said, I fully agree with him, these lenses do wonderfully well. There's nothing wrong in them. But now we switched over to the retro iris claw lenses.
Dr. Partha, your thoughts?
Yeah, the retro iris claw is a very, very good lens to be used in such cases. The technique has to be well done. Otherwise, you might have just enclavation of a small amount of iris tissue and you're not able to see that amount that you're enclaving between the claws. So that's very important. It should be adequate. Again, it should not be too much. Too much means the ovalization of the pupil. So that adequateness comes only with practice. So if somebody is doing it well, it's bound to be a good one and it stays on. But if it has been done a little, traumatically, then the fraying of the iris plus a disinclavation is a possibility.
Okay.
What is your thoughts on the classical sutured? Pardon?
Sorry, can I add
Yeah. Yeah.
So the moment you finished your enclavation, please go from the side port and put fluid into the chamber. If your lens does not budge from it, the position, that means you've done a good enclavation. Otherwise, if it's a poor enclavation, it's given there only and you can re-enclave. That's what I teach my residents. Okay, sorry, please go ahead.
Okay. What's your preference with the classic sutured SFIOL?
You're asking me?
Yeah, Dr. Ron?
You're muted, Ron. Ron, unmute yourself.
Yeah, so there are a couple of options. Some people do a flap and then you do a Sharroff tunnel. Recently, we've been moving more to just a little groove with a Sharroff at the end, and then you just feed the haptic of either an AR40 or a CT Lucia into the thing, and you can put one or two sutures plus or minus glue.
Anybody doing the classic sutured lens with either Prolene or Gore-Tex?
Well, our VR department has been doing this for a very, very long time and without the Gore-Tex. So as of now, whatever figures we have, the amount of fraying of the sutures, the non-Gore-Tex sutures has been minimal. However, Gore-Tex is the way to go and we are changing over to the Gore-Tex sutures now. Another small point that I would like to bring up in these secondary IOLs is the capsular bag remnant needs to be taken off in toto before placing in the secondary IOL. It is mandatory because if not done, then there would be a tilt of the IOL and that can be quite a large tilt and then it can go into difficulties of refraction.
So thank you. So while the classic variant involves a lot of conjunctival dissection and creation of flaps or pockets, the Hoffman's pouch is an elegant improvement on the technique where the pouch is created from the corneal side and then without any dissection of the conjunctiva, the needle is railroaded through the sclera and the conjunctiva, and a hook is used to retrieve the sutures from the pocket. And then as the knot is tightened, the knot slips back into the scleral partial thickness scleral pocket, and so protects the knot from exposure. Glued scleral fixation has become very popular of late. So in these kind of glued sutured IOLs, what is your choice of IOL, Dr. Kokar, Dr. Chitra?
Okay, so I'll just take a first. I have to go after this. So if I'm putting a scleral, I use a 3-piece lens, and I prefer the technique in which you have a flap and you have a groove in which the haptic goes in. So I need a little portion of the haptic to go in, versus a Yamane technique where it's stuck at 2 points and the lenses are usually mobile. So I prefer a 3-piece Alcon lens. I think any 3-piece is good for that matter. That's it. Thank you.
Thank you. Dr. Chitra?
Yes, 3-piece lens.
Okay. So final questions to Dr. Partha, and what is your preferred post-operative protocol for these kind of secondary IOL?
So the post-operative protocol is because of the amount of tissue handling that there is, the steroid, the topical steroid has to go in and we give it over a course of 4 to 6 weeks. But the evaluation after the immediate post-op is very important. If there is an excessive amount of reaction, that needs to be taken care of, and then only we give something systemic steroids to curb that amount of inflammation. Number 2 is the cycloplegics. The cycloplegics are definitely important, and they have to be given. And again, depending upon the course of reaction, then they can be taken off. But the third and the most important thing is evaluation of the posterior segment. At times, especially if it is a traumatic cataract with a secondary IOL or a pediatric cataract where you have not been able to see the fundus and the periphery, an evaluation right up to the ora is mandatory because of the handling of the vitreous during this procedure, which is a secondary procedure. There could have been tears and problems in the posterior part of the eye.
And of course, addition of non-steroidal anti-inflammatory drops, I would prefer to use it 1 month beyond the 6-week period on a BD dose.
Thank you. With that, I come to the end of my presentation, and thank you to all the panelists. Dr. Minu?
Yeah. I think we have the final keynote address, which we were all waiting for. Dr. Chitra Ramamurthy will present on her topic on why cataract surgery is poised to be a refractive surgery now. Over to you, Dr. Chitra.
Can you see my screen?
Yes.
So today we all need to be cognizant of the first and foremost. Thank you very much, Chaithanya Hospital, Dr. Matthew Kurian and Dr. Minu Mathan, for this wonderful opportunity to be there with you all. I thoroughly enjoyed the discussions and the 2 great talks which were before me, and it's going to be a difficult task to follow up on them. So going on to my topic, why is cataract surgery poised to be a refractive cataract surgery? So today the patients are quite cognizant of the fact that there is the technology and there is the skill in many of these surgeons, and they could expect great visual freedom. And it's also what's best for your patients. So we need to tell your patients that yes, there is going to be a loss of accommodation when you're going to remove his lens and the depth of focus. But today you do have the alternatives which could match up to give him a youthful look. Now, as far as the essentials, what we need to look at is we need to ensure that the right biometry is being done, and the topography and the eye trace. And this is going to help us whether you're going to place an aspheric IOL in this eye, or a multifocal, or a trifocal, or address the astigmatism. So I'm going to split my talks into pearls. So the pearl 1 says, what is the right time when you decide that your cataract surgery is going to be a refractive cataract surgery? So this is a time when you have started realizing that your phacoemulsification is consistent, does not have complications, your wound architecture is absolutely consistent, there is no issues of any surgical induced astigmatism, you get a nice round rhexis with a 360-degree overlap, and most importantly, your biometry values and your end result of post-op visual outcomes are consistent, then that is definitely a right time. When your emetropia is within plus minus 0.5 in more than 90% of the cases, and you're using the newer formulas. So now the surgeon has bought into it, and that doesn't suffice. It becomes very important right from the front desk to your room sister, to those patient coordinators, that they all talk the same language to the patient. So the patient is absolutely not confused about the skill of the surgeon who's going to be operating, or rather of the institution at large. So then comes pearl number 2. So we need to address the workflow and the presenting options. So you need to choose your patients very wisely. Patient should be absolutely realistic. He knows that you have the best of technology which is offered, but he needs to be also made aware of this small limiting feature of these multifocals about the night vision related issues, which have actually become so very less if you choose your patients appropriately, and also understand the neuro adaptation. And it would be madness for you to crowd your patient with so much of information, and it has to be a very individualized approach to a specific patient, because one size definitely doesn't fit all. So what we do in our setup is, even before a tonometry is done, before the first drop of anesthetic is applied, once the patient has come for a cataract surgery, we do a biometry, so that we are on a plane where we clearly understand that whether the patient is just going to go in for a multifocal lens, or there is some astigmatic component wherein you want to give a multifocal toric. And with that clarity, we would then go on to counsel these patients. So in this particular, and that pearl number 3 goes without saying that when you have the skill at hand, a precise biometry becomes absolutely important. I would not pull down an immersion biometry. It is definitely good, but today we do have the facilities of optical biometers, and the penetration of IOL master, as we all know, is so deep and penetrative, and the fixation point is precise. So, you know, your ability to measure the axial length becomes so very significant, and the average difference when you're using an immersion as against an optical biometry is as much as 200 microns. But again, if you're going to be using an immersion biometry, you need to be sure that your spikes, the anterior and the cornea, the corneal spike, the anterior and posterior lenticular spike, the retina spike, the scleral spikes are all in the same amplitude, and that at least 5 or 6 readings are taken, and the standard deviation is less than 0.6, and the gain is kept as low till you get the right amplitude and you do not press on the eye. Again, we need to measure both these eyes in every patient. Like even if you're using one eye is pseudophakic, you can keep it in, check the axial length and the anterior chamber depth, and see whether there's no asymmetry between these two eyes. Now, asymmetry could also mean that the eye which has significant asymmetry could be also an amblyopic eye. And asymmetry in your measurements could also mean that you need to be careful in how you're doing your measurements, because an axial length difference of more than 0.3, a K value of more than 1 diopter between two eyes, and an IOL power of more than 1 diopter, definitely you need to go and validate whether your measurements have been appropriate. Again, when you're doing a biometry, you need to accurately look at all the parameters, especially even the K between the two eyes. And you can see that the right eye was flatter than the left eye. And if it had got unnoticed, it would have been quite a bizarre step. And when we went and looked into the history, the patient said that he had got a laser vision correction done 30 years back. And then we needed to go on to using the other formulas for the refractive surgery, and the IOL power calculation had to be modified. It also becomes very critical that you do have a look at the quality of the raw data. Now, this was again a patient who showed a +2 diopter in his left eye and a 0.5 diopter astigmatism in the right eye. But when we did a complete evaluation, we realized that the patient has significant dry eyes. And after you go ahead and treat this dry eyes, lo behold, that astigmatism was just 0.2 in both these eyes, and the IOL power calculation was so totally different. And if this factor had not been looked into, you would have been in trouble with an absolute IOL refractive surprise. You need to do something as basic as tell your technician to look at the Myers on the Placido imaging, and look at these points on the optical biometer, whether it has a fishtail appearance or where some of those spots are missing. You need to advise your technician to look at that traffic signal kind of thing where the red, green, and yellow tells you whether you're on the right track. You need to ensure that your standard deviation should be less than 2 or should be less than 30 microns. And you need to see that the signal noise ratio should be more than 2. And these are things which, if the technician is aware, the calculations would be definitely accurate. We also need to look at if the astigmatism is more than 3.5 diopters, are we looking at some kind of a keratoconus or a pellucid marginal degeneration? Is it an eye with a large axial length where we would absolutely mandate that we use, or small eye, we look at the 4th generation formulas and do not miss out anything. When you're doing a keratometry, you have definitely different modalities to go by, but what we understand that, as you can look at this table, that each of them are measuring at different diameters. 3.2, IOL master has 3 rings, the lens star has 2 rings. So what we all understand is how close to the center you get, and that would be most accurate. But again, it at least makes sense that you check your keratometry on 2 modalities, because sometimes if you have missed a dry eye status and there's a difference in the value between the axis and the magnitude between 2 eyes, then you need to go and remeasure. But if you have optical IOL master 700, what you need to understand is the advantage of the total keratometry, which is available here, wherein it measures 18 points on the anterior cornea, uses a swept sort OCT and the B scan to measure the anterior cornea and interpolate the information from the posterior cornea and get the total K value. And it is now able to give you a Barrett TK universal and a Barrett TK toric. But when you're looking at the other formulas, you need to understand that they have used their own mathematical model to measure the posterior corneal astigmatism. And if over and above you add the TK value to this, you could be overcorrecting the astigmatism. Now, this is another important decision tree table. Like if the patient has a normal cornea, then there is no challenge. You go ahead and do a keratometry, and then you feed in the data and then use the right formula and get your calculations. But when you do a keratometry, and as I said, the standard deviation is less than greater than 0.2 or more than 30 microns, then you need to find out whether there is something wrong, whether there's just a dry eye which you're looking at. Then you go ahead and treat your dry eye, and then go ahead and do your topography and tomography and go on to the IOL power calculations. But if there is no dry eye, but there is an irregularity of the surface, then you need to address whether it's a KC or a PMD, and then go ahead and do your calculations. Then comes Pearl 4, that is the choice of formulae. Now, today we have the access use the latest generation formulas, or at least you have access on the website. So what advantage it all is because these are like it has 5 variables, the Barrett Universal 2. So these are values which is actually allowing you to better estimate the effective lens position. Essentially, every time, right from the time of geometric optics to now Gaussian optics, and then this newer generation formula, the search has been to ensure that you are bang on in your effective lens position. And with the Barrett's formulae, you are able to get your Universal 2, Barrett Toric, True K, and Barrett RX and True K Toric with the incorporation of your total keratometry. The further advantage of the Barrett's formula is it also takes into account the varying principal planes, like the geometry of the lens, which is varying with the high and the low refractive errors. So basically, it could be, you need to keep in mind that it could be a biconvex lens, a panoconvex lens, or a meniscus lens. And if this change in principal plane is also taken into account by these formulas, then you are closer to getting your ELP and a better target emmetropic error. We did a study of some of these eyes on a 3rd generation formula and the Barrett's universal formula. But what came striking across that we were able to get within plus minus 0.5 with the Barrett universal, with more than 90% of them in long eyes, normal eyes, and short eyes. And it seemed to rather strengthen your conviction that it is the way to go using the 4th generation formula. Then Pearl number 5, you need to know your IOL calculator. We need to know whether the posterior corneal astigmatism, the toricity ratio, and the centroid is being accounted for. We are all familiar that posterior corneal astigmatism in 90% of the case is against the rule and creates a minus lens. And if supposing the anterior cornea is with the rule and the posterior cornea is against the rule, then your total astigmatism is going to be less, and it's going to be vice versa if both the anterior and the posterior cornea are against the rule. Not able to go to the next. Yes, and we also need to look at the simple table without going into the complexity, that we need to know that you can't use an average toricity ratio in all these eyes. Like in an average eye of 22 diopter IOL with an ELP of 5.5, the toricity ratio is 1.4. But if the IOL power is 46 and the ELP is 4, then your toricity is 2.2. And if the IOL power is 10 and the toricity ratio is ELP is 6.5, then the toricity ratio is 3.4. So from 2.2 to 3.4, that is a significant thing which can happen. So we need to definitely have formulas which incorporate the toricity ratio if you want to be a cataract refractive surgeon. We need to understand a little about the centroid SIA, that if you're only going to look at the magnitude of astigmatism, then you are a little off the mark. But if you're looking at the axis and the magnitude, you find in this particular case that it was 0.35 in 20 in one eye and 0.35 in 110 in the other eye. The centroid was 0. So essentially what we've come to understand that with an incision of 2.4 millimeters, the centroid is 0.01. If you look at this again, if you have used an immersion biometer, it gives you all those details, but what you need to add on is the IOL constant or the acoustic constant of using ultrasound. And if that is fed into the AACRS or APACRS.com, the Barrett formula will tell you what should be the IOL power which should be implanted, what is the axis of placement, and what should be the least astigmatism you expect. The pearl number 6 is what is your threshold for toric IOL. Now, this was a patient with 0.797 with the rule astigmatism, and it tells you that it needs to have a non-toric IOL. But if it was 0.88 against the rule astigmatism, it says they're going for a toric IOL. So we need to remember that when you are having an against the rule astigmatism, your threshold for using a toric IOL becomes lower because the anterior and the posterior corneal astigmatism getting added on, you could get to do so. Pearl number 7 is an ideal pre-op examination, and that has been very well validated that we need to look right from the ocular surface to the retina to ensure that you can augur or promise the kind of visual acuity the patient expects. Specular microscopy is absolutely mandated, and if the specular microscopy is defective or less, we need to use viscoat, or you need to inform the patient that there is a possibility of doing a DSEC later. A topography is, of course, again, very important. We need to see whether it's an asymmetric cornea or asymmetric cornea. An asymmetric cornea, you might have to do a topo-guided regularization before you could think of using a premium IOL. You also need to look at the OCT macular, and if there is something sitting there, an epiretinal membrane or something, we need to explain to these patients. We need to do an eye trace, which will tell you about what is the angle alpha in these eyes, what is the total higher order aberrations. Are these patients going to do well in multifocal? And today, with the kind of multifocal IOLs we have, we are able to be more liberal about using angle alpha of more than 0.5. Now, we also need to understand that about angle alpha is the angulation between the optical axis and the pupillary axis. And if the angle alpha is more than 5.5, you would be a little wary of suggesting a premium IOL. But what I want you all to remember, which you already know, that today with the PanOptic, Symphony, and Century, the central optic zone is so much larger. So you could use an angle alpha of more than about 0.82 and still get optimal results of implanting an multifocal in these eyes. Then comes pearl number 8. You need to match the technology. You have had IOLs of different designs which have evolved with different focalities. We are all familiar with that. But today, with the evolution of trifocal, you are able to improve the intermediate vision with the specific foci without compromising on the far and near, without an increase in dysphotopsia. But we also need to measure what is the potential of these lenses. So we need to look at the defocus curve, the modulation transfer function, which tells you on eye trace, and also the point spread function. Like you know how to plot a defocus curve. Like you need to measure the vision for distance, and if that is 0, you could keep adding 0.5 over and over till the patient is able to see. And at the point when the vision becomes defocus is that point that tells you that the range of vision in these eyes. And different intraocular lenses come with different defocus curves. The trifocals have a very large range of defocus, which is why they're able to give you great vision at distance, intermediate, and near. So then you need to implant the right IOL for a right patient. A patient with, you could implant a trifocal today, but there are some who really swear on a extended range of vision lenses, where when they have the facility because of the dysphotopsia being less as they claim, but you could do a mini monovision in these eyes. But if a patient had undergone multifocal in one eye and finds his near vision is not good enough, you could do a Tecnis high-ad bifocal in the other eye and just bail him out. Pearl number 9 is how if you have an access to flags, then that takes you to a different level altogether, that you are able to ensure that you do all the steps of the surgery absolutely, it's not moving, absolutely meticulously. You are able to get your right side rexus and you could center it on the capsular bag, which is the way to go. And then all that you have to do is just bunch up the rexus, and the utter ease with which you are able to fragment the lenses, and with the least phacopower and a cornea flendy procedure and placement of these lenses. I'm not going to the details, which I'm sure all of us are familiar with. Pearl number 10 is a threshold of using a toric IOL becomes very low if you're using a multifocal. Now, this was a patient who had about plus 0.8 and 1 diopter of astigmatism, and I was advised a panoptics and did end up with a small residual, or was promised a laser vision correction after a period once refraction stabilizes. But the next eye he underwent a toric, panoptics toric, and a laser vision correction was later done in the right eye. And finally, the patient was very happy. Again, the Pearl number 11 tells you if you have a very low diopter of astigmatism and if you have a facility of using a femto platform, and now that we can do a pachymetry, a topography, a real-time OCT, you should use these arcuates, and this patient definitely did very well after his surgery. Pearl number 12 is nailing the target axis. Now, you could use a slit lamp, and I believe a slit lamp measure wherein the light goes, horizontal line goes right across the visual pupillary axis, or if you're going to use a ASICO marker, which is good, but there could be a minor error in these eyes. You should mark it appropriately. You should see that the eye is dry and it doesn't get blotchy. You could, of course, you don't have a facility to this. You could use your Mendelssohn's marker and the toric marker and get away with these eyes. You could, when you're doing a toric IOL, after you've done all your, if you have a Varion overlay or a Callisto, after you've done a good surgery, you do a good polish of these eyes. You inject viscoelastic and place your toric IOL into the bag, remove do a bicompartment viscoelastic removal, and then lock in your toric IOL in the alignment as has been shown. Pearl number 13 is realigning it on the rotated toric axis. Now, if your patient is off his axis, and you can take him on the slit lamp and find what is the current alignment of the lenses and mark it, and you could feed it into the astigmaticfix.com. Now, before you go on to the surgery, you need to know that the spherical equivalent of the lens of these eyes should be 0. So if the spherical equivalent is not 0, then there is no way rotation is going to help you. You need to probably go ahead and do a bioptics or do an IOL exchange in these eyes. And in this particular case, you can see that the spherical equivalent is going to be good. And if you have access to the Barrett RX formulae, then it would even tell you that would the patient do well by rotating these lenses, or would the patient do well with a piggyback IOL implantation, or would the patient do well with an IOL exchange. So, however, this patient needed a rotation, and you can see he did optimally well. Now, how long would you wait before you go back and realign these lenses? Yes, early enough, but you could at least wait for a couple of weeks for the capsular bag to contract and then go in and do your rotation. Pearl number 14 is to follow up and follow through. So these are the 5 C's, like you need to see whether the ocular surface was good, the cornea was good. If there's residual error, you need to address the residual error, do a bioptics or piggyback or an IOL exchange, because you cannot have these patients unhappy. And if there are capsular bag opacities, wait for a period of 3 months. Ensure that you're not going to do an IOL exchange before you treat the capsule and do a YAG laser. And of course, sometimes the IOL is decentered and all you need is to just slip in a CTR and the IOL gets centered. So sometimes you would be a great surgeon, but you would have chosen the wrong patient. So what you need to understand or explain to these patients, yes, these eye surgeries is good, but there is a complexity about it, and the intraocular lenses do come in a certain size. So they should be informed that laser vision correction could be just part of the plan. And Pearl 15, which is absolute top concern, is let us understand that we are educating our patients and we are not selling our technology onto these patients. I think refractive cataract surgery is a beautiful science. And if all of us understand that we are all ready for it, I think that would definitely take our practice to a different level. And I believe that if you have a conceptualized approach in your mind, open to all the challenges, you are where you should be. Thank you.
Thank you very much, Dr. Chitra. I now invite Dr. Minu Mathan to come up with the algorithm that is devised based on the panel discussions.
Okay, thank you, Dr. Matthew. Can you see my screen?
Yes, please.
Yeah. So we'll because everything was detailed so much in great attention to detail. I'll just outline the major points which are very crucial for management of the three situations which we saw. The first was posterior capsule rupture. So this was mentioned very clearly that when you preoperative itself try to suspect a PCR or possibility of PCR by getting the other eye status and also the previous procedures and the history properly. And on the table, early detection of PCR like the sudden red reflex or a clear area which you see there, and difficulty in rotation or followability and the impaling difficulty, and the AC flutter and the sudden deepening, pupillary snap and the lens tilting or the nucleus dropping. These signs at the earliest if we diagnose, the better we will get an outcome. And in between, when you feel that the nucleus doesn't have enough support, do not hesitate to use an IOL scaffold, though it needs a little bit more of a technical expertise. IOL scaffold is a good technique to prevent the loss of nucleus pieces into the vitreous cavity. And if you have lost pieces or even epinucleus, do not try to go into the vitreous cavity and aspirate. So that is the greatest sin we can do to the retina while managing a posterior capsule rupture. And vitrectomy, we should all be ready with a vitrectomy in all our ORs with a very high cutting rate, which is maximum possible in our machine which we have, and slightly lower vacuum but lower flow rate. And in higher end machines, if you can, we can change over to IA cut and cut IA mode. Otherwise, we can do a dry aspiration also after clearing the anterior chamber of the vitreous, and we should use triamcinolone acetonide to confirm the absence of vitreous at the end of the procedure. Though it may look very, very clean, we will be surprised to see that there will be a lot of vitreous strands which may be appearing in the anterior chamber or into the paracentesis when you put triamcinolone acetonide. So, posterior capsule dehiscence, if it is a small central one, if it is looking good, you don't have to you don't have to convert it into a rexus. Posterior capsule rexus is very, very small, and you can easily place the lens into the capsular bag. Otherwise, convert it into a posterior capsule rexus if possible. And if the rexus is, and place the IOL into the capsular bag. And if it is a very large capsular PC tear, and if you have a rexus margin intact, then you can place a 3-piece IOL into the sulcus and then optic capture it if the rexus is central and small enough. Sometimes if the rexus is larger than 5.5 or 6 millimeters, you may not be able to capture it very well. And if the rexus margin is also run off, then we will have to consider secondary IOLs or IOL fixated IOLs, which we will come to. And in small pupils, as we discussed in great detail, try to assess preoperatively which will dilate, which will not dilate. Use the maximum medical possibilities of mydriatics, and intraoperatively also try to viscodilate. And if they are dilating adequately, for your expertise, which was mentioned very clearly, that your experience and the possible pupil size you can deal without dilating devices is inversely proportional. And even in experienced hands now, as we heard from most of the panelists, the use of hooks is increasing, or the dilating device is increasing, so that the safety part is taken care of. And if not adequately dilating with mydriatics or visco, identify whether there is posterior sanicae, release them, stress them, and try using pharmacological devices once more, using phenocaine or diluted adrenaline. And if it is adequately dilating, proceed with surgery. And if not adequately dilating, use devices of your choice which you are comfortable with. and in dilatation is not adequate and there is no synechia. And if you feel that it is not good enough for you, large enough for you to do surgery, please use devices. And during surgery, if you are proceeding with the mid-dilated pupil, if you feel that the pupil is coming down at any point of time and it is becoming unmanageable, please use iris hooks or rings. But then both be careful not to engage the rhexis margin. Put viscoelastic underneath the iris and then lift up the iris and then engage the first hook, and after that we can follow the elevated iris and complete the placement of hooks. And in IFIS, it can come down at any point of time. If it is well dilated, start off without using anything, but then if it is mid dilated, it will most probably come down, and in the beginning itself we can place iris hooks, and the rings may not be that very useful to avoid iris prolapse during the procedure. And in a secondary IOLs, in posterior capsule, the presence of posterior capsule is very important, and if there is posterior capsule is intact and the zonules are also intact, we may find such cases. People misdiagnose things and think that there is no capsule and leave people aphakic. And in such a case, place the IOL into the capsular bag. And if you feel that the zonules are dehiscent but the posterior capsule is intact, then the IOL can go into the bag along with the capsular bag stabilizing devices like these rings or segments, which may or may not require suturing according to the amount of zonular dehiscence and the centration achieved during the procedure. If it is more than 6 clock hours, it is better to always fix the bag and the ring to the sclera. And if the posterior capsule is ruptured, and look for the rhexis margin, and if the rhexis margin intact, we saw before, 3-piece IOL, and if it is runoff, do secondary IOL. And secondary IOL consideration is again the systemic problems of the patient. If they cannot lie down for a long time, and if you want a quick procedure to do, if the specular is good and angles are fine, and as it has been discussed very thoroughly, AC IOLs are not out. AC IOL can be used, but the sizing is very important. Measure the specular, measure the angles, see the angles, and look for the sizing, and if they are all appropriate, and after a good vitrectomy, we can place an AC IOL in a relatively older patient. And if the iris is normal and your technique is fine, always use you can always use iris claw lenses, which is clawed retroiris on the posterior surface of the iris. And patients are low morbidity, the comorbidities are not there. You can lie down for a long time with a good endothelium and angle and iris tissues. We can go in for scleral fixation, more cumbersome procedure, takes learning curve is there. We can use sutured IOLs. Now we are coming away from Prolene sutures. If at all you're using, please use only 9-0 Prolene. They are also breakable on a long run, 10 years, 12 years. And go for Gore-Tex sutures, 7-0 Gore-Tex, which is available right now, slightly costlier, but then those are permanent sutures. And we can always do glued, non-glued, sutureless intrascleral haptic fixation, and even the Yamane technique after getting used to the procedure in a few cases where you will have a learning curve in such cases. And thank you very much. And with this, we come to the end of the session on cataract, and also we come to the end of the whole CME. And I take this opportunity to thank all the external speakers. And so before that, before ending our session, I would like Dr. Partha Bishwas to give a few summing up comments on this session. Please, sir.
Thank you, Minu, and thank you, Matthew, and Chaithanya Eye Hospital for this wonderful program. The layout of this program is mind-boggling. Keynote speakers for 15 minutes. Usually after a keynote, people are bored. But the keynotes were so excellent, Chitra's and Ron's, so excellent, that it was a real music to the ears. But the crux of this program was the case scenarios that you discussed, the panelists involved, the panelists informed in advance that this is what you are going to discuss. So everything chock-a-block, everything well planned and well executed. And the icing on the cake was the algorithms. Fantastic. I have no words, and I'm going to emulate this program into our AIOC 2022. Thank you so much.
Yes, Dr. Chitra, you're brimming to tell something.
No. I agree with all he said. And I said, look at the smart guy he's going to incorporate in his program.
Actually, the credit goes to Dr. Unni. Actually, he devised this and he told we'll do it like this time. So actually, he is the one who, this is his project.
But you all did it so well. There was so much of professionalism at every step, and the amount of information transfer, everything was wonderful.
Really good.
Really
Really
nice.
good.
We really
Everybody-
enjoyed these 2 hours.
We all learned immensely, I'm sure.
Thank you.
Dr. Ramesh, thank you very much for chipping in and very, very precise and crisp opinions and inputs. Thank you so much.
Thank you.
Thanks, Mino. Thanks, Matthew.
Thank you very much. Thank you, everybody.
Really,
I've been asked to conclude the CME program also, to thank all the panelists, all the keynote title speakers, and all the delegates who have attended. We have large attendance in Facebook and YouTube, and in Zoom we have our faculty and our Chaithanya group of people joining. The next time also we plan to get better in and find out newer ways to present our CME, which is our annual program. Thank you, Matthew, for co-moderating, and all the Chaithanya faculty who work behind this. They are not in front of the camera, but they have all worked many hours trying to coordinate with the IT people. We have not taken external help. It was all done with the IT department inside our hospital itself, and they were also working many long hours actually. So thanks to all of them, and also to conclude, Sun Pharma was a good support for our CME, and thank you all very much for this great session.
So next year's CME, a physical CME, you have to promise.
That is, we are actually having a physical CME, hybrid physical in November, the Retina Imaging Congress. That the faculty is going to be live. Faculty is going to be in person.
Kerala has still high numbers. They can't.
We may be shifting. We may be shifting like IPL shifted to Dubai. We will shift to a safer place. Actually, that is what we are planning.
Kolkata. Why not Kolkata?
we will choose. We'll choose a place.
Thank you very much.
Thank you. Thank you.
Thank you all. Bye.